or the age related, not with the BMI or gender. Actually, if you think, it should be, for the surgeon, it should be difficult in a high BMI to intraoperatively to decide when he may go wrong. And lengthening is of course more common than the shortening, that's true. Now we have the next two papers to be presented by Dr. Mohammed Mustafa. Please come in.
Assalamu alaikum. My name is Dr. Mustafa, and I'll be presenting my article on is tranexamic acid safe in hip hemiarthroplasty. It's a review. I belong to Liaquat National Hospital, Karachi. So, as we all know that hip fractures are very common injuries which are primarily managed using hemiarthroplasty, total arthroplasty, or internal fixation. And regardless of the surgical techniques that we use, there are still always complications that are always on a rise. And primarily the most common being anemia, with a prevalence ranging between 45 to 85%. So obviously blood loss, it impairs functional rehabilitation of the patient. And obviously it is associated with multiple factors like increased hospital stay, delirious episodes, etc. And even when you are thinking about transfusing these patients, there is always negative implications associated with it. For instance, increased risk of anaphylactic reactions, lung injuries, bloodborne, viral transmission, etc. And eventually, all of these factors will result in increased hospital stay, increased load of morbidities associated with it, and obviously increased hospital costs. So it is important to optimize this blood loss in hip arthroplasty surgeries or any hip fracture surgeries. So transamine has already been studied in total hip arthroplasty surgeries for non-fracture patients, and it has been considered safe. However, for hemiarthroplasty surgeries, it has not been studied as widely. And knowing that hemiarthroplasty is a lesser complex procedure and lesser blood loss during the surgery, but the fracture itself results in increased blood loss. So some studies are there which have suggested that transamine is effective and safe in the form of causing no further increase in DVT or pulmonary embolism. So we carried out this literature review in the Department of Orthopedics, Liaquat National Hospital, in order to find out the efficacy and safety profile of transamine. And we included studies carried out until December 2022 using multiple databases like PubMed, Embase, Cochrane, and studied hip fractures in transamine and hip fracture surgeries. So what was the inclusion criteria? They were adult patients who were undergoing hip hemiarthroplasty surgeries for hip fractures. There will always be a comparison group with perioperative transamine with no transamine. And studies which will be mentioning our outcomes of interest as I'll go on further. The exclusion criteria will all exclude case reports, and if there was no comparison between the two groups, and studies that did not mention the outcomes. So what was the primary outcome? Primary outcome was the rate of transfusion. Secondarily, we were looking for the post-operative HB, hospital stay length, rate of DVT, and 30-day mortality. So initially, we looked into 2,364 studies, and after removing duplicates and studies which we did not find or were not matching our inclusion criteria, we eventually selected 17 studies. 17 studies which were studying 4,132 patients who received tranexamic acid with a mean HB ranging between 7.5 and 12.5. So these are the characteristics of some of the studies that we studied. And as you can see that primarily we have intravenous being used as a mode of transamine primarily, and dosing ranging between 1 and 3 grams. and mean age of the patients being 55 and 85 years. So when we looked into the outcomes that we were looking for, so initially reduction in transfusion rate, we found that transaminic acid group is much more effective in reducing transfusion rate as compared to the control groups. And when comparison was made between intravenous and topical, it was found that intravenous mode is much more potent than the topical one. Post-operative HB was found to be more in patients receiving transamine. Length of hospital stay overall was a mean of 1 day lesser in patients receiving transamine. There was no significant association between occurrence of DVT and pulmonary embolism in patients receiving transamine versus those who were not receiving them. And 30-day mortality was decreased in patients receiving tranexamic acid. So overall, the review, it comprises of 47,643 patients who had hip hemiarthroplasty for a hip fracture. And our review shows that perioperative transamine is efficient and a safe drug with additional benefits of significant reduction in transfusion rate. However, no significant differences were present in the occurrence of DVT and pulmonary embolism. In the past, transamine has been shown to be an effective method in total hip arthroplasty, as I mentioned, and now has become the standard of care, as we all know. However, increased research has now been started on patients with a hip fracture and transamine in all these type of surgeries like hemiarthroplasties, dynamic hip screw, or cephalomedullary nailing. So when we talk about these studies, the adverse outcomes have still not been quite published. In our studies, in our review, we came across 12 studies which were investigating DVT and studying pulmonary embolism. However, no significant difference could be appreciated in either of the two groups in any of the studies. Again, this is similar to previous studies on total hip arthroplasty, where no significant differences could again be appreciated in thromboembolic events in patients receiving transamine versus not receiving them. So we also studied a subgroup of patients between those receiving intravenous to those receiving the topical drugs, and we found that intravenous is much more potent as compared to the topical form. And in all of these studies, the topical form was given post-implantation, soon after the implantation was done. And again, some articles also studied 1 dose versus 2 doses of transamine when compared to the oral control group, and it was found that a reduction rate in transfusion was much more in those receiving the 2-dose group. So what were the limitations? So variable studies were included with randomized controlled trials and retrospective cohort studies. And secondly, the dosage and timing of the administration of the IV and the topical form, it was different, which sometimes makes it difficult to compare. And again, more research needs to be carried out, particularly in the form of randomized controlled trials and systematic reviews and meta-analysis. So in conclusion, administering transamine for hip hemiarthroplasty surgeries for fracture surgeries is not only efficient, but it is also safe, as it reduces the rate of transfusion and it improves post-operative hemoglobin, and without any risk of increasing adverse outcomes like DVT and pulmonary embolism. Thank you. So we do use transamine, just intravenous dose of transamine 1 gram primarily, just before we give the incision. In both total hip replacements for without fractures and those with fractures as well. Yeah.
For the fracture fixation, do you use transamine?
Other than hemiarthroplasties, we haven't used it quite typically.
Yeah.
But for arthroplasties and hemiarthroplasties, we are using them.
Anybody else here uses transamine regularly in the hip? People use it. Okay. We follow the rapid recovery program as we use in England. So we give intravenous intraoperatively. not pre-op. And sometimes it depends because we give local cocktail in the capsule, which includes like bupivacaine along with some Strorlec or like Toradol, and with some tranexamin for local
For local
infiltration as well.
infiltration. Okay.
So we give 2 doses usually
Okay.
in the arthroplasty, in the full total hip. But in same I do in the knee arthroplasty as well.
So what I studied was that the 3 doses post-operatively, it is much more better
Yeah.
as compared to a single dose of transamine as well.
Okay.
So that's quite important as well.
How often 3 doses?
8 hours apart.
8 hours. Okay. Anyone else has any experience of transamine giving tranexamic acid to control the bleeding?
We don't use it in hips in total or hemi otherwise, but we use it in knees definitely. And we give the transamine once we release the tourniquet, because at that point is the time we think that the bleeding is going to be more. So that is where when we want the bleeding to be less. So just before releasing the tourniquet, 5 minutes before, we tell the patient that we are, the anesthetist, that we are closing and it is about going to be the time. So that helps reduce the bleeding, not the bigger bleeders which are going to be there, which you need to cauterize in any case. No, we give I, not locally. We don't use it locally. Once we have come, yes, everything is done. Just before the close.
Do you have another
No.
paper?
All right. Thank you so much.
Fine. Thank you. Thank you very much, everyone. We had a very interesting session. Now I would like to Dr. Professor Intikhab Tawfiq, Professor Hashmi Saab, Masood Umar, the Umar Saab is here. Anyone has any comments regarding the session or any questions, or they want to share any of their thought on, including Professor Zahid Askar Saab. His initial talk was amazing regarding the approaches. So we would like to welcome anyone who has any comment to give or share the experience from LNH, AKU, or even Professor Amin Chunai Saab is here if they have any regarding the arthroplasty to comment on the experience or whatever the talks we were shared. The only thing I wanted to ask Professor Hashmi Saab is regarding his most of the hips you showed, you did, I think we briefly discussed this, you used the cable and for the abductor mechanism to restore. Is that your common practice for the conversion on failed hips to convert? And what is your post-op regime for them immediately after the surgery?
Thank you very much for your question. You see, most of the failed hip surgery in Aston Moore, greater trochanter is still intact, until unless you have done osteotomy or incidentally the fracture had happened. In an Aston Moore or a bipolar hemiarthroplasty which are failed, you don't need to do anything with the hip abductor mechanism and with the greater trochanter. But especially in a subtrochanteric fracture, comminuted intertrochanteric fracture, many times you encounter a non-union. The fragments, they are displaced. Lesser trochanter is somewhere else, greater trochanter is somewhere else. So you need to do subperiosteal dissection, lift that hip abductor mechanism, bring it down to its original native position. And I try to restore the hip abductor mechanism as much as possible. It may not be 100%, but you pull it down and put the cable. Cerclage wires, they don't work actually. They break very easily. And over a period of next few weeks, you will see the broken cerclage wire. So the cable is one which actually works very well. But if there was some osteotomy or there was a lower down, you are thinking that the bone is really osteoporotic or there is another fracture in the subtrochanteric region, then I will put a trochanteric plate. Otherwise, cable alone would be sufficient in these cases. Second question regarding your weight bearing, I usually start early weight bearing and weight bearing as tolerated, and I do not actually hesitate to put those patients on early weight bearing. and slowly and gradually they increase the weight bearing according to their comfortable pain tolerance. And once their hip mechanism becomes a little stronger, after 2 to 3 months, then I allow them to stand on one leg and on the opposite leg, standing, holding the walking frame or putting hand around the table or the wall. That's my usually protocol, and it helps a lot.
Thank you very much. Thanks. Yeah.
I think I must appreciate it's a very good number you have in 10 years, about 50 cases of the dysplastic CDHS. But one thing more which I, being an acetabular surgeon, I do is that I use a head as a structural graft. I prepare the base, the site, and then I put a plate on it to sort of reinforce it with after a screw, and that gives you more confidence and safety element in terms of safety element that I may sort of get a better result. So this is, but my numbers are not that much with regard to the congenital hip dislocations, but excellent work. I must appreciate.
Thank you. I mean, you see, my indication to put a plate, I have 6 cases of a pelvic diastasis. When there is interior and posterior column, they were severed actually. And in a Revian hip surgery, there are a few cases when somebody has done actually, doing even a hip surgery, they have ruptured interior and posterior columns fracture. So in those cases, actually, I try to put a plate first on the posterior column, couple of screws in the ischial tuberosity, 3 screws superiorly in the posterior superior wall, and then put the acetabulum. But putting a femoral head as a graft and the supralateral superior margin, it is now almost a trademark for me. Everybody knows that he is going to actually shave the head, put a tricortical piece, put with a 1 or 2 screw, and then with the tri-flange cup, that actually flanges of a cup, actually they are placed over that graft, and that helps to consolidate that.
Thank you very much. I think we will close the session now because the next arthroplasty session is about to start. Thank you very much everyone for coming.
Thank you. Now we move towards the second session. My name is Dr. Khalid Kareem, and I invite my colleague, moderator, Dr. Noman, to kindly come. As we are already late with the session, so we start the next session without any delay, and I request the Professor Parvez Mahmood Hashmi to kindly come and give the talk on the reverse shoulder arthroplasty in proximal humerus fracture.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Can I have the first slide, please? If you look at, sorry, this is, I'm sorry. If you look at the incidence of a proximal humeral fractures, it is on an upward trend because of an aging populations. And my talk will confine to what are the different types of a proximal humeral fracture. Especially one should recognize what are the stable and what are the unstable fractures. And what are the various treatment modalities for those especially unstable fracture. Now historically, if you see, when we were resident, we were taught that we need to reconstruct everything, either with or without bone grafting, and try to restore the anatomy and shoulder abductor mechanism, that is a rotator cuff. So that has to be restored. That was the conventional teaching which we learned as a resident. And in the 35 years, you see the initial mode of treatment was a fixation, either it's a stable or unstable fracture. Then the people, they realize that fixation of a proximal humeral fracture, it fails in many cases, and percentage of failure and reoperation is a pretty high. So considering that, they move towards a second mode of fixation or second mode of a treatment, that was hemiarthroplasty. But hemiarthroplasty had its own complications and failure rate, which was pretty high. And then people, they moved from hemiarthroplasty towards a reverse shoulder arthroplasty. So my talk would be basically focused that what are the indications for fixation, where we will use a hemiarthroplasty, and hemiarthroplasty should not be used as a technique of doing the procedure, But if it is indicated, the surgeon is experienced and he is able to fix those lesser and greater tuberosity in a proper anatomical position. If they have a proper hemiarthroplasty implant, one should try only, and especially if the patient is young. In older age group, usually this hemiarthroplasty fails miserably. Now, proximal humeral fracture, they represent between, you see, 4 to 10% of all the long bone fractures, and they occur more frequently in elderly people. Incidence is expected to increase considerably over the next coming years, and especially acute 3 and 4 part fracture, it can be challenging to treat, particularly if they involve the humeral head or tuberosities they are involved and there is accumulation or there is a head splitting fracture associated with a dislocation, anterior or posterior dislocation. They are very difficult to treat. So the old people, they can become dependent or disabled due to functional deficit if we have actually treated inadequately those patients with our fixation techniques, and their misery increases instead of improving. Now, most of us, they use a Nair classification. As a student, we were taught that Nair classification is a better classification which tells us about the anatomy of a proximal humeral region, and here you will see what is type 1 to type 4 fractures, and especially we categorize into depending upon the proximal part, head, greater tuberosity, lesser tuberosity, and the shaft, what is the degree of displacement, which will require fixation, and which has a high chance of avascular necrosis. Now, then the AO people, they jumped in and they have their own comprehensive classification. Most of the residents, they actually try to memorize this classification. But the Hurtle was the one who actually came up with this concept of a 4-segment, proximal 4-segment. And that proximal 4-segment, it starts with a head, greater tuberosity, lesser tuberosity, and the shaft. And that is called HGLS classification. In easy to remember, HGLS means H is for head, G is for greater tuberosity, L is for lesser tuberosity, and S is for the shaft. Now, just like you see those toys people, the kids, they play with the Lego sort of a concept. Now, you can come up with any sort of a combination of various fractures. Now, if here you see it's a type 1, in the proximal segment, these 3 components, they are joined together, while the shaft is a separate. So it's a type 1. In the type 2, there is you can see here, the head is separated, but the remaining greater, lesser tuberosity, they are intact. So here is a treatment which is a controversial. The head is a separate, it can be split, it can be dislocated, depending upon the functional class of patient. It's a young patient, old patient with the quality of bone, what treatment you will offer to that patient. So this is very, very important. So similarly, these are the 12 classification. Further, the 2 more classification, they have been added with the dislocation and head split concept. But these one which I have encircled actually, here you see the head is a separate from 9, 10, 11, 12, and the second. So in this Hurtle classification, this is important, especially when you look at those X-rays, you not only get an X-ray, to do a CT scan with a 3D reconstruction, and then look at the patient as a whole and try to determine this thing I have just actually explained to you in the previous slide. So the 2-part and 3-part fractures, they required osteosynthesis, a fixation with the philos, plus minus bone grafting, depending upon the functional class of patient, quality of bone, and the degree of displacement. But 2-part, 3-part fracture in which the head is a separate segment, and it has lost blood supply, fixation depends upon the age, functional class, and the quality of bone. In an older age group, many people, they will go to a replacement. But there would be certain people who can say that we can do a better fixation, still with a bone grafting, and we can get an early result. So in a younger patient, one thought process is that younger patient, they can bear the burden of another surgery. So if the patient has come early, quality of bone is good, still head is a separate, you try to fix it, restore the anatomy, and wait for another couple of decades till the head goes into avascular necrosis. And then you can do a replacement or some other salvage procedure. So in an older age group, when the bone is an osteoporotic, and you know that this patient is an old age group, osteoporotic bone, he can bear the burden of only 1 operation, and considering that the avascularity of head, you will offer him a treatment which will give him a permanent solution for the rest of his life. And that would be a replacement. So identification of a fracture configuration is very, very important to analyze its fracture geometry, degree of displacement. Associated injury should also be recognized when you're offering a treatment, especially neurovascular injuries. Many times you see injury to the axillary nerve or even to the brachial plexus also. So that should be identified. And then, depending upon your assessment, you will decide either it is a fixable or not fixable. If it is a fixable, what technique you are going to use? Are you going to use bone graft? And your reconstruction, it has to be inadequate. Because proximal humeral fracture over the period of last almost 10 to 15 years, which I see most of the fracture, they are not fixed properly. Just like hip fracture, the first thing is you need to restore neck and shaft angle, which is not being done. And head is usually an varus. When the head is an varus, greater tuberosity impinges to the margin of acromia. The first thing is restoration of neck shaft angle. Second is restoration of anatomy of those tuberosities, both greater and the lesser tuberosity in an anatomical position. And third is your construct should be stable enough that you can start early range of motion. And the fourth component, in older age group, many times you come across an impingement syndrome, partial rotator cuff tear, you must address at that particular surgery. If you leave it, you may not get an optimum result in those cases. So if you look at this X-ray, 4 weeks old fracture, and you can see here, the head is tilted into a varus deformity, it is impacted, and if you try to bring the head back to its anatomical position, there would be a void of bone. So which you need to reconstruct. Either you take a piece of fibula or a triangular corticocancellous iliac crest bone graft and try to reconstruct it. So that's how it was done. And one more thing for junior people, whenever I do a fillas or reconstruction, I always put a suture in the rotator cuff, supraspinatus suture, especially one suture in the supraspinatus and infraspinatus, so that you can pull the head in a backward direction. The other thing, to restore the neck shaft angle is, there are various techniques which I use. Many times I put a small spiked instrument here, that would be Hohmann detector, or maybe I can put a thick K-wire 25 or 30 kg here and just use a joystick and try to bring the head in a valgus deformity. If you cannot do that and head is tilted into varus, it will further turn into a varus over the coming weeks. And this is one of the major cause of a failure and restricted range of motion. So that's very, very important if you're doing an osteosynthesis with a fillas plate fixation. So what are the guidelines? Guidelines, they are mostly depends upon the experience of a surgeons, and they develop guideline depending upon their experience and population-based practice. So in what cases you will do replacement, in which cases you will do osteosynthesis. These are the very, very important questions which we are still actually finding. Now, proximal humeral fracture fixation with the fillas, with or without bone grafting, it has come up to a stage where people have encountered a lot of complications. And those complications, they are tremendous. Especially they go into a non-union. There may be these failures, they happen due to multiple reasons. Inadequate fixation, osteoporotic bone, lack of bone graft, any structural support, inadequate restoration of neck shaft angle. And these complications, they ultimately increase the misery of patient, and then the surgeon, they thought that there is a high chance of a reoperation, we should actually go do something else. So Alberto Nokia, he actually did a study, and he noted that there were 31 complications in 20 patients out of 56. Like inadequate reduction in 8 cases, subacromial impingement in 7 cases, inadequate fixation, pseudoarthrosis, adhesive capsulitis, avascular necrosis, loss of reduction to varus, and the infection. So once people, they started to encounter a lot of these complications, they changed their practice from this pattern to another. Another study in which, this was from New York, Venkat Korai and his associate actually did meta-analysis based on a PRISMA guidelines in 2013 and 2015. And initially, you see the number of studies which were included, they were actually more than 51,000.
But after exclusion, fulfilling their inclusion and exclusion criteria, only 57 articles were left with 422 patients, and based on their level of evidence. So they also noted that there are a lot of actually complications, that intra-articular screw penetration, varus collapse, subacromial impingement, avascular necrosis, adhesive capsulitis, non-union, deep infection, reoperation occurred in many cases. You look at the reoperation rate is almost 14%, and collapse at the fracture site. So that contributed to the surgeon to think that we need to change our gears from a fixation towards a replacement. And what kind of replacement at that time was hemiarthroplasty. So with hemiarthroplasty, those people, they thought that we would be able to restore early range of motion and get a good function. But it was not, again, short of any complication and side effects. So you see, in a proximal humeral fracture fixation, 1 out of 9 cases had required reoperation in an unstable cuminated fracture. And these patients, they required a salvage procedure. And in a salvage procedure, as I was telling you, they thought the hemiarthroplasty will solve their problem. But hemiarthroplasty depends upon the two most important things: anatomical reduction and restoration of both tuberosities and restoration of rotator cuff mechanism. If you are unable to restore rotator cuff mechanism, if these tuberosities go into non-union, then your shoulder abductor mechanism, rotator cuff would be lost, and this humeral head, it will move in an upward direction. So there are certain guidelines to do a proper hemiarthroplasty, and you need a special kind of an implant. But as I told you, the success depends upon a proper retroversion. If there's a less retroversion, it will lead to an instability. More retroversion, it will lead to, hinders the greater tuberosity healing. And another thing is the overstuffing because of an improper size of a humeral head. And then cemented versus non-cemented, and tension of a rotator cuff is another important factor. Because if you do too much tightening, those greater and lesser tuberosity, they will slide lower down, and your rotator cuff will fail much earlier. So these are the complications which they noted with this hemiarthroplasty. And hemiarthroplasty for specifically needs a special design, special size of femoral component. It should have some space and place for the placement of a greater tuberosity. It should not actually overstuff your glenoid component, and stem should be in such a way that it can have a proximal humeral fit in that position. And in spite of that good design, people, they encountered a lot of complications. So the problem still actually persisted, that it was still an unstable construct. There were bulky prostheses and poor tuberosity fixation, malunion, or the resorption of tuberosities. So malposition of prosthesis, if it is too proud, people, they have said in 50% of the cases, too low in 29% of the cases, and excessive retroversion. These are the complications they were noted. And then there was a migration of greater tuberosity. They failed to unite, and then they migrated in a subacromial space, which they caused an impingement. So, and this migration, posterior, superior, and posterolateral, it went. This was a study done by a French group, and they found that hemiarthroplasty is not suitable implant for these. So looking at the non-union rate or complication related to the tuberosities, they were 49% of tuberosity reduction, they were actually failed. They were either average or poor. So the differences, they were noted on the x-rays and different prostheses. They looked at it, and they thought that hemiarthroplasty is not actually suitable for these patients who has an unstable fracture. So the poor results, they were associated with the advanced patient age, implant malpositioning, increasing degree of tuberosity displacement, persistent neurological deficit, postoperative complication, and they thought that they should change from a hemiarthroplasty to another implant. So these were other few complications which were noted with the hemiarthroplasty, and then they switched to a stable construct. So I say that this is an evolution. Initially, we thought that the reconstruction would be an answer, followed by hemiarthroplasty, and now people, they have switched to a reverse shoulder arthroplasty. We know that principle of reverse shoulder arthroplasty is based on different principle. Here you do not need a functional rotator cuff, especially the supraspinatus tendon. And initially it was designed to treat an osteoarthritis, especially associated with rotator cuff arthropathy. But as the time passed, they come up with a better design, and they thought that it can be used for unstable humeral fracture also. And now they are also using for other failed proximal humeral fracture, tumor surgery, for revision surgery, and neglected trauma also. Reverse shoulder arthroplasty, it provides a treatment option that is less dependent on the tuberosity healing, because here the principle is you don't need a competent rotator cuff, especially supraspinatus, and even many surgeons in which the rotator cuff is intact, once they have done a reverse shoulder, they will just sever the rotator cuff, especially supraspinatus tendon, after putting a reverse shoulder implant. And this is especially true with French group. Mostly they do this thing, apart from doing biceps tenodesis. So the function of non-anatomic arthroplasty is to provide semi-constrained fixed fulcrum to allow the deltoid muscle, which is little elongated and stretched, to function without an intact rotator cuff. And at the same time, you medialize glenohumeral center of rotation, lengthening the arm to improve the movement arm of a deltoid. So nowadays, reverse shoulder arthroplasty is preferred by most of the shoulder surgeons for an unstable humeral fractures. So indication for reverse shoulder arthroplasty, they are fractures, especially type 3 and type 4 part humeral fracture, revision surgery, and here the implant design, they are relatively different as compared to for a conventional reverse shoulder arthroplasty, because this stamp has a place for attachment of a greater and lesser tuberosity, because you need a competent subscapularis and infraspinatus and the teres minor to have an internal external rotation. Supraspinatus function is not required in reverse shoulder arthroplasty. So nowadays, modular implants, they are available where you will have a base plate, and that base plate can have, once it is fixed, it's a cementless implant with the screws and with the pegs. Now on this base plate, you can put actually glenoid component polyethylene, or you can put a glenosphere. So if you have done a primary shoulder, in this case, you can put actually just glenoid cavity concave surface, and on this side femoral stem and the femoral head can be put. But if that fails because of a rotator cuff incompetence, one can go in and just change it. The stem will remain inside, base plate will remain there. Here one can put a glenosphere, and on this side you can put the component which will actually articulate with the glenosphere. That would be a metallic based plate along with polyethylene. So nowadays modular implants, they are available, but unfortunately in Pakistan we have only 2 sets of implant, one provided by Zimmer Biomet and other is by Evolutus as a French implant, which we have been using over the last 10-15 years. Now the results which were compared with the hemi with the reverse, they have shown a better outcome in these cases. So few case example, unfortunately most of the patients, they come after a failed osteosynthesis to us, and once they have come to us, then there is no option that the head has gone into avascular necrosis, screws they are penetrating, and you have to do some salvage procedure, and this salvage procedure is then doing a reverse shoulder arthroplasty. So this one is the Zimmer Biomet implant. Another case, this is a German implant, which initially I did in 2009. It is almost now 14-15 years follow-up. In initial x-rays, you see hip abductors, the greater tuberosity, they were attached with a cerclage wire, and ultimately this cerclage wire actually broke, but did not compromise her function. She is doing well. Another case, a doctor by profession, it was fixed in our institution, and you see it failed because the plate was pretty short and only fixation was done inadequately in the head region, but then the shaft region had hardly a couple of screws. So we have to do, this is Evolutus implant with a locking screw distally in the femur, because the in the humerus, proximal humerus wall deficit and weak. He is doctor by profession, general practitioner. He is doing well many years down the line. So another case of a failed loss. And here we had to do this evolutus implant, reverse shoulder. This is many years down the line. And other case in which you see this unique implant once it came, we started to fix it with this, but in total of my, I did 4 cases, 2 cases worked, and in 2 cases has failed. This is a unique implant. Just like a DHS, it has a central peg and these 2 prongs which go and fix the head. But for this, you should have reconstructed greater and lesser tuberosity together. So that failed actually, and then we had to convert it to a reverse shoulder. So this is another case. He had a fracture dislocation, old man. So we did a reverse shoulder Zimmer biomit. He is a politician from Balochistan, doing well. So the complication mentioned in the literature, they are dislocation, infection, hematoma, instability, neurological injury, intraoperative and perioperative fracture. They can happen when you're doing a proximal humerus reaming. And even the fractures can happen to the glenoid also. It has happened to me once also. So one of my residents, when I was putting the base plate and I asked, you just actually tap it, and he tapped just as he is tapping the acetabular cup. So the shoulder surgeon, it has to be a goldsmith, not a hip or knee surgeon. So you have to be gentle in that. And luckily, because I am the one who was doing a lot of actually scapular fracture fixation, so I had to put an interior plate on scapula to restore his anatomy. So this can happen to anyone. The other complications, they are like reflex synthetic dystrophy, scapular notching and subsequent loosening. This happens in usually if you have a long follow-up, you will see. And occasionally we do have a bone loss on the glenoid side, especially in those people who had a interior fracture dislocation or a chronic osteoarthritis of a shoulder where they have a loss of posterior lip, the posterior subluxation. Now, in an advanced country, they have a base plate with wedges, just like you have a base plate of a tibia with the wedges on this side. But unfortunately, we do not have those wedges, so we have to take a bone graft either from the head or from the iliac crest, put it onto the interior lip so that you can actually put it properly in the glenoid, your base plate. Otherwise, there would be if you do not do an eccentric remake and ignore your interior lip of glenoid, you will end up a recurrent dislocation of your prosthesis. So this can happen, especially when you're doing such kind of a surgery. So if you look at the result in the international literature, Cuff et al. Actually compared primary hemiarthroplasty with the reverse shoulder arthroplasty and noted a lot of improvement in forward elevation, especially with the reverse shoulder elevation. And other gentleman, Boylan et al., he also noticed that down the 5 years down the line, the results of a reverse shoulder arthroplasty, they are better than the hemiarthroplasty. So the previous studies, they are also showing same trend, and now people, they are changing their gears and they are thinking that for an unstable type 3 and type 4 fracture, especially in an older age group, one should do reverse shoulder arthroplasty, should not actually fool around by doing a reconstruction with the bone grafting. The chances are that will fail and it will actually require another operation. So as the reoperation rate increases, and especially in our setup, people, they cannot afford it. Thank you. I will just stop it here. I think this is the last slide. Only these studies, they recently actually compared hemi with the reverse shoulder arthroplasty. So one of which compared the locked hemiarthroplasty with the locked reverse shoulder arthroplasty. All these 3 studies reported the outcome in patients with a mean age of 70 years and plus, and found that the reverse shoulder arthroplasty is better clinical scores, less pain, higher forward elevation, and greater patient satisfaction was noted. So in summary, I would say the reverse shoulder arthroplasty is a reliable treatment for acute proximal humeral fracture, especially in elderly people. It grants a better outcome and a fewer complication as compared to hemiarthroplasty. But I think the time is evolving and evolution is a process. As when we were students, we were taught that you need to do a reconstruction based on near classification. Now the Hertel classification is mostly being used to evaluate these fracture and come up with a better treatment. We don't know, maybe 20 years down the line, we have something else which is coming, like resurfacing or some other thing, which will improve the function of shoulder in these unstable fracture. Thank you. Are there any questions?
Thank you, Professor Parvez Hashmi. Any question from the audience side? Yes.
Thank you very much, sir. It was a wonderful talk. I was just wondering that because there, normally once we do the hips, there's a cutoff line at which stage you decide that no, you are not going to fix it back, you are just going to replace it. So is there any cutoff line in your practice where you decide straight away that there's no point in fixing it back, just let us replace it?
Couple, thank you very much for your nice question. You see, this is the question we are trying to answer, that when we should fix it and when we should reconstruct it. If a person is 40, 45-year-old and he had a even fracture dislocation and the head is actually dislocated anteriorly and posteriorly with a good quality bone, good functional class, I will fix this. This is my thought process. Reason being, a young person can bear the burden of another operation maybe 10 years, 15 years down the line. Maybe do a bone grafting, reconstruct it, and do anatomical reduction, and try to see if the head is revascularized or not. But in a patient who has a 65, 70 year of age or older than that, with an osteoporotic bone, with a lot of comorbids, and fracture configuration shows that it is a avascular head. And in Hertel classification, I showed type 2, 9 to 12, all those they show the head is avascular. And then 13 and 14 classification has also been added in that Hertel classification, where the head is splitted or dislocated. Now those are the cases, depending upon the functional class, old age and osteoporotic bone, one should not fool around in doing reconstruction. They should tell the patient that reverse shoulder arthroplasty is the only choice of procedure if person can afford it. If person can afford it. Reason being, you see this reverse shoulder initially evolutus was only 3 lakh rupees. Now it has gone to 7 lakh rupees. Similarly, Zimmer Biomit, it started with 7.5 lakh rupees. Now the last one which I did last week, it costed 14 lakh rupees, just implant cost. So the cost is a major issue. Second is availability of those things. We do not have a modular implants. Unfortunately, many of our local vendors, they do not have a good rapport with the international companies. And you ask those companies that they provided, they ask you, give us some reliable, honest person who can actually do a proper marketing of those things. And he will not actually take away our money. Because I know there are a couple of cases in which those vendors, they did not pay him well, and then they have blacklisted Pakistan. So these are the issues which we face.
And we know that these fractures, the more fragments they are, the higher chances that the head will lose its vascularity in any case. So that is where the Hertel's criteria came in to decide that subjectively that when you think that head will stay vascular, still even the fragments are more. And you have very rightly pointed out that proximal humerus fracture, the 3 and 4 part fractures, is a surgery for cuff more than for fracture itself. And you have to put the cuff back properly through the holes which are already made in those Phelos plates, so that the cuff stays in and the chances of how practical do you find the Hertel criteria in your practice to predict the vascularity?
You see, as I said, it is an evolutionary process. When I was a student and resident, needs classification, and in every radiology, Dr. Umar would ask, so how many parts of the fracture is, what is the criteria of degree of displacement and angulation? Now, as the time has passed over the last 5-7 years, now in every radiology meeting, we will ask our resident to tell us this classification and you present your CT scan finding. So it is an evolutionary process. Now, maybe the time will come again, as initially he described 12 groups. Now there are 13 and 14 groups, they were also added later on. And then Later on, he identified that if the head has a metaphyseal beak attached to it, it shows that there are chances of vascularity. Until unless head is a free piece and it is an old age, you think that it is a avascular piece. And here, if patient is a 70-year-old, osteoporotic, multiple comorbids, and you have to optimize that patient before you take him to the OR, one procedure should be enough to treat his problem. So here the patient comes first, surgeon comes as a second. I always say you must think, and Dr. Umar taught me that before picking up any knife, you must think either this surgery will give any benefit to the patient or not. This is the ethical question. I pass it on to my junior resident also. So surgery should not be done for the sake of surgery. It should be done for the benefit of surgery.
Thank you very much, sir.
Thank you. Any further questions from the audience? Thank you, sir, for such a nice talk and the fruitful talk. Now I request Professor Major General Suhail Amin. Sir. Okay. Sir, please your name.
I'm Colonel Nadeem.
Okay. So I request Colonel Nadeem to present the talk on the behalf of Professor Major General Mohammad Suhail Amin. The presentation is on total TKA in obese patient.
Hand के पास. Thank you very much. We know that total knee arthroplasty in the patients come in various forms in the clinic, and obesity is one big problem in these patients. So once we are dealing with the obese patient who is requiring knee replacement, we need to identify the patients who are at risk and knees at risk and set up a proper preoperative analysis, choose appropriate surgical strategy so that we can reduce the complications which are going to be higher in such patients, definitely. So we know that obesity is defined as 20% or more than ideal body weight, and BMI is one criteria which is commonly used. And the obesity is classified as super obesity if it is more than 50 BMI, with 25 to 30 being overweight and various shades which fall in between. So obese patients tend to develop arthritis of the knee at a younger age. It has been proved in the literature. The well-recognized association once you get obesity is not only that you put extra load onto your joints, you get other things as well, like diabetes, hypertension, coronary artery disease, which further compound the clinical decision making once these patients present. So because of the microtrauma which happens to these joints, because the more load is being transferred through the mechanical axis, releases a lot of inflammatory markers, and with each loading that keep on increasing the damage, and the joint ultimately degenerate. So once you decide that the joint needs to be replaced in an obese patient, the question comes that how good it is going to be. And we know that weight and a high BMI have a negative effect on the longevity of primary total knee arthroplasty. And the revision rates are higher. That tells that you need to select your patient appropriately once you are deciding to replace in obese patients. The second question comes into the mind that whether we should try to reduce the weight of the patient first and then replace it, or replace to go straight head. And the various weight reduction strategies which are there don't work very quickly, and the very fast weight reduction in these patients is normally not advisable as well, because we know that
if you try to reduce the weight very, very quickly because of various strategy in there, that puts extra stress onto the body and lead to the different biochemical changes which can affect the healing process of the surgery which you plan once you're doing, and especially if such a big surgery is being planned, you don't want the wound infection to be there, the wound adhesions to be there, and you don't want these patients to suffer perioperatively with a quick weight reduction brought in. As these patients try to fast with various diet plans, that reduces the albumin levels in the body, and we know that the low albumin levels are associated with the wound complications. The association of low albumin with the perioperative complications is well established. It increases the mortality, increases the surgical site infections, and can lead to the septic shock. The second question is what type of anesthesia should be used, because these patients are big. It is difficult to find the intervertebral spaces by the anesthetist, so you need an expert team to put in the proper anesthesia. So normally what we do in our setup is we do all these patients as a routine in many other centers as well with the epidural anesthesia, because that takes care the intraoperative and postoperative pain relief in these patients. So this is a paper which has already been published, that surgical site infections are more in obese patients. And as the other in-house complications, because these patients have problems of mobility preoperatively, and it is very difficult to mobilize them in the initial postoperative period. The second bigger problem which is faced is that tourniquet, that how are you going to apply the tourniquet in the patients who are obese, falling into the class 3, class 4 type of obesity and are requiring the knee replacement. So one should be ready to either customize the cuff, but sometimes even the customized cuff might not work. So the surgeon should be adept enough to perform the surgery even without the tourniquet and take care of the considerations of doing the surgery without tourniquet, because definitely a bit of more blood loss is going to be there in such patients. And they say that the surgery in a bit flexed position limb reduces the bleeding. We normally template all our patients preoperatively. The only problem while templating these patients which is faced is that there is a thick tissue in between the bone and the plate. So that tends to overestimate the size. So you need to have all the backup with you. Don't rely only on the templating in such patients. Intraoperatively, the exposure is a challenge in these patients, as it is difficult to maintain the alignment and to put implant into the correct alignment, because you are going to fight with the tissues. And more you fight with the tissues, the difficult it is going to be to put the alignment in a proper position. Because the bony landmarks will not be as easily palpable as normally in the other patients which are thin and lean. So if you're not careful and not ready, you can fight with these technical difficulties with increased leg circumference, which is going to affect your surgical exposure, additional layer of the adipose tissue, which is going to compromise the visualization because the fat is going to come in between again and again, which can result in inaccurate bone cuts and damage to the soft tissue structures. So you definitely need a bit longer in seeing these patients. The second problem which is faced is where do you push the patella, because normally what we do is that we cut the paramedian along the retinaculum and the patella falls laterally, but in these patients there is always a lot of tissue onto the lateral side. So one good technique mentioned in the literature is that you create a small pocket of tissue, not a big one that you are going to create a dehiscence layer in between the skin and the subcutaneous tissue, but a small pouch. Instead of displacing the patella all the way down under the subcutaneous tissue, you can keep it in between the skin and the fatty layer. Create a small pouch in there and the patella can dislocate there instead of going all the way, because that is going to put a lot of stress onto the extensor mechanism and you can end up in rupturing the extensor mechanism, which is a big dreadful complication. We are not familiar with this, but the computer-assisted surgeries can minimize the complications in such patients. What is the revision rate? The revision rate is definitely higher in obese patients, especially if the BMI is more than 35. And it has been proven in a study which is already published in Journal of Orthoplasty. These patients somehow or the other can end up in having a catastrophic failure if especially the component is slightly malaligned. In a patient who is not obese might survive for a longer period of time even if there is a slight varus malalignment of the component, but in these patients will end up in definitely catastrophic failure. So that is where comes in the putting in the augment along with the stem. If you think that your component is not going to be properly seated and there is going to be less bone on the tibial surface underneath, it is better to add the base plate with the stem so that the weight transfer is properly along the mechanical axis. Postoperatively, these patients require a lot of dedication and a well-trained rehab team who can take care of these patients to get the range of mobility and can minimize the complications of DVT, respiratory complications, and the change of postures, and getting their quads and hams strength back. So you need these continuous CPM machines in your setup because these patients are going to find difficult to mobilize their knees earlier on. And this machine is a big help that reduces a lot of stress onto you, onto your rehab team as well. And just to show as an example, this is one of the staff nurse. She is 40 years old. She ended up in having a grossly collapsed various knees and was almost onto the desk type jobs because she was unable to be active in the ward where the more demand is onto the staff to be alert and active with the patients, and she was onto the wheelchair for a longer period of time. And this was the status of her knees. Because everyone finds a obese patient, the tendency generally is to, okay, you reduce your weight first and then come for the knee replacement. You work hard more on your muscles, get some strength. So that is how you tend to linger on these patients. And these patients, they keep on continuing in this misery and keep on losing more and more bone, resulting into the bone losses. And then you have to not only deal with the knee itself, you have to deal with the bone loss as well. So this is what we did. We were able to manage on one side without the augment and base plate. We just built the medial side on the right side with a bone piece with the added screws, and on the left side the loss was more, so we added a base plate with an augment and a stem. So she was walking with the help of support definitely, and this is her walk once. but you can see that this patient is not falling into the super obese category. It's just in between class 2, class 3 type of obesity. The super obese is going to be a lot more difficult. So the take home message would be that BMI should be used, but it not only as a single factor in selecting the patients, other factors should be taken into the consideration as well, which involves the motivation of the patient. The patient needs to understand the benefit of the surgery in a clear-cut way, and how much the patient role himself is going to be there. So if the patient is not adequately counseled and adequately taken on board, this can end up in a problem. Thank you.
Thank you. From the audience.
Thank you for very nice talk. Sir, please, is there any cutoff BMI at which, we should proceed to operate rather than wait in obese patient?
The problem is, it is the knees of the patient. If the patient has a grossly collapsed knees, the patient needs a knee replacement. There is no doubt about that. Now, that is where comes that whether the patient is going to be fit enough in the perioperative and the postoperative period, and how much complications and comorbidities are associated with that patient already. So normally in our practice, we are not doing and encouraging the knee replacement once these patients are falling into class 4 or class 5 type of obesity. But to be very frank, many of these patients even need the knee replacement. It's just that you don't find enough public courage and enough support with you to take care of these patients, because these patients not only rely on, and it's not only your effort which matters, it's the effort of the team which needs to come in, because these patients require a lot of intraoperative and post-operative support. So normally we, in our setup, are not doing once it is going into the class 4 or class 5 type of obesity, because that is when these patients are going to end up in problems more than us.
Thank you.
This is Dr. Umar. I have really several patients in the obese category of 3, 4, and 5. I have used two methods. One is for people to have sleeve gastrectomy beforehand, recover, and really have some level of musculoskeletal fitness, and then have surgery. This is a minority of patients, because it is very difficult for them to move around, and after sleeve, if they are going to be in bed, they may lose weight, but then they are very weak, they lose all the muscle mass. So operation is usually done first, usually bilateral surgery, one stage. And surprisingly, their difficulty becomes a lot less, even though they are very unfit, but getting rid of pain really mobilizes them pretty quickly. Obviously, their total range of knee flexion is less, but they have no trouble getting reasonable range. I mean, you let them hang their leg and it automatically goes down. It is not difficult to get limited functional range of motion. But obviously, beyond 100, 110, they don't need it. Their tissues start to match against each other. And at least 25 of these patients of mine then have gone for sleeve gastrectomy or some other procedure. successfully. And some people had this operation after 6 months, some after 1 year, and I insist on it because their knee implant will not last long if they are really in that kind of weight category. Thank you.
Thank you, sir. Any further question? Okay, so we move towards to the next talk by the same presenter, Colonel Saab, on the extensor mechanism rupture after total knee arthroplasty.
And next, please. So another big challenge once you're dealing with the knees and the fear that your extensor mechanism is not there intraoperatively or preoperatively. The patient came in with an extensor mechanism which was not there. How to handle it? This is one of the most challenging complications. The incidence varies in literature up to the 12%, and the causes are multifactorial. They fall into the preoperative, intraoperative technique problems, and postoperative rehabilitation of the patient. All of us are familiar with the anatomy of the extensor mechanism of the knee, the quadriceps joining to form the quadriceps tendon, and through the patella, with the patellar tendon attaching onto the tibial tubercle. So once you come up with a patient who is unable to extend the knee, you need to look for all the problems which can be there associated along with the extensor mechanism rupture. We know that once the extensor mechanism rupture, the patella is going to be high in the lateral position, coming as a patella alta, and complete quadriceps tendon rupture will result in the patella baja. So on one single lateral X-ray, you can identify whether it is quadriceps tendon rupture or a patellar tendon rupture. The quadriceps tendon rupture is a bit lesser in frequency than the patellar tendon rupture. So it's the complete tendon rupture which is there. What about the partial tendon rupture? The partial tendon rupture can be identified with the patient having pain, but you need to investigate it further with the help of MRIs to find out what exactly has gone wrong. In addition to establishing that which tendon has gone, whether it's the quadriceps tendon or patellar tendon, you need to identify the risk factors which are there. Are there any risk factors associated with these patients, which can be in the form of rheumatoid arthritis, diabetes, which is associated with these patients, which compromise the soft tissue quality of these patients, CKD, and are there any scars around the knee joint, and the patient has undergone previous many surgeries around that area. Intraoperatively, you can end up in having a patellectomy or quadriceps snip procedures are risk factors which can put the extensor mechanism in jeopardy. The patellar tendon can avulse from the tuberosity as well, and it can come as a palpable defect at the insertion site. So how to avoid these extensor mechanisms, especially if you are coming across a patient who has a stiff knee? So the good technique could be, as you do normally as well, that you leave a cuff of tissue onto the patellar side while cutting through the retinaculum so that you can have enough of the tissue to repair it back. And then you can elevate partially the tubercle from its insertion in the patellar tendon so that you can have a bit of less stress onto the patellar tendon. Instead of rupturing it, you do a controlled release of the tendon so that you can put it back once if it comes into that stage, instead of letting it go without your notice, because then that is not going to be a controlled rupture. So it's a controlled type of partial release along with the tubercle which you can do. Another factor which can put these extensor mechanisms into stress is the malpositioning of the component. So patellar maltracking is definitely going to increase the stress as the components are malpositioned and can end up in having stresses at various points of extensor mechanism which can ultimately fail. Joint line. So if you elevate your joint line unnecessarily, that is also going to be putting extra stress onto the extensor mechanism, and it can lead to the rupture. So what to do once you come across a patient with lost extensor mechanism? Conservative treatment, probably if it is partial rupture and the patient can still extend the knee. But if it is completely gone, then you need to find a strategy to repair it or reconstruct it. So in the acute setting, you definitely need to repair it if you can, or if you can't, you need to know the techniques by which you can augment your repair with the different autografts which are available in these patients. The problem comes with the chronic ruptured tendons in which the tissue is retracted and you can't bring all that tissue back. And if you try to augment it with something, it's not probably going to be of sufficient strength that you can mobilize that patient comfortably in the immediate perioperative and postoperative period. So we know that from our experience of trauma, we know that if your tendon ruptures acutely, what are different techniques to repair it directly. You can use the Korokov stitches. You can pull those stitches through the tunnels made in the patella, and then that can hold. But that is not going to take care of the gap if it is there. So if there is a gap associated with it, and if the tissue is not sufficient quality left after it has ruptured, so then you need to augment. ये आगे move नहीं कर रही please. Then you need to augment it. So for the augmentation, in addition to the autografts, the allografts are available. We don't have them, and then because of the unavailability of the allografts comes the synthetic meshes which you can use, which can be readily available, and the techniques are mentioned in the literature to use the mesh as a augmentation of your extensor mechanism once you lose your extensor mechanism. This is the autograft technique, and with various rerouting options. You can use the SAMI-T, you can reroute it, you can take the SAMI-T, quadruple it, and put it through the tunnels and bring it back. We have not used the quadriceps and this Achilles tendon as an autograft, but this is mentioned in the literature as well as because you can bring it back up and use it. इसमें थोड़ा सा लैग आता है मेरे ख्याल में. So once you have the allograft option, you can take the whole extensor tendon and place it where the original extensor mechanism was supposed to be. Fix it on the distal side and route it through the leftover quadriceps tendon and roll back onto itself and then stitch it. The synthetic mesh as an option for extensor mechanism repair was described in 1995 by Mr. Mark's mesh. So you take a mesh which is available, which is normally quite frequently used by our general surgical colleagues to repair different defects once they are dealing with their hernias and their abdominal wound dehiscence problems. So you can roll it, make it a sizable 10 into 14 inches sort of a sheet. You can drill a hole just distal to your base plate at the insertion site of the patella. And then you can fix it through that sheet with the screw, which is of a good quality cancellous 40 to 60 mm screw. And then you can route that mesh through laterally onto the patella and then join proximally. So that will take care of the tissue if it is not there, especially the distal patellar tendon ruptures, and can augment it. And then that can take care of one single sheet of the tissue if you have a loss onto the proximal side as well. What you need to do at the end is that you need to put it properly so that it's not coming directly into contact with your condyles onto the femoral side. You have some tissue in between that sheet of graft which you have used, and then you need to cover it on top of it with the retinaculum and the muscle sheet on top of it as well, if it is available. So this is one of our patients which we came across. We lost the extensor mechanism during the surgery, and then we took this sheet, used it in the technique which is mentioned there, covered it with the soft tissue on top of it, and the patient is in follow-up. So far, the patient is progressing well because on table we could see that the patient is not having enough stress onto the tissues and can mobilize adequately. So in conclusion, extensor mechanism rupture can happen once you are doing your knees. It can happen at any stage intraoperatively, or your patient can present before surgery coming with the patellar tendon rupture, or can present in the immediate or late post-operative period in the follow-up with the extensor mechanism rupture. So one should have strategies in hand to deal with such problems.
Okay, thank you. Any question? Yes, please.
Thank you, Dr. Nadeem. This was a very important topic actually, and some of us may have come across this complication. Just my two questions. One, you mentioned tibial crest osteotomy, one of the measures to protect avulsion of the TT. Just please can you give a brief detail about that? And second question was about the mesh, because on the knee there are loads are too much in comparison to hernia repair. So I mean, what the literature says about the efficiency of this mesh when you are going to just protect the ligamentum patelli by using it.
Yes.
Thank you.
Thank you very much for the questions. The problem is that you are not going to get a lot of space by doing the tibial tubercle release or osteotomy, partial sort of an osteotomy. It is just once you are fighting with getting some space into that area, and you don't want to put stress onto that tissue, that it automatically ruptures. So by just taking it with the help of an osteotome slightly off can lift your extensor mechanism and to provide you with just sufficient space that you can go in and can work in that space which you are trying to create. I personally, to be very frank, don't have that experience because I'm not primarily a knee surgeon to deal with such problems, but that is how it has been mentioned in the literature. Maybe my senior colleagues sitting here can answer this question more effectively. Coming on to your second question, we have used this sheet in our patient. We in military have the experience of a general surgical side with us as well, and we use it as we know how to handle and how much strength it has got. If you roll it well, in itself this sheet has enough strength, but to take the load of the knee, it needs to have further strength into it. That is where you need to take a long sheet and roll it to make it more robust, strong enough. So that is where it is said that it needs to be of at least some thickness. So you need to roll it into 4 or 5 layers actually, so that it can have enough strength in it and cannot give away the problem which you are dealing with.
Nice talk, sir. My question is regarding the post-operative rehabilitation protocol after extensor mechanism reconstruction. So how much flexion means when you reconstruct, when we augment, when we use synthetics, what are your targets to how much extent the patient is supposed to bend the knee?
You need to test intraoperatively that how much movement you are going to allow this knee, because you're not just putting everything in there and not testing it intraoperatively by moving this knee across. So you need to identify that safe range of motion in which this construct is not going to be under a lot of stress, because if it is already under a lot of stress, that probably you have not done enough. So that is where you need to identify intraoperatively that the patient is having sufficient range of motion, can at least bend to 90 so that the patient can sit in the chair at least, one. And you need to put that range of motion clearly into your notes for your rehab colleagues so that they know that they are not supposed to go beyond this range of motion. So what we normally do is that we normally immobilize these patients in a lockable brace once these patients are coming off, because we want to protect this precious effort which we have put in. We don't want any other non-medical related problem of shifting the patient, moving from one place to other to put already a lot of stress onto this. So we take a lockable brace, lock it into extension, and keep that into extension in the intraoperative and immediately postoperative period. We ourselves, one or the senior surgeon or one of our senior residents goes in and then unlocks it, or we teach to our rehab colleagues how to unlock it, because there are slots in there which can lock and unlock, and you can adjust the range of motion with those lockable type of braces. And then you can know that how much they are going to flex that knee in the initial 2 weeks period, and then follow up up to 4 weeks following that once they are coming to you after the stitches removal. So normally what we do is that we allow them range of motion in the safe zone immediately in the preoperative, immediate post-operative period till the stitches removal. Then they come to us after 2 weeks for stitches removal, and then they increase their range of motion in that safe zone further for the next 4 weeks. And we keep on protecting it till almost 3 months or so, so that we know that everything has healed reasonably enough, and we can increase the range of motion further and can stretch the tissues to get the laxity out of the tissues, which is naturally there in everywhere almost.
Nice.
Thank you, Colonel Nadeem sir. Now we move towards the second part of the session, the free papers. For the free paper, I think we have a Dr. Adnan here, and Dr. Mustafa, Dr. Zuhaib, and Dr. Asif. So I request Dr. Adnan to come on the dais to present the free paper. Is he here? No. Okay, Dr. Mustafa. Okay, Dr. Zuhaib. Okay. Dr. Zuhaib is presenting the paper on outcome of proximal femur replacement in failed internal fixation of hip fractures and case series.
Assalamu alaikum. So I am Dr. Zuhaib Nawaz, and I am presenting one of my research papers when I was a resident at Aachen University. And the topic of my presentation is outcome of proximal femoral replacement in failed hip surgeries. Next, please. So the contents will include introduction, material and methods, results, discussion, and conclusion. So failure of hip implant surgeries can be caused by various factors, including infection, non-union, malunion, avascular necrosis, implant loosening, and implant failure. So failure of internal fixation results in pain and restricted ambulation for the patient. In management of elderly patient with hip fractures, the basic aim is to ambulate the patient as early as possible to prevent the complications of bedridden, like DVT, urinary tract infection, and pneumonia as well. So my study was a retrospective analysis of 26 patients. It was done at Aachen University Hospital, and the duration of the study was from 2011 till 2018. So this was one of our case that came to us in which the implant was removed and patient was subsequently having the fracture of intertroch area. And outside AQ, it was fixed with the DHS. However, it again subsequently failed, and that results in the cutout of the DHS implant. So when the patient came to us, we did proximal femur replacement with the THR, and patient was ambulated the very first day. So basically in this implant, is the pointer here? स्लो प्रोग्राम है आपके कुछ सही है. So this was the proximal femur replacement in which we have the holes for the iliopsoas, and this was the so we had the holes of iliopsoas attachment and we have the holes for abductor attachment in this implant, and then we have the screws where we can manage the anti-version with the help of this screw. So that is the basic advantage of this implant, that we have these holes, along with that we have this screw, and along with that it manages abductor tension, and along with that we can manage leg length discrepancy as well in this implant. So total patient were 26, and the result shows the mean age of the patient was 74 and mean follow-up period was around 20 months. Harris hip score was improved from 26 to 66.7 postoperatively. 3 patients developed dislocation that was managed in close reduction. 3 patients died within 1 year of surgery, in which 2 were with MI and 1 patient has sepsis secondary to implant infection. 3 patients developed surgical site infection. 1 has superficial surgical site infection that was managed with oral antibiotics. Second case developed deep surgical site infection that was managed with debridement along with IV antibiotics. And in the third, wound debridement was done, but the patient died because of sepsis. So in conclusion, proximal femur replacement modular stem implant has advantages over conventional hip implant in patients undergoing surgery after failure of internal fixation. Thank you.
Thank you, Dr. Zohaib.
This was one of the article that was published in literature that shows total hip arthroplasty for complications of proximal femoral fractures. However, the complication rate were increased if we do the primary THR after failed internal hip.
Okay, thank you. Dr. Zohaib, any question from Dr. Zohaib? In the last, I am again calling the name of Dr. Adnan. Is he here to present the free paper? Dr. Mustafa and Dr. Asif Ali. Okay, thank you. Now I request in the end of the session from Professor Parvez Hashmi to give the concluding remarks about the session. Sir, please.
was an excellent session. You see, our Colonel Saab has presented two difficult topics, especially extensor mechanism, lag, and I always say that you try to get a better exposure just extending your incision. If you can extend incision, and people, they have a habit of everting the patella. Especially in patella baha, you have a little difficulty, but if you can extend your incision proximally and distally and only subluxate the patella and do a proper retinacular release, or on the lateral side, there is a lot of synovial tissue which we call patellofemoral tissue. It's not actually retinaculum, it's a lot of synovial tissue. My resident always say that nobody does it. Why you put periosteum elevator on this side and it is a meniscofemoral or lateral side synovial tissue, you release it. If you release it, and even I do not evert the patella, I only subluxate it and put a Hohmann detector on that side. And if person they have a patella baha, they can put a small pin around the patellar tendon into the tibial tuberosity. That will actually inhibit. So in my, I do a limited arthroplasty, maybe in a year 70 to 80, not more than that. But those people who are doing excessive this arthroplasty work, they can actually put a better light on it. But at least I have never encountered any patellar avulsion on that side. The second comment I would say that once you have done any reconstruction work around extensor mechanism, either it's a quadriceps or patellar tendon, we have been taught and we learned to put a cerclage wire around the patella in the quadriceps tendon, so that's pull it down, and then making a hole distal to the tibial tuberosity and just tensioning it, and which allows only 10 to 30 degree of motion at that time. Till the time your extensor mechanism is healed over a period of next 2-3 months, 4 months, then you can, just under local anesthesia, you can remove that wire. So that helps a lot. Maybe you can ask Dr. Umar because he is my teacher, mentor. Oh, I see. He has left.
Thank you, sir. This is how we conclude the session, and I'm thankful to the panelist, the presenter, for presenting the great talk. And this is how we end the session, and now we go for the tea break, I think. Sir, please. Sir, sheet distribution, sir, bhi mujhe. Nahi. The organization. Okay. I request Professor Parvez Hashmi to give the certificate to Dr. Zuhaib on free paper presentation. Photographer? Sir, please. No answer? Thank you. Thank you, sir. फ्री पेपर्स हाँ आप लोग आते हैं सर्टिफिकेट 1 2 सर आपकी शीट इस पे है नहीं सर इसमें है आपकी शीट सर की शीट नहीं है क्या नाम परवेज हाशमी प्रोफेसर परवेज हाशमी क्या नाम सर कल क्लोज हो जाए आ जाओ बेटा Thank you. I request the second presenter, please. Take a certificate from Professor Parvez Hashmi. Okay. Thank you, sir.
two, mic check, one, two. Hello, 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 hello. One, two, hello, 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 one, two, mic check. One, two, hello, hello. प्रेजेंटेशन कोई लगा दें, बस वैसे कोई सा भी लगा दें. इंशाल्लाह नेक्स्ट टाइम होगी प्रेजेंटेशन को. हाँ आगे कर दो. हाँ हाँ प्रेजेंटेशन में कहूँगा ना. खुश हूँ.
ना ना 10 शेरा हो रहा. खुश हो.
Assalamu alaikum. My name is Dr. Rahil Baloch and I'll be the moderator of this session. I would request the panelists, Dr. Kazim, Dr. Mustafa Javed and Dr. Saeed Sheikh to please take on their seats. आपकी permission? आप इधर आ जाए, पर आपकी तो talk है. Okay. So we're going to start with the first talk of Professor Zakir Azkar, tibial spine avulsion.
Today I'll be talking about okay. So today I'll be talking about the tibial spine fractures. Representation. I'll be talking about the anterior tibial spine fracture, its classification, the management and different controversies in management, and the role of primary reconstruction. Now, tibial spine fracture is basically equivalent to an ACL tear in adults. It can happen both in pediatric patients, can happen in adult population as well. I've seen quite a few cases of tibial spine avulsion in adults as well. First described by Ponce in 1894, and the first classification of it was done by Mears and McKeever in 1959. The commonest age group is about 8 to 14 years age, but the important thing is that in about 40% of the patient, there can be associated injuries like meniscal injuries, even ACL injuries, and chondral damage associated with anterior tibial spine fractures. The common mechanism is basically a fall from a bike or a fall while they are playing. Now, when it comes to examination, you have to examine the patient as a whole, and you should always look for other ligamentous injuries. As I explained to you before, quite a high percentage of them have got associated meniscal injuries. The classical classification is the Mears and McKeever, which basically divided into sort of three types. The first is undisplaced. A type 2 is when the interior part is lifted while their posterior part is still intact, and type 3 is the one which are totally displaced. They add type 4 as well, in which the tibial spine fracture, or the bony part of the injury, was a comminuted fracture. Recently, Green, in 2019, his own classification of the tibial spine fracture, and it is basically based on MRI findings. So he divides into 3 types: 1, 2, and 3. 1 is if they are completely undisplaced, or the displacement is less than 2 millimeter, then this will be a Green type 1. In type 2, if the interior aspect is raised more than 2 millimeter, but the posterior is raised less than 2 millimeter, then this will be a grade 2 injury. While if it's completely displaced, or even if the interior element, the posterior element is lifted more than 2 millimeter, or there's an entrapment of the meniscus, then this will be a grade 3 Green injury. So this you actually see on the X-ray. So tibial spine has been lifted up again. So this is an example of a type 3 injury. And an MRI, you can actually see that this will be a Green stage 1 injury, because their posterior, Green stage 2 injury, because the interior is lifted and the posterior is lifted less than 2 millimeters. The most important thing is the associated injuries associated with these injuries. So the meniscal injuries are about 32 to 59%, which is quite a high percentage. And the interior horse entrapped is in about 26% of type 2 injuries and 65% of type 3 injuries. And in 20% of these injuries, there can be a concomitant ACL injury as well. The goals of treatment are simple. You have to reduce it, hold the reduction till it heals, and start early mobilization. And if during operative you can do something to avoid ACL laxity, then that's important. Now, the treatment of type 1 is simple, straightforward. You can do it conservatively. Type 2, there's a bit of controversy. You can treat it both conservatively and operatively, while type 3 and 4, they have to be treated operatively. Type 1, you generally basically put in a cylinder cast for about 4 to 6 weeks. You can also aspirate the hematoma, increase the chances of healing. Now, some of the people, majority of the people, they will put in full extension, because what they hope is that because of the pressure of the femur, it will actually hold it reduced. But some people will put in about 20 degrees of flexion, just to put a bit of tension on the ACL. Type 2 injuries, they are sort of a bit controversial, but however, if they present early within the first 24 to 48 hours with less than about 5 millimeter of displacement, then you can actually do an MVA and put them in POP. And after POP, you should get an X. I don't know what's happening to this. So you can, and then you get an X-ray and you just clean. What you also should do if you're trying to treat it conservatively is to try to get post-op MRI as well, because an X-ray you cannot get a proper idea of how good the reduction is, and you have to keep an eye on the reduction for at least the first 3 to 4 weeks. You usually put them in cast for about 4 to 6 weeks, and then you mobilize them. But as explained to you before, a lot of the people, because of the problems with the residual laxity in type 2 injuries, they will go and still operate on them. So this is it's basically a randomized controlled trial, and it was 43 type 2 injuries. 22 were treated arthroscopically with suture fixation, and 21 with conservatively. And they were basically weighted by X-rays, the Lachman test, the interior drawer test, the IKDC scores, and the lysome scores. And what they found out, that the one who were treated conservatively had more grade 2 laxity as compared to the surgical group. And there are also significant differences in the functional scores as well. Now, type 3, when we come to type 3 and 4, the decision is easy. You have to treat them by operative reduction, because obviously if you don't treat them, they will not heal. The controversies here are that you should treat them by open reduction, or arthroscopic reduction, and how you're going to fix them, whether you're going to using screws or sutures or double button, and what the post-op rehab should be. Now, operative reduction, one of the problems with operative reduction is this entrapped meniscus or the intermeniscal ligament, and sometimes it's very difficult to do it. And one of the easy tricks is to just put by a sort of outside, and you put a suture, the same way you do it in the meniscus, you put a suture, you put a suture underneath it and just pull it out on the other, interior to it, and you can actually pull either the meniscus or intermeniscal ligament that way so that it does not interfere with reduction. This is something which is a very useful technique, because if you don't do something to actually take that meniscus or the intermeniscal ligament out of the way, your reduction will be very difficult. It will be very difficult for you to do a reduction. When you come to fixation, there are different things you can use. You can use the normal screws. The ones we use are the 4mm cannulated screws, or you can use the double button, or you can use the sutures and the suture lasso we use in shoulder surgery. Screws generally, technically, can be less demanding, and probably because they give you a better fix than the sutures, then you can mobilize them earlier. However, for the screws, you need a larger osteochondral fragment, and sometimes there is hardware irritation as well, and you probably have to take out the screws if there is some impingement. And obviously, if you cross the physeal plate with your screws, then there have been chances of physeal damage as well. Screw fixation, you basically go in, you can do it arthroscopically, and you can do it openly. So what you do is you go in, you have to put in 2 wires. So you put in 2 wires, basically to hold it. So you basically put in 2 wires, and on the top of one wire you can drill it, and you can put in your screw. And this is a diagram showing the 2 4mm screws have been put in, and they are not crossing the physes. I like to use a double button tightrope, because although the results are maybe roughly the same as the screw, but just give you sort of, but I feel it's easier to apply, and you can actually adjust it once you're. यार क्या हो रहा है यार, बस खुद ब खुद जो है ना. And you can see the double button as well, sort of fixed on the advantage of this is that even if once you apply it, you can still sort of adjust the tension and sort of adjust your fixation after that as well. Suture fixation is, now these 2 techniques, the screw and the double button, you can only use if you have got a biggish osteochondral fragment. But if the osteochondral fragment is small, or if it's comminuted, then the only option you are left is a suture fixation. It does minimal damage to the physes, but the problem with this is that this is technically demanding, and you probably need suture lassos for that. So that means you simply pass that lasso in between, pass that lasso through your ACL. I don't know what's happening to this. So this is the suture, and actually you can do two things to the suture. You can either sort of fix it inside the joint by using a knotless anchor suture, or you can, like the same way you do an ACL, you can actually put it on the top of an endo button. So you can either use a knotless anchor, or you can use an endo button on the tibial side. In patients who have got the fascia still open, you can do an all epiphyseal tibial spine fracture fixation with the help of these sutures. Now, is there any difference, and the controversy starts whether you should treat them open or closed, and what fixation method you should use. So this was a study done by Watts, and actually they compared the open versus arthroscopic fixation of tibial spine fractures in children. And they had 31 patients, 13 or ORIF and 18 by arthroscopic fixation. And what they found out that in arthroscopic, in their study, 33% of them acquired arthrofibrosis. But if you look at the study again, the main problem in the patients who underwent arthroscopic fixation was that they were fixed 1 week after the injury. And the operative time was more than 120 minutes. So they postulated from that especially if you delay the surgery for more than a week, or if operative time is more than 2 hours, then you increase the chances of your arthrographosis. This was another study by Schimberg. It's basically a multi-center comparison of open versus arthroscopic fixation of pediatric spine fractures. And it was a retrospective cohort study. There were 477 patients involved with it. 88% were arthroscopic, 57% were ORIF. The average follow-up was 1.2. And what they postulated was that despite the fact that the rate of short-term complications, return to operative failure and failure to return was similar in both these groups, but the one thing in which arthroscopic was better was the diagnosis of concomitant injuries like meniscal injuries, condyle injuries, and maybe ACL injuries. Now we come to the fixation. So should be using the screws or should be using the suture fixation? Now there's a cadaveric study in which actually they used 3 different fixation techniques. So they use antegrade. So they use antegrade and retrograde screw fixation and a pull-out sutures. And they basically, this was done on cadavers. So actually they looked at the strength of these 3 different fixation techniques. And they found out that the antegrade fixation gives you much rigid internal fixation as compared to the pull-out sutures for ACL avulsion fracture. So biomechanically speaking, antegrade screws are better, say, in a type 2 or type 3 injury in which you got a biggish osteochondral fragment. Study by Kellman, again, 67 patients, again 33 screw fixation, and that was a randomized controlled trial, type 2 and 3 tibial avulsion fracture. The average follow-up was about 12 months. And what they found was that there was no difference regarding, again, no post-surgical arthrogryposis, meniscal procedure, etc. But what they did found was that the screw fixation group had more reoperations, probably because of the irritation of the screws and the screw removal, and it had 3 times more chances of sort of undergoing reoperation as compared to the suture group. Again, another meta-analysis by Dan. Again, roughly, so again, and they also roughly sort of came out with the same notion that although they have got the similar post-operative outcomes, but the rate of subsequent surgery and implant removal rate was more in screw fixation than in suture fixation. So generally speaking, say for example, if you got a biggish fragment, then you can do a screw fixation, but you have to keep in mind that the chances of resurgery, especially removal of the sutures and irritation of the chances of removal of the suture because of the impingement are higher. As far as the post-op rehabilitation is concerned, it's very important that you start the range of motion exercises within the first 4 weeks, because if you delay it after 4 weeks, then the chance of arthrographosis increase increase quite a bit, so 0 versus 36%. And if you immobilize them for more than 4 weeks, again, the chance of developing arthrophysiosis are quite high. So it's very important that you start mobilizing. Whichever fixation you do, you have to mobilize them within the first 4 weeks. If you don't mobilize them within the first 4 weeks, then the chance of arthrogryposis sort of increase quite high. Complications, one of the common complications of arthrogryposis, it's mainly related to delay in surgery and the longer operative time. It has been shown if you delay the surgery for more than 1 week and the operative time is more than 2 hours, then the chances of arthrofibrosis increase. The other thing you have to mind that ACL laxity is quite common after spine fractures, and incidence can be as high as about 30 to 40%. And ACL reconstruction for new injury of spine can be seen at the rate of about 20%. So we have to keep that in mind. So in summary, the tibial spine fractures are something which have to be handled quite carefully. Early fixation, so you have to try to fix them within the first week, and early mobilization within the first 4 weeks is important. Generally speaking, open reduction and arthroscopic reduction, they give you the same results, but the chances of free surgery in open reduction are higher as compared to the arthroscopic reduction, one. And secondly, the chances of finding isolated injuries again is quite higher if you do it arthroscopically as compared to an open reduction. You should not mobilize them for more than 4 weeks, and if treated properly, they can give you good results. Chances of residual laxity are always there, but it's amazing that how with the proper physiotherapy, not many of them sort of will need ACL reconstruction. Thank you for it. Any questions?
Any questions by the audience?
Sorry. Or by MUA, just you mean you just sort of put them in type 1. With type 1, you don't need anything, but in type 2, so what I meant was that you put them in just an extension cost. No, you can put them some form of analgesia as well. So sorry, that was wrong. So you can put them in analgesia, and then you can take an X-ray. Obviously, if it's very painful, then you can put them, so give them some analgesia or anesthesia, but not necessarily. The laxity can be because of 2 or 3 reasons. One is because of concomitant injury to the ACL. Secondly, because the way these injuries occur, basically there's a first stretch on the ACL, and then there's a avulsion that can be there. Sometimes you can get over it by sort of trying to advance your tibial spine and fix it that way. One. Secondly, about 10 to 15% or 20% of these patients can have concomitant ACL injury as well. So part of it is because of the nature of the injuries, the ACL gets stretched or can even get torn. Obviously, if it goes into non-union, then obviously you will have a...
So, I had the excellent presentation. Almost आपने सारी चीज़ों उसमें cover की. Laxity, that was my question. The laxity comes from whenever we want to reattach it arthroscopically, we have to make a more creator into that, in which we want to pull it into that. It's little anterior and little distal. That always put a lot of stretch on the ACL. We think that is a better for that. No, that may not be better than that. We should have an adequate range of motion while fixing it. If it is not tight in all throughout the range of motion, then probably subsequent laxity is. When we tight it and pull it that inside, that may be the reason for the subsequent laxity.
That's the problem. You see the reason why I sort of use a double button or use a suture fixation for these injuries is that before your sort of final sort of fixation, you can actually see and you can actually check your range of motion as well. The problem with the screw fixation is that unfortunately you can't do, once you fix it, then you fix it. But with a double button or a suture fixation, you have got this liberty of actually trying your final reduction before you do it.
Yes, that's I think good.
Thank you, Professor Zahid. We'll move to next talk by Dr. Javed on buccal hander tear reduction and repair.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and good afternoon. So I am Dr. Javed Iqbal, working as an assistant professor, departments of orthopedics, traumatology and sports medicine, Lady Reading Hospital, KPK. So this is the hospital where I am working. Today's talk, so I will talk about the bucket handle tear and our customized cost-effective approach, how we are taking these tears. So basically this is the view how the bucket handle tear is looking arthroscopically. This is basically the bucket handle tear medial meniscus, and I am probing it. Look at this. So I am going nothing to disclose. The learning objectives today, we will talk about the bucket handle tear, the treatment approach, that is meniscectomy and the meniscus repair, our customized approach, how we are going to tackle the bucket handle tear medial meniscus, and the evidence-based medicine, that is the research we are conducting in our department on the bucket handle tear. So as you all know, bucket handle tear constitutes up to 10% of the meniscus tear. And in case of torn meniscus, the patient will have the symptoms of pain, swelling, locking. And what will be the natural history if the patient is let to go with these symptoms, so he or she may damage the knee, and there will be early onset osteoarthritis of the knee joint. So this is the MRI view. Look at this. This is basically the PCL, posterior cruciate ligament. This is basically the T2-weighted image sagittal view MRI. This is the PCL, and this is basically the bucket part of the medial meniscus that had been gone posteriorly, and this is double PCL sign. So now let's move to the bucket handle tear. So basically, again, this is the arthroscopic view. I am doing the diagnostic round. This is the lateral compartment. This is the medial compartment. This is the femur. This is the tibia, and this is the torn part of the meniscus that has been displaced into the internotch. So let's move to the treatment of the bucket handle tear. So we have got the meniscectomy, which is basically the default treatment. There are multiple reasons, and this is easy to do, less time consuming, and the implants that are very costly, that are basically in use for the meniscus repair. So that is why in majority of the cases we are opting for the meniscectomy. And you all know the consequences of the meniscectomy. The second approach is basically the meniscus repair, and for the meniscus repair, we have got commercially available implants. That is the outside in, inside out, all inside repair kits. And we are doing here, I will show you how we are doing the meniscus repair by means of locally customized approach in case of bucket handle tear. So now we are going to the steps. What are the steps which we are basically following in case of bucket handle tear? So first we do reduction, then stabilization of the body of the meniscus by means of outside in technique. Then after that, the application of air, that is all inside meniscus repair device into the posterior horn of the meniscus. So in case of our customized approach, what are the basics armamentarium? These are basically the basic armamentarium. These are the sutures, the Vicryl 2.0. This is again the Vicryl 2.0, and we also use the Prolene 2.0 for shuttling of the suture or around the meniscus or through the substance of the meniscus. And this is the IV cannula, 14 gauge, simple implants. So the first step is basically the reduction of the meniscus. What are the steps we are doing before the reduction? We widen the joint. In case of medial joints, we do the pie crusting of the MCL to open the knee joint to make a space for the meniscus to sit back against its natural anatomical bed against the capsule. Before that, we basically prepare the bed. That is basically we shave the area to make it more bleedy to enhance the meniscus healing once it's seated back to its natural bed, and then the application of the reduction devices. That is basically we are using the probe, or we can use the trocar as well. So basically this video shows how we are doing the meniscus. So the bed has already been prepared. This is the femoral condyle, this is the tibial plateau, this is the bucket handle part of the meniscus. This is basically the trocar, and the meniscus has been reduced and it is sitting against its natural anatomical bed against the capsule. So after reduction, basically we are going to stabilize the body. So this step is basically the stabilization by means of outside in technique. So two stitches has been deployed. That is from outside in meniscus, and this is basically vertical matrix sutures. That's the stitch number 1 and stitch number 2. In majority of the cases, on average, we have we deployed 2 stitches. This is another case how we are deploying the stitches. Look at this, the femoral condyle, tibial plateau. This is the body of the meniscus, and the suture has been passed through the substance, and one has been passed through the inferior surface of the meniscus. And look, we are pulling it, and it will reduce the meniscus, and it will seat again its natural anatomical bed. So nicely it has been reduced against its natural anatomical bed. So the first step was basically the reduction, followed by stabilization of the body of the meniscus. Now we are going to deploy all inside meniscus repair device into the posterior horn of the meniscus. In some cases, we can leave the meniscus as such, and there is no need for the application of the all inside meniscus repair devices. But there are cases in which the bucket handle tear extends into the posterior root. So there is need of the application of the all inside meniscus repair device, because there is a sort of ramp lesion, residual ramp lesion, and so the meniscus repair may fail again after some time. So basically the step how we are deploying the all inside meniscus repair device into the posterior horn of the meniscus. This is basically Fastfix 360 system, and now we are going to deploy it. So the body has been stabilized. This is basically the first stitch that is going to be deployed into the posterior most part of the meniscus, and there is radial component. If you focus here, there is radial component, so I'm going to incorporate this radial component into the stitch as well. So this is the first stitch, and this is basically the second stitch. So this stitch has also been deployed. So one stitch, two stitch, and this is the all inside meniscus repair device stitch into the posterior horn. And we'll remove the slacks, we'll cut the extra stitch, and the meniscus will be stable one. This is the step how we are removing the slacks. This is the knot pusher device, and after this we will cut the extra stitch. So this is the post-op view. Look at this. This is minimally invasive arthroscopic approach. The stitch number 1, the introlateral portal, the intromedial portal, and this is basically for the outside in meniscus repair device. These are three step sites. So now we are going to the evidence-based approach. That is, we have compared this customized outside-in technique with the commercially available implants, that is sharpshooter needle. This is basically a comparative study that we conducted. So the study design was basically, this was a quasi-experimental study with a total number of patients 30, 15 patients in one group and 15 patients in second group. So in one group, we stabilized the meniscus by means of sharpshooter needle, that's commercially available implants. And in the second group, we deployed we reduced the meniscus, stabilized the meniscus by means of locally customized outside-in technique. So basically, we conducted this study from January 2021 to July 2022. There's 1.5 year study, and we conducted in our hospital. So what were the outcome variables? So successful reduction, and perioperatively that was assessed by means of probing the meniscus after repair. Then the healing was assessed by means of Barrett criteria, and the cost analysis, the comparison between the two groups, and then the patient reported outcome measures by means of IKDC and Tegner-Lysholm score. These variables were took into account, and all the patients were followed preoperatively and scores were recorded, postoperatively at 3 months, at 6 months, and after 1 year. So the cost comparison between the two groups. So commercially available implants that range from 15,000 to 26,000. On average, it's up to 20,000. And the mean was 19,555. And the customized implant, that is 2 or 3 sutures and 1 IV cannula, and its price is ranging from 800 to 1,600. That's on average 1,200 rupees. So the comparison was made and statistically evaluated, and it yielded a p-value of less than 0.001, statistically highly significant. So a big difference in the prices of the two implants. So this is basically successful reduction perioperatively. We compared the two groups, and in case of commercial implants, there is the sharpshooter needles. Out of 15 patients, there was 100% reduction in stabilization with no failure perioperatively. But in case of our customized approach, one case failed to reduce, and in that case, we we reduced and stabilized by means of sharpshooter needle. So 100% in case of commercially available implants, and in case of customized protocol, that was 96.1%. Then the healing was assessed as per Barrett criteria, and Barrett criteria states basically there are 4 variables. First of all, swelling, popping or locking, medial joint line tenderness, and McMurray test. These are 4 variables, and all the patients were evaluated by that protocol. In case of commercial group, we got healing in 14 patients. That is, the success was 93%. And in 1 person, we failed to achieve the healing. That is 6.6% was the failure rate. In case of customized group, out of 15 patients, in 13 patients, we got the healing, and in 2 patients, we not achieved the healing. So then the patient-reported outcome measures that was compared. So in case of commercially available implants, preoperatively the score was recorded. Then at 3 months, 6 months, and 1 year. And when all these scores, the mean were compared, there was statistically significant difference from each and every step. Means this treatment protocol is effective. In case of our customized approach, same. The Tegner-Lysholm IKDC score was recorded preoperatively, 3 months, 6 months, and after 1 year. And it was noted there is significant improvement in the scoring of all these patients, and we yielded a p-value of less than 0.05. That was also significant. Then the comparison of the two groups were done. That is the customized group and the commercially available implant groups, both were compared, and we found that the 6 months and 12 months scores of the both were compared, and we yielded a score, a means, which when were compared, the p-value was not statistically significant. So in terms of PROMs, both groups were the same. So in conclusion, our customized outside-in protocol that is cost-effective, a big difference in price from 16,000 to 26,000, and on the other side we have got 800 to 1,600, a big difference. Reduction, that is quite satisfactory, and we can reduce the meniscus and stabilize the body in case of bucket handle tear. Healing, we achieved the satisfactory healing, and the PROMs were also satisfactory in both groups. We have got some limitation. The sample size were less. There is only 30 patients, and it was quasi-experimental study, so we would like to recommend randomized controlled trial, and the follow-up should be longer compared to the small, shorter follow-up. So what is the take-home message? Let's learn from this video. These are basically two kids playing with each other with a stick in a hand of one. This kid is basically approaching to the knee of this, and this is respecting the knee basically. The baby is kissing the knee and respecting the knee. So the take-home message is prevent the knee trauma, respect the knee joint, value the meniscus. The meniscectomy shouldn't be the default treatment, and cost shouldn't be a restraint to save the meniscus. So whenever the meniscus is in range of saving, that is by means of that is basically not too much heavy, not too much bad, so one should try his or her level best to save the meniscus, because saving the meniscus is basically saving the knee joint. These are the references, and thank you so much for attention. Any question, please?
Questions to be asked?
Dr. Javed, very nice talk. Just one quick question. The suture that you use for the outside in technique was Vicryl, right?
Yeah.
Okay, so Vicryl is not absorbable suture.
Yeah.
That's strength 50% goes within 3 weeks. So in your thought, it's non-absorbable should not be the better option?
We have got some issues in the non-absorbable. That is the purulene. The knot is not secure, and it easily breaks when we pull it outside the knee joints. So Vicryl and the fiber wire, these are the fiber wire is ideal, but in long run that also causes irritation. So in the reference article, it has been mentioned that Vicryl can be used, and when the meniscus is seated back against its natural anatomical bed exactly, so during that time the meniscus may heal. So the patient is supposed post-operatively, rehabilitation protocol is very important. The patient is not allowed to bear weight for 6 weeks, and there is a range of motion protocol that is in the first week 30 degrees, second week 60 degrees, third week 90 degrees, and after 1.5 months the patient is allowed to bend his or her knee beyond 90 degrees. So these are basically the measures. Ideal is non-absorbable suture, but in purulene I have done some cases, but that basically we can say a fracture. The suture fracture when we bring it outside the knee during, and the knot is also not secure one. So fiber wire is the ideal one, and in limited resources, limiting areas, we can use Vicryl as well.
Well, in your future thought can help you if you can use that. My just thought about it.
Yes.
Thank you very much.
Javed, then excellent. We are doing the same in the doctor's hospital, Lahore, and this is a very, very cost-effective. And
Yes.
if you focus just, Najat was saying, the Vicryl is a suture which is going to lose its strength very soon. Sometimes we open it and it may stay there for 6 months as well, but they are just like the fibrils remaining of that. It's not that much of a bond which would have. The body of the meniscus through which you are doing outside in is the strongest part. If this is detached, roots will do nothing.
Yeah.
So you're putting posteriorly inside, all inside, that is very good. And simultaneously you have to fix the body as stability giving. What we are doing, we have purchased bundles of your fiber wires, ranging from 1.5, 1.6, 1.8, 1.9 diameters from the vendor who supplies to these national, international community. So that is very, very economical. At almost 1 meter of that cost us sterilized in the pouch through that ETO, that costs 600 rupees only. So you can use that instead of this proline, and that will give you a better stability, and it continues to be stable. Metal suture is a good technique, and it reduces them back. So that may be used as well.
So, sir, you are deploying the all inside repair device in each and every
No,
case?
the body is from the outside in. The
Yeah.
posterior suture
Yes.
is all inside, the
Yeah.
same technique, but using the suture, which is the fiber wire,
Yeah,
it is 1.5, and through the same needle.
Got it.
But we do it all inside. Posterior horn is all inside, the body is with the outside in suture, the same technique.
Yeah, sir, I went through the literature. In some cases, they have done by means of outside end technique, never fixing the posterior horn. But in case of extensive tear that extending in towards the root, one should fix the posterior horn by means of all inside meniscus repair device.
Whenever there is a buckle handle, the
Yeah.
bucket means a bucket and handle means a handle. It has both ends, anterior and the posteriors, so till the roots.
Yes,
So
sir.
we are just mistaken that it's not going to the root. It's always, otherwise there cannot be a bucket. And if there is a bucket, that can easily be reduced. These are the difficult buckles to reduce.
Yes,
and
sir.
जिसके लिए pie crusting भी आपको करनी पड़ती है, joint open भी करना पड़ता है, and even then sometimes you are unsuccessful. If it is far interior, it's not going to the back of the posterior, then there's no need to put an additional suture on the posterior one. That is only for those tears which go right up to the root almost, from inside out.
Yes, sir. Nice.
Actually, those are the ones which. Hello. Those are the ones which are actually the bucket handle tears, because they are the ones who are going to displace and lock the knee. The problem is that many of these patients, they present late, because traditionally once they land into the clinics, they just dispose them off, saying that with the locked knee joint which is unable to extend beyond 30 degrees. So that means that there is a meniscus which is locked inside. So it is an emergency, because every time this knee is going to cycle, no matter whatever the limited range of motion is, it's going to destroy the meniscus with every cycle of the motion. And it will convert this meniscus from repairable to irreparable stage. So that is where we lose most of the meniscus, because the biggest decision which I feel while handling these meniscus is this meniscus still repairable? And will I be able to reduce it? You are able to reduce it, fix it back, that is fine. And unless you don't handle do something with the handles of the bucket handle tear, it is never going to be a stable enough fixation. What I tend to do is I put in a stitch and then I cycle my knee through full range of motion just to see how stable it is. So if it is stable, I leave it. I don't put it any extra stitch around the corners. But if it is not stable enough, because no matter you are protecting your meniscus by blocking the range of motion in rehabilitation protocol, but still you need to be sure that whatever limited range of motion this patient is going to have, it is stable in that range of motion. It's not going to fall apart, because as Najat has pointed out, Vicryl does lose its strength, especially in the critical period where this meniscus is trying to heal, and you are trying to push the patient to get more range of motion. So that is a very critical point. You're right that the literature is mentioning that Vicryl is good enough, and it does good, but lately, after having gone through some bad experiences, because you put in a lot of effort to repair this meniscus back, and it is very sad to see this meniscus failing once the patient comes back to you again with the locked meniscus. So I have shifted my practice from Vicryl to the non-absorbable one. But you are right, resources are always going to be a big hurdle.
So, sir, you are not repairing the posterior horn means iatrogenic ramplesion in case of medial side.
No,
If
you
the,
have to.
The meniscal caps, yeah.
No, you have to. You can't leave it. That's what I'm saying.
Yes.
You can't leave it like that.
Okay. Yeah. Okay. Nice.
So very nice presentation by Javed, and some
charges for anesthesia, hospital, and it will cost not less than 20 or 30,000. If you add another 4,000, you will buy a fiber wire. And your technique is excellent, your patient selection is excellent, but you should add fiber wire to it because you are already spending 90%. If you add another 4,000, you will get fiber wire and that will be excellent because meniscus tear is a non-union or sort of non-union. It may heal or not heal. And you already know the principles ABC of meniscus repair, the anatomical reduction, biological augmentation, and compression. So if you just add 4,000, it will not be a big issue. It will not be statistically significant. So very nice presentation, very nice technique.
Thank you so much.
Thank you, Dr. Javed.
Ji sir. Okay, sir.
You can use Ethibond and it will cost you 400 rupees for a single stitch.
Okay, sir. Yeah. Thank you, sir. Thank you, sir.
Thank you, Dr. Javed. We'll move to next talk by Dr. Dilbagh, subacromial impingement. In interest of time, I would request them to be on time, please.
Okay, Bismillahirrahmanirrahim. Now topic we are going to discuss is another very important topic, quite commonly present to the orthopedic and sports surgeon. And the reason for bringing this topic here is that that should be diagnosed properly and managed accordingly. Now, to begin with, what is the subacromial impingement? So, subacromial impingement is basically the condition where the inflamed bursa and or rotator cuff tendon is pinned between the humeral head and the undersurface of the acromion. So, you can see from the the picture that this quite tight space. This is the coracoacromial arch underneath which there is lying the bursa as well as the supraspinatus tendon. Now the term impingement was introduced by Mr. Neer back in 1972, and he defined it accordingly as we already mentioned, that this is basically the compression of the rotator cuff tendon under the acromioclavicular arch anterior 1/3 of the acromion and the coracoacromial ligament plus minus ACJ. Then progression of the syndrome can end up with the formation of the bony spur in the coracoacromial ligament and the undersurface of the acromial, which further tighten the space, leading to the aggravation of the existing symptoms of the patient. Now just a few other definitions are there in the literature, and I have brought here for the for the knowledge of the trainees that there are other terminologies used like subcoracoid impingement. So basically again this is the compression of the soft tissues between the coracoid and the humeral head, particularly the lesser tuberosity of the humeral head in the overhead activities. Another terminology which I have already discussed, that is subacromial impingement syndrome. Basically this is a collective term used for the internal impingement as well as the external impingement. And still other internal impingement is used in isolation. Again this is the impingement of the tissues against the glenoid. Basically this happens inside the shoulder joint. Now how it is happening? So basically impingement is caused by the mechanical irritation of the rotator cuff tendon, resulting particularly in the overhead activities, leading to the hemorrhage, edema formation, and with the tendinitis of the rotator cuff tendons. The most commonly involved tendon is the supraspinatus because this is lying directly under the subacromial space. As we already mentioned that Almighty has put a bursa between the bones and tendons. So again the subacromial bursa, once it is get inflamed, it occupies that space further. It makes the space tighter, leading to the subacromial bursitis, which aggravates the patient's symptoms.
And this is one of the common presentation, particularly in the athletes who are involved with the overhead activities or with the pitching. Now, how the patient present to us? So there is pain and tenderness around the area of the glenohumeral joint. There is pain or weakness with the active abduction, particularly in the mid-range, and patient can complain of the, a painful arc, which is between the 60 and 90 degree of abduction. Moreover, there is further limitation of the internal rotation, which is in comparison to the normal side, and a special test need to perform meticulously to reach to the exact diagnosis, like Hawkins impingement test. And there is still, tenderness around the area we already discussed. Now, etiology of impingement, there are, as we already mentioned, there are external causes and there are internal causes. External again classified into the primary and secondary reasons, while internal is because of the repetitive trauma of the soft tissues, as we mentioned in the repetitive overhead activities. So in the going back to the external reason, in the primary, because it happens because of the outlet obstruction, which end up with the rotator cuff dysfunction. While among the secondary reasons, among the external group, is the instability of the joint, which again end up with the rotator cuff dysfunction. And likewise, internal impingement also end up with the rotator cuff dysfunction because of the constant tendinitis of the supraspinatus tendon. Now, what are the factors, or who are the people who are prone to develop the condition? These are the anatomical abnormalities, particularly you know that there are 3 types of the acromion, and the type 3 acromion, which is actually the hooked one, it's the one which, these are the one who suffer from the condition. Likewise, if a patient has been through a fracture of the acromion and there is formation of the excess amount of the callus, or male union of the acromion can end up again with the narrowing of the space, and it can lead to the subacromial impingement. Similarly, poor scapular control and tear and instability of the shoulder joint, overuse repetitive trauma, instability, and the muscle imbalance can lead to the external impingement of the shoulder joint. Now, in the literature, there are stages of the shoulder impingement syndrome. It doesn't happen over the night, rather it takes decades to develop. So, in the first stage, basically there is the edema and the inflammation, and usually it happens in the younger age group, around 25 and above. And important thing is that this is a reversible condition. So, if patient is able to modify the lifestyle, or if patient is able to come out of the repetitive activity, the disease can be stopped here. But if there is no intervention, or patient keeps on continuing with the same routine, so then there is a good chance that this will shift to stage 2, which is basically fibrosis and tendinitis of the supraspinatus, and usually it happens up to the age of 40 years. So basically patient complains of the pain around the area, and there is sensation of the soft tissue crepitus, and limitation in the range of movement also starts happening, both active and passive. Still further, if we go, so normally beyond 40 years of age, there is the bone spur is formed and tendon gets ruptured. So this is actually terminal stage, and patient can present to us with the inability to abduct the shoulder joint, along with the other symptoms which were there in the stage 1 and 2. Now, how to diagnose these? So particularly it's important for the resident that you are going to thoroughly assess the patient, have to take detailed history. Particularly the nighttime pain is quite, important for in this condition. It happens, and especially when the patient lies down on the affected side, the pain gets worse. Along with that, important, examination of the shoulder joint, other than the look, feel, and move, you have to do a special test. Among the special tests, there are the tests through which we can look whether there is impingement. So, among these, near impingement test is quite famous. Other is the Hawkins test, and third one the cross over impingement. Likewise, the patient need to be assessed for the rotator cuff dysfunction in the same setting also. So all we know that for the
If supraspinatus is the abduction, particularly MTKN position, is checked. For the infraspinatus, external rotation is checked against the resistance, and for subscapularis is the lifting of the arm on the back of the patient. And drop arm is basically is indicative of the full thickness tear of the rotator cuff, particularly supraspinatus. Now, management of the subacromial impingement. So this is one of the conditions in the orthopedic where there are a lot of controversies and there are a lot of the literature available. So if you can get time, you can read it. So we are going to, just present a couple of papers that how the condition is managed throughout the world. So before going into that, debate, what are the treatment objectives? We should know that the aim of our treatment should be that the patient should get pain-free. Patient should be pain-free, and there are no swelling around the shoulder joint. We have to retard the condition, the stage, not to progress from stage 1 to 2 and not from 2 to 3. And same time, we have to advise the patient to strengthen the cuff muscles. Important thing is that the patient should be able to get back his active as well as the passive range of movement. And there should be increase in the strength, endurance, and power of the muscles. So these are our treatment objectives. And patient should be able to have of activities, should be able to perform daily life activities according to his lifestyle. Now, starting with the non-intervention, going into minimal intervention, and then the full intervention. So always there is role of the physiotherapy here. Shoulder strengthening exercises are the one which come first into the action. The patient should be referred to a qualified physiotherapist to let the patient to develop the muscles which control the shoulder girdle. So there are, there are exercises through which there is a strengthening of the posterior complex, pectoralis muscles, internal rotators. Moreover, there are the exercises which are going to develop and strengthen the adductors of the shoulder. Deltoid should be strengthened. External rotator should be strengthened. And last but not least, the medial rotator should be strengthened. Same with the lateral rotators. Now, there are a good amount of the articles who are in favor of physiotherapy. And one of the articles is about the effectiveness of the conservative intervention, including exercise, manual therapy, and the medical management of the adults with shoulder impingement. They conclude that exercise should be considered for the patient with shoulder impingement symptoms. But not only these exercises we have mentioned already, there should be other measures like the manual therapy and laser should be added. Now, if a patient fails with the, physiotherapy alone, then there is the, physiotherapy and the oral medication in form of the NSAIDs. If that fails, then there is the role of the subacromial injection therapy. Now, in the literature, again, we have two types of injections available. One which is common in use is the corticosteroid injection when mixing with the local anesthetic. And the other one is the one which is, more recent one, that is the PRP injection. But again, the literature suggests that there is no significant role of the PRP in comparison to these corticosteroid injection. In other words, they are in favor of corticosteroid injection more in comparison to the PRP injection. Now, following the failure of the conservative measures, physiotherapy and then injection, so you can give up to 3 times injection. We don't want to give more injections, particularly corticosteroid, because they are one of their main side effect is that they can complete the tear from incomplete to full thickness tear, because the steroid, they cause further weakening of the supraspinatus tendon. Then the role of the surgery comes. Now, which surgery and how the surgery should be performed, again, there is literature full on it. And basically we have two options available. One is the open decompression of subequine space, and the other one is the arthroscopic decompression of the subequine space along with the acromioplasty. And as we mentioned already, we are going to embark on surgery only when there is failure of the conservative measures. Now, as we mentioned already, there is, no role of the open over the, there is no particular emphasis or importance or the outcome better of the arthroscope in comparison to the open decompression. So again, article was, and moreover, they studied whether there is role of additional acromioplasty there or not. So again, answer was no. So from this article where they were discussing about the acromioplasty in conjunction with the subchromic decompression, they emphasize on the importance of the physiotherapy. They don't jump to the surgery before exhausting the physiotherapy and the NSAID treatment. Now in the athletes, subacromial decompression, fewer of the, studies are there who are in favor of the subacromial decompression athletes. Another article from the Roy, they state that higher percentage of the satisfactory outcome following subacromial decompression in the non-throwing athletes in comparison to throwing athletes. In other words, they mentioned that in comparison to the, throwing athletes, non-throwing athletes, they get more benefit. Now the last question, whether we should go for the open decompression or for the arthroscopic decompression, again, the literature is there on it, and one of the article in which there was 25-year review of the patient, they were again in favor of the, opinion, they were in favor of opinion that there is no upper hand of the subacromial decompression with the arthroscopy over the open. So in other words, almost outcome of the both is same. Having said that, they emphasize the importance of this arthroscopic decompression, with the advantage is that there is, rehab is quicker, then and it is very good for the stage 2 disease. And if the expertise are available, so arthroscopic should be attempted before the going to the open option. So take home message from this debate is that diagnosis of the subacromial impingement needs detailed patient review and assessment. Treatment should be tailored, keeping in mind the patient activity level, lifestyle, and severity of the disease. Attempts should be made to avoid over-treating a patient with the subacromial impingement. Thanks for your attention.
Any questions from the audience? No. So we'll move forward for the free paper.
Please.
The first paper. Thank you, Dr. Dilbagh.
He wants to ask a question.
Has a question?
What do you mean by placebo surgery?
Sir, I think so. I could not read the article fully, but from the placebo was just the birsectomy and without cutting or shaving the bone. These are just soft tissue.
Sir, placebo surgery is basically the sham surgery. Sham surgery is basically you put the patient well and give the anesthesia, everything as you do in the normal surgery. But then you don't proceed for incision. You just left everything from there on. It is sham surgery, by the way.
Actually, I don't think so. It is ethically acceptable because how you are going to give anesthesia to a patient?
How do you satisfy the patient without any incision that I have done a surgery?
सर इसमें तो ये शैम सर्जरी वो इसका पूरा कंसेंट लिया जाता है बट my knowledge probably incision is given but this is called sham surgery.
I think so. Dr. Nadeem wants to put some input.
Yeah.
I think probably we are confusing. It's not a routine treatment surgery which we
which you suggest for a patient. It is in terms of the research where you are trying to establish whether your one procedure is superior to the other procedure or not. Because many a times for the surgeries like the traditional surgery in the form of bursectomy which was done, there was a long debate whether there is any benefit which the patient gets out of it or not, or whether you can just leave it to the conservative treatment in the form of physiotherapy. Is that going to be enough? It's just like giving a placebo drug to a patient who is presenting with the simple knee pain and giving him some simple basic analgesia to the patient. So probably it's on those lines. You can compare the two treatment options in a proper manner then and say that your procedure was superior.
Okay, thank you, Dr. Dilbag. We'll move further for the free papers. The first paper is by Dr. Shahrukh Ahmed, multi-ligament knee injuries. Shahrukh. हाँ.
Okay, Bismillah Rahman Rahim. Dear colleagues, respected seniors, I am Dr. Shahrukh here, presenting a paper on multiligamentous knee injury treated with our autologous graft, which is our novel technique. This is my institute, Liaquat National Hospital, from where I belong to. So multiligamentous knee injury is a challenging problem in orthopedic surgery, thought to be rare. The incidence of multiligamentous knee injuries reported by Plancher et al. Varied from 38 cases over a time period of 5 years to 14 cases and 2 million admissions over a period of 50 years. Hence, knee dislocation often result in multiligamentous knee injuries, but some multiligamentous knee injuries are not knee dislocations. A knee dislocation is characterized by rupture of both the cruciate ligament with or without associated grade 3 medial or lateral sided injuries. So multiligamentous knee injuries defined as a knee injuries involving the tear of at least 2 of the 4 major ligamental knee structures: anterior cruciate, posterior medial corner, and posterior lateral corner. So the purpose of this study is to evaluate the functional outcome and our surgical technique in a patient with multiligamentous knee injuries. This is a prospective observational study which was conducted in Liaquat National Hospital from January 2017 to 2020, and patients were kept on follow-up on 6 months, 1 year, and 2 years using a lysoform knee score, and data analysis was done using SPSS version 21. So all those patients with having multiligamentous knee injuries, complete tear of ACL, PCL, and MCL and NCL were included, and those having vascular, neurological, or open injuries were excluded from our study. This is a lysoform knee scoring scale system which we were using. This is a schematic representative diagram of a reconstructional procedure. So initially, a diagnostic arthroscopy was done through a lateral infrapatellar portal with the tourniquet inflated to validate our clinical and radiological findings. The surgery for ligamental reconstruction was carried out using autologous graft. We went to anterior medial and anterior lateral portal, and then through that we made posterior lateral and posterior medial portal. For unicruciate ligamental reconstruction, we used to take graft from unilateral knee, that is hamstring graft, semi-T and gracilis, and for bicruciate ligamental injuries or with collateral injuries, we used to take graft from both the knees. And when there is a multi-ligamental knee injuries, we used to take quadriceps tendon graft as well. So in the knee with ACL, PCL, MCL reconstruction, we harvested quadriceps tendon. For contralateral knee and semi-T and gracilis from ipsilateral and quadrilateral knees. Then quadriceps tendon graft was used for ACL reconstruction, and hamstring tendon graft were used for MCL and PCL. This is a arthroscopic image showing a graft passing from posterior tunnel. And then we use a quadriceps tendon graft for ACL reconstruction. And this is a post-operative X-ray. Here you can appreciate an endo button for PCL anchor sutures for MCL, and titanium screws for ACL, and anchor suture for LCL reconstruction. So, when lysome knees 35 patients were enrolled in our studies, and mean age was around 30, and mean BMI was about 21. Surgical duration time for ACL MCL reconstruction was about 150 minutes, and for multiligamentous knee injuries, it was about 240 minutes. And according to KD distribution classification, most of our patients would lie among KD3M. So when the result was compared using a lysome score of 6 months, 1 year, and 2 year follow-up, most of our patients was lie among 90 plus in 1 year follow-up, and 6 patients in 2 years follow-up. And the score was in between 85 to 90 in 26 patients in 2 years follow-up. So according to a lysome score, when 2 ligamentous knee injuries, mostly having a good surgical outcome comparing to the multiligamentous knee injuries, and here you can appreciate a lysome score of more than 91 for ACL and PCL reconstruction. And these are the different studies of multiligamentous injuries, and our study was compared to the other studies, and here you can appreciate that a lysome score decreases with the increase in number of ligamentous injuries. So on conclusions, our complex knee injuries are difficult to treat. Failure to treat all the injured structures of the knee can lead to alter the knee kinematics, and hence the outcome is poor and increased risk of surgical failure. To achieve early rehabilitation, it is recommended to treat all the injured structures in early phases, and our clinical experience suggests that good functional and clinical outcome can be achieved by using an autologous graft for multiligamentous knee injuries. Thank you.
Any questions? No questions. Thank you, Dr. Shahrukh. We'll move to the next paper by Dr. Arsalan. Outcome after massive rotator cuff repair. Dr. Arsalan is here. No. Okay, the next is Dr. Zuhaib. Dr. Zuhaib. No. Again, Dr. Arsalan or Dr. Zuhaib? Not available.
So, as per instruction of Professor Abu Bakr, we shall have some discussion. So, from the extreme expert panelist, how you deal with the multi-ligament knee injuries? Professor Zaid Askar, we have Dr. Jumman, Abu Bakr Saab, Sanaullah Saab, we all are here.
Okay, so if patient present to me within 3 weeks, I will go for single stage. If tissue is viable, I will repair it, and I always augment. Whether MCL, I will repair it primarily, but I will augment with CMT. If it's PCL, I will do it. I do ligament preservation, fiber preservation. I never take out any fibers from PCL. So I will keep the fibers, 95% of the fiber, and I will augment it with a graft. I no more do primary repairs. I will augment with graft, with a thinner graft, so just to have the benefit of primary healing in the primary graft.
So you are early. You will go early. You will going to repair in the early, and it will be single stage, right?
It will be single stage, but always I will do CTA because 10 days back I had a patient who was having multiligamentary, but there was thrombosis of all the arteries.
Yes.
And that landed in knee amputation. So if CTA was not done, it would have been my fault, and then the consequences.
Sir, you want to give any input?
So multiligamentous injury is a disaster to the knee that has happened on the roadside accidents. And 9% of them, they end up with the vascular injuries, and the 3% of them end up with the peroneal nerve injuries. So concomitant injuries, sometimes the whole of the capsule, anterior, posterior, medial, lateral, we are just focusing on the ACL, PCL, posterolateral cord, anterolateral cord. So there is so much damage to the tissues. In younger athletes, young person, I think after your CT angio and etc., the vascular splice and certain a single stage reconstruction is a much better option. The only problem is the tourniquet, etc. You can deflate tourniquet whatever you want and reinflate it for maybe another 30 minutes, and even subsequently you can do it without tourniquet as well if you have exhausted with the tourniquet time. I still believe in the younger people, a single stage reconstruction to get them to give. And sometimes there is associated meniscal injuries as well. And we have just forgotten about that, and the others that should be fixed. If you are expert in that, if you continue for whole of that day for that particular procedure, I think it may be to stage it as a better option.
Thank you very much. Osama, you want to throw light?
Thank you very much, Dr. Kazim. Well, multi-ligament injuries, like just like Dr. Abubakar said, this is disaster. I mean, we need to decide a plan for this. I would always give 6 weeks before.
So you go for delay?
A delay, okay, and then physio shot, and then fix the core
so
first.
You reconstruct or repair?
I reconstruct and repair if there is repairable tissue available. I fix the core first, PCL and ACL, and then I see if I have time, I'll go for MCL, PLCs, and other around the corners.
So you go for 2-stage?
Yeah, 2-stage.
Perfect. So, Javed Saab?
Yeah, my approach is basically 2-stage.
Okay.
First of all, I do intra-articular bicruciate reconstruction simultaneous, and then extra-articular. But sir, my question from the faculty, in case of ACL, PCL, when we do diagnostic round, when we take the graft, prepare the graft, so definitely there is difference in the shoes of the each and every individual, right and left shoes. One is good, one is bad. So when we get a good graft, good diameter graft, good strength graft, that is basically visible to us. So for PCL, that good graft, we should decide the reaming on based upon that, or for ACL. Recalling the anatomy, the diameter of the PCL is bigger, larger than the ACL. So the good quality graft should go for the PCL or for the ACL.
So we're going to take 2 questions at the same time. So KM Shah Saab, you want to throw, sir, give your comments?
I would only say that as already been said by Abu Bakr Saab, it's a disaster.
Yes.
So I would go slow. I would assess, especially the neurovascular bundle, because it is also likely to be injured. And once that has been stabilized, then I would go for.
So you go for delay surgery. Yeah. So thank you very much. Professor Zaid Asghar Saab.
I actually look at the state of the knee joint. So if the knees are sort of swollen and things like that, then I will wait. Otherwise, if the knee is in reasonable shape, then I'll go in and do it. I do everything in one stage.
Single
right?
stage.
Single stage, and the way I do it, that I first, if you are doing, because I've done about up to 3 ligaments, so if I have to take the graft from the other side, so first I take graft from the involved side,
yes, sir.
Take the tourniquet down, then do it on the other side.
Okay.
And then I put the tourniquet up on the affected side and just do the reconstruction. So I'll do everything in the same stage.
Single stage early and reconstruct, right?
Yeah.
Perfect.
Depending upon if the knee is not too much swollen.
Okay, sir. Wasim Saab.
Exactly, I agree with the Zaid Saab. I'm following the same pattern, not less than 3 weeks before, yes, Sanaullah said, but I have no experience before 3 weeks, and I didn't recommend even before 3 weeks. I tried, it's my routine practice initially, my initial practice, I started with the same as 2-stage, but then with the 1-stage, and initially deflate the tourniquet and then do the other things.
You were going to do single stage, early, and reconstruct.
Reconstruct.
Perfect.
But nowadays, I can complete my all reconstruction in a single tourniquet time.
Within 2 hours.
I took the graft first, prepared, and then do all the times the same in 1 tourniquet time.
Thank you very much. Juman Saab.
I think both approaches are fine. So I sometimes usually scope them and deal with the meniscus injury if it is there. Because the scope usually don't give too much time if there is a multiple ligament dislocated knee, so it starts exavasating. So I mean, my primary objective is to deal with any loose body, spondyl injury or meniscal injury at that time, and then do ligament with a staged approach.
So you do stage approach
Yes.
to the multi-ligament,
Most
and you
likely.
early or delay, sir?
Not very early, at least 3 weeks, but I do scope them within a week.
Within a week you
If they
scope
have-
and
yes,
wait.
If the MRI has a meniscal injury,
Okay.
MRI showing meniscal injury.
So
then I
you
wait for
you are
ligament.
going to reconstruct or repair?
Reconstruct, I think usually internal interarticular ligaments are not repairable in these cases.
Yes.
So we do reconstruction but delayed. But if the MRI is showing meniscal injury, I go early with the scope.
Thank you very much. So we are going to take last from Dr. Dilbagh, and then we're going to hand over to you.
Thank you. Single stage, first question. And from the opposite limb, both the hamstring as well as the peroneus longus from the opposite limb. So it will save my tourniquet time on the affected side. And I mean, after drabbing, then we have to raise the tourniquet to, again, you can save your tourniquet time. And within 3 weeks, I mean, it's not very much edematous and not very angry looking. Otherwise, you have to wait for 3 weeks for the condition to settle. Meanwhile, patient has to be in the brace. Thank you.
So in multi-ligament injury, there is one emergency, that is artery, thrombosis or injury. And second urgency, the cartilage and the meniscus. So if there is meniscal tear and you repair it while waiting for the second stage or delayed, meniscus may heal in meanwhile. So there is an emergency, the thrombosis or arterial injury, urgency, the cartilage and meniscus, and then one can do single stage or double stage.
Years back, when there was no MRI only was available, and the clinical examination was the only, and the term was the internal derangement of the knee. Now there is no term internal derangement of the knee over there. One of my class fellow, he had a knee injury, and the knee was opening. The one we know was the Odana who tried the unhappy. So the knee was opening in extension on the medial side. When it opens in extension on the medial side more than 1 centimeter, there is a medial, posteromedial and the ACL injury. It is opening at the hinge of the lateral side. The concept was just repair the ACL or reconstruct the ACL, whatever though are, leave it the posteromedial and the posteromedial ligament. And that he is at my age, his knee is doing fine. Only with the ACL reconstruction, not doing anything with the deep medial and the posteromedial curve. So you can leave it. I mean, he's still at my age of 70, his knee is doing fine.
I think we are already 30 minutes delay, so we'll end up this third session of arthroscopy and move to the fourth session, which will be led by Dr. Javed and its panelist.
Assalamu alaikum. I am Dr. Javed Iqbal. I will moderate this session. For this session, the respected panelists, we have got Dr. Shams Tabrez Saab. Sir is requested to kindly come to the panelist seats. Professor Kamran Bhatt Saab, Dr. Sofyan Saab, and Dr. Nadeem Saab. These are the panelists of this session, and they are requested to come to the seats. So, ji sir. So kindly, sir, come to the dais. Ajay, sir. Yeah. Yes, sir. Zaid sir, Dr. Zaid Askar Saab is requested to come to the chair, please. Dr. Zaid Askar Saab, please. Yes, sir. Ajay, sir. Thank you so much, sir. Kindly have a seat. Thank you, sir. So the first talk we have got primary ACL repair, the way I do it. Dr. Osama Saeed, so he is requested to please be to the dais and start his talk. Dr. Osama.
Thank you very much, Dr. Javed. Can you please put up my slides? Thank you very much for the opportunity and the invitation to come here and speak on primary ACL repair. I would like to just walk you through what we are doing at Faisalabad, a couple of things, a couple of questions. Why do we need to think about repair? Can we repair or not? I have nothing much to disclose, and all our patients have been presented, consented for our data be used for the education purposes. To all my mentors who helped me through my career, who helped me navigate through this day, thanks to all of them who made me understand every single concept of it. Is it a paradigm shift, or is just another option on the board? Can we do it or not? Whether it holds a future or promise or not. So we'll just walk you through all it. So ACL injuries, I mean, all the tier locations, they matter. All ACL tiers are not the same. Their location matters, and there have been a lot of research and evidence going on the location of the tiers. So location of the tier decides what we do with it. Anatomical arthroscopic primary repair of proximal tears. The type of tears you can well appreciate is proximal towards the femoral side, then there are mid-substance, then there are distal one from tibial side. So all the tears, they define their treatment, what we are going to do with it. A very good paper in American Journal of Sports Medicine. They just went through to see the prevalence of the type of tears we see in ACLs. So 43% of the tears, they came back as the proximal tears. So that's where the future holds, and that's where the promise is. So many of us face this thing when we enter the joint and see the ACL stump has been attached to the PCL. So that says something, that it has promise, it has a potential for healing, and it gets attached to the PCL or anything that's available around. So it's the same like MCL proximal tears. So they have a healing potential. What we did at Faisalabad was just to see the outcome of the primary ACL repair, just to reiterate whether we put in the brace or not, and how are the patient-reported outcomes with the primary ACL repairs. Patient selection has been a key factor in this. I personally myself, I just took all the ideal patients who are well informed. I just walked them through what we are taking them through for the first 3 months especially. So isolated tears are definitely the ideal way to go within 3 months of the injury. Location of the tear, I just discussed, the type 1, type 2 Sherman, and then subsynovial femoral-sided proximal tears with the good tissue quality. That is a very important key factor in it. Pediatric population is an ideal candidate for this. BMI, I do consider low BMI. All those patients who are very well aware of their endurance, their balance, their training throughout the rehab, they are going to face after the repair, and their commitment to the process, because I tell them that it's a process, it's not the one-day game. They have to go through all the process for next 6 months, maybe 9 months, and then they decide after the fitness test when they return to sports. Adjuncts to surgery, I use pre-op rehab, I just explained, but they are supposed to do before the procedure, and explaining to the patient is repair, not the reconstruction. If we reconstruct, what they're going to face is repair, what they're going to see. Provide the natural healing environment in the form of serial PRPs, stem cells, BMACs, and microfractures and notchplasties. We take help of all these procedures. They could be adjunct, but they have an evidence for the biological healing have not yet been established the way it should be, but still they help, and there is a growing evidence on it, and we're just hoping to get them one consensus on it. So I just keep a closed follow-up throughout and return to sports in 9 months when the quads ham strength is good and they clear the HOP testing. So the way I proceeded, I just start with the examination and the anesthesia. It really helps elucidate a lot of findings that we are unable to elicit inside the clinic, inside the office, where the muscles are active. When the patient is anesthetized, the muscles are relaxed, so I just proceed with the examination, and it really tells me hidden pathology and just elucidate many things that I may have missed inside the clinic. I just scope it out first, and scoping these injuries first really gives me a way to plan and think and rethink my decisions. And we often get surprises that we are prepared for the ACL injuries, and when we go inside, we see a meniscal tear or any other pathology, even a cartilage injury down there. So we just change our plans accordingly. Just like this tear, we had an ACL. When we went inside, there was an additional bucket handle meniscal tear along with it. So we had to improvise, and we had to repair the meniscus and then address the ACL later on. The type of tools and equipment you need for the repair, the swivel lock, suture anchor, that's what I prefer in my technique. And if you are repairing it with a suspensory fixation, so you need a button and maybe tight rope or flexible or the fixed loop, and a couple of other things with ACL. Jig is there, fiber wires, and there's a suture passage device in any form. I use Scorpion by Arthrex. The way you repair the tendon is like distally to proximal. I repair both the bundles at the same time. If the tissue quality is good, this is the kind of tissue you need to repair. I mean, it just makes sense. Then if you want to repair something, you just need something repairable. If you have repairable tissue inside, so you can just repair it the way I just showed, just distally to proximal, take a couple of bites, and then exit proximally close to the femoral stump. Then finding the right spot has been a challenge. I mean, you just take the knee beyond 90 degrees of flexion, and then just to see the right into the residence ridge and below the anatomical footprint of the ACL, that's where you put an anchor. Then when I put in the anchor, the next question raises is whether the anchor stays inside and what kind of biomechanical strength it has, whether it has a good pull-out strength to go through all the rehab. Then I give gentle tugs to the knee just to see the anchor stays inside, just like in this case. This is how it says the anchor strength. I'm just giving a gentle tug and anchor is not coming out. This means that my repair is stable, repair and robust. It's going to stay inside. The kind of tears I just prefer to repair and consider for saving. It's really important to have these kind of tears in which we have a sufficient reasonable tissue available for the repair. I just put a brace inside coming out from the anchor. I just load the anchor with the fiber tape, just take it down to the tibial stump coming out, and the tibial side you see nicely strong, solid, natural ACL has been saved. On the tibial side, I just put a backup fixation, whether in the form of an endo button or in the form of a suture anchor fixation. You could use any anchor. It could be soft tissue anchor, a knotless anchor in the form of swivel lock or push lock. It's just to provide a seat belt concept, just to provide additional strength, just like we discussed in yesterday's talk, that it really helps taking the loads in early rehabs. Immediately I get explore a shot. If I'm using a suspensory fixation, then I just make sure everything is on place. The endo buttons on the femoral side or on the tibial side, they're well in place. So this is the way to go. That's where I close my case, and I check immediate post-op stability with the interior drawers and the Lackmans, and the knee is quite stable right after the repair. Couple of cases I would like to share with you. The kind of tears you need for the repair is just to see it's nicely bleeding, it's well in 3 months, and then when you do the repair, this is how it looks like, quite steady, solid, back into its footprint. Another one, pre-op, per-op image of the case we did as a primary ACL repair with the brace. He was a national athlete by the Army, and you see ACL has been nicely repaired. And down the line, we went for his second look 6 months after the surgery, and this is how it looked like. You see ACL has been healed, the stump has been really gaining all the arteries and the blood supply. You see it's nicely well in place, and it just looks like a normal ACL. And it's just 6 months down the line. So what are the advantages of saving the natural ACL? You see the blood supply down there. You can never have this in ACL reconstruction. So saving this sheath, saving this blood supply really helps in saving those proprioception mechanism that is like there well in the tibial stump, and it really helps with the balancing in early rehab. ACL repair is least invasive. No bone drilling has been done. Native orientation of the collagen has been restored, and complex biomechanical properties can be restored with it. So early recovery is there, of course. Mechanoreceptor can be saved. It is less painful than the ACL reconstruction. Physical sparing option in the pediatric population. Footprint, you have to save it in the tibial side especially. And the hamstring strength is really excellent as compared to the reconstructions in patients where you are taking the autografts out for the reconstructions. So graft side problems, donor side morbidities, you don't see them in ACL repair. And above all, you have not burned all the bridges. There is always an option of reconstruction if patient goes down the line, has another injury, go back to the sports, and then you can come back for the reconstruction later on. So preserving the native blood supply has its advantage, and it really helps in patients go through the rehab. And rehab is, what I offer is weight bearing as tolerated in the day one. It's no it's now a big deal for the patients went for the repair. There's no brace used inside the rehab, and then advanced rehab is like close-chain exercises for the first 6 weeks, and then we control edema and swelling in the first 6 weeks. 4 months strength training is started, and then 6 months we just start strength training and sports specifics and offer the patients to go through the series of testing that involves acceleration, deceleration, sudden hop testing, and then cutting maneuvers in different ways, whatever the sports is. And then return to sports has been decided in the non-contact sports at 9 months and the contact sports for somewhere around the 12 months. But every patient is different. Athletes, they have different endurance, stamina, agility. So what we offer them, I supervise all the rehab, especially in the first few cases. This is one of the national athletes, and he is a sprinter, 400-meter champion. I went for the repair, I offered him the procedure, I explained everything what we are going to do. The commitment and the promise was his compliance should be excellent, and he's been sending me videos since that day, so I supervise what he's doing, what exercises he should do, what he should not do. And that's where 9 months down the line he came back to me and offered him and hop testing. That's what we prefer before clearing all the athletes back in the game. So it's single leg, triple leg, zigzag, all the leg hop testing. You see the balance, you see how he's performing after the repair, and he's performing exceptionally well. And I see very less patients like this in ACL reconstructions. This is him 12 months post-op. You see the balance, you see the agility, you see he's back on track with the same spirit and potential just because no autograft has been harvested. The hamstring strength has been excellent, quads doing very well. So all these things work well. Just to this day he get back to the sport. Another patient who's a local club level player is 1 year down the line. I'm assessing him after 1 year. So excellent strength. Then when we cleared him for the activity, another patient who's a doctor by profession, I offered him the procedure and just well explained everything what we are going through and what complications we could face down the line. And he agreed with it, and then he's performing really well. He's went back to his sports and his hiking and everything. His knee has been excellent without any sign of even micro instability. So we followed all these patients with their MRIs. You see the MRI is 1 year follow-up. You see down there, the ACL is right, vertical, just parallel to the Bellman-Sass line, well in place, vertical, no indirect signs of instability. And right there, the ACL stump is there. You see the anchor in place. It's a single anchor technique. ACL has been restored. It's healed. It's right there. So knee looks perfectly fine. Another one we followed with the MRI. It's 24 months follow-up. It's been doing this MRI so far. Another one, 24 months, 2 years follow-up. You see another section in coronal sagittal planes. ACL has been restored, his anatomy, his tension, and there's no signs of laxities.
This has streamlined process has reduced the burden on practically more and more consideration.
So there's growing evidence on it that all the ACL surgeons, they must be familiar with all the techniques we are performing in today's world. It could be primary ACL repair, it could be augmentation, the way we do it, just like we discussed yesterday. It could be synthetic augmentation. It could be an augmentation in the form of adding an extra-articular procedure with it. And down the line, there is an option of ACL reconstruction, and always. So growing evidence, just recently, consensus signed by 28 surgeons from 11 nations. So it's growing, it's gaining attention. There are a lot of evidence coming out in the literature, and we are just hoping that someday it could be, hoping for all the athletes who want to perform at the optimal level and who don't want to go for an invasive and aggressive surgery like ACL reconstructions. And maybe down the line, 10 years, 20 years, people would think about us that we were very aggressive surgeons, but not saving the natural ACLs and not saving the natural ligaments that had the healing potential. So, and the consensus is whatever we do with the reconstructions and anything, there is very few hope that it could be anatomical. Despite all the debates we have and discussions we have, an anatomical ACL reconstruction has been a challenge. So, in my opinion, there is no anatomical ACL than your natural ACL. So, we should make every effort to save it. Thank you.
Nice talk, Dr. Osama. Any question?
Yes, please, Dr. Dilbagh.
Thank you so much for your very nice presentation. Just one question. One of the patients you mentioned at 6 month follow-up, you did arthroscopy.
Yeah.
What was the indication that time?
Yeah, that's a great question, actually. He went down the training. He was an army athlete, and he had, during the training, when he went to the camp, he had another problem during his running and training, all that. And when we assessed him, there's sounded like a meniscal tear, which was a grade 2 in my opinion. And when we went down inside, there was a grade 3 tear of medial meniscus. We repaired it, and then we had a look on the ACL repair that we repaired 6 months ago. So he was doing perfectly fine, and that's what I showed.
Thank you. The reason for my question was because normally we don't do repeat.
Exactly. Yeah.
Arthroscopy just to see, because clinical examination is enough.
Exactly.
Thank
exactly,
you.
Yes.
Any
I
question?
think, yes, sorry. A very valid point brought on by Dr. Dilbagh. I was just wondering, it's a wonderful presentation, Osama, and a very valid point highlighted that once you can save the natural ACL, you should save it. You should not just shave it off, throw it in the bin and reconstruct it straight away. But the challenge which we face that these patients normally don't present very early. By the time they present, everything is already gone. So there is a very few patients you will be able to, but once you are putting in the scope into a patient with the intention, you must think for a while, can I repair it? Yeah. And if you can repair it, you should go ahead with the repair. Just a follow-up question on that. When do you decide? Because many a times these ACLs, they don't rupture or avulse from their footprints. They normally go in the mid-substance, and it is quite challenging to repair them once there is a mid-substance rupture. And one thinks that should I augment it at the same time or not? So when do you decide that this is the time to augment it in addition to repairing it back?
That's a great thought, actually. Sometimes I just see the tear is proximal, and the player what I'm treating is not having a non-contact sports and having good muscle control, went through the pre-op physiotherapy, and we're conducting a study on it as well. Some repair we did without the brace, and they're doing perfectly fine. Just like an athlete I showed you, he's running on the track, no brace was used in that athlete. It's all about selecting the right patient who can give you confidence in the rehab. Second, the tear location should be excellent. It should be proximal, as close to the femoral footprint as possible. And then in the mid-substance, I don't repair those tears. They're actually practically not repairable. And then adding the brace is all the athletes who are elite, who are performing cutting sports, who are high risk, and then who are involved in the cutting, like contact sports, just like in Faisalabad, we have a lot of kabaddi players, and all those players, I add brace in it.
Yes. Another point which one must think while dealing with these ruptures is that ACL, we know that is the innermost structure in the knee joint. So there is hardly any patient which you will find with an isolated tear of the ACL. There is always damage to the associated structures first till the time force reaches to the ACL and then damages it. So one must look for it, search for it, examine it, evaluate it, and then decide whether it is only going to be the ACL handling which is going to benefit this patient, or is there something else which we are missing, which might fail our hard work which we are doing in it.
Exactly. Sometimes you have a partial or grade 1 or 2 MCLs which I don't repair or deal with. We just put in a brace and they just heal out pretty well in first 3 months. So you need to make sure that other structures around the knee, especially posterolateral corner, around the endomedial corner, everything is intact before using bark on the ACL repair.
Any question? So,
thank you very much.
Nice talk, Dr. Osama. The next presenter is Dr. Sanaullah. So he is requested to go to the dais and to present his talk.
Bismillah ar-Rahman ar-Rahim. There was so much discussion on preservation. So it's also, my talk is on preservation of both bone and soft tissue. My name is Dr. Sanaullah. I'm working as assistant professor in RMI, basically sports surgeon. So anterior cruciate ligament is the commonest surgery in knee joint. And all inside ACL is nothing but, instead of tunnels, we have sockets. Sockets, like we can say that the tunnels are longer and the sockets are shorter. And fixation on both sides is adjustable, that is the buttons. So anterior cruciate ligament is one of the, again there are a few advantages. There is no screw and there is bone preservation and sockets. So if we compare with standard or conventional ACL reconstruction, the differences are, here we use a single tendon, here we use sockets instead of tunnels. On both sides, we use suspensory fixation. We all know that there are two types of fixation, the aperture fixation and the suspensory. So here we use the suspensory fixation on both sides. And ideal for skeletally immature patient, because yesterday in Dr. Zaidaskar's talk, screw fixation is not possible and conventional ACL is not possible in skeletally immature patients if we are doing it ideally. And although it's technically difficult, but the results are good. And it's also a bit costly as compared to the standard. So graft is usually the semi-T is enough, and length of the semi-T should be from 240 to 280. And in my patient population, the quadrupled length of the graft is usually 6.8 plus minus 1 or 2 mm. And the diameter usually is 9 plus minus 1. So in a bulky patient, it might reach to 10 mm. In a thinner patient or a female, it might be 8 mm. So the diameter ideally should be 9 mm and the length should be 6.8 mm. It's a bit tricky and precise as compared to the traditional ACL reconstruction. Graft preparation is extremely technical in this method of ACL reconstruction because it should be stronger. And I usually take 4 stages, 4 points of fixation. The graft should be extremely tight and compact. So if someone wants to know the technique, I have mentioned, I have copied an article. So it's a bone preserving, and if it's bone preserving, the periosteum is not violated, so less pain post-op, you will see less pain and less bone marrow edema in all inside ACL reconstruction as compared to the traditional. So less bone, it's bone preserving and less violation to the periosteum and less edema to the bone post-operatively and less pain. So outside and femoral tunnel has its own advantages. Although I use traditional drilling for all inside, but there are few advantages of outside and femoral tunnel using. And these are very important. It's more anatomic, like you don't need to flex it to 120 degree. So in a normal, you can see from anteromedial portal quite nicely and clearly. You don't need to flex it to 120 degree. So in 90 degree of flexion, you can do it, and as you have the jig, as we do in the table, so the target is usually perfect. And it's more anatomic, no accessory medial portal is required, no hyperflexion is required. During hyperflexion, we usually have fat, so that will take another 5 to 10 minutes to remove the fat pad to see the tunnel and the reamer perfectly. The posterior blow white is less common and there is no short tunnels. So again, the adjustable loop burdens, I have find an article, the fixation and the outcomes are comparable. The strength of the loop, adjustable loops and screw are comparable. And dual suspensory fixation is an animal study which shows that the healing is more in all inside ACL reconstruction as compared to the traditional. So in screw fixation, the healing is slow as compared to the all inside in this study animal model. Suspensory versus interference screw reconstruction has again another study which shows biomechanical strength, biomechanical advantage over traditional. Screw has its own disadvantages. Like screw should be fixed to the near cortex or to the far cortex. Screw also has in spongy bone or osteoporotic bone, screw may skive or there may be divergence, and we may not properly fix the both ends of the graft. Again, complication of screw are quite common. Infection, aseptic loosening are also common, and guide wire related issues are common. While fixing femoral tunnel, graft in femoral tunnel, the guide wire will break many times. I have seen many broken wires. In my case, I was using screw or femoral tunnel, so I have just shifted my practice towards all inside. Special circumstances will all inside ACL can be advantageous is multi-ligament injury in skeletally immature patients. So the skeletally immature patient here, you can see that the tunnel drilling in the femur will not be possible in traditional way. It should be done from outside, and so it's one advantage. Technical difficulties which we see in all inside ACL are graft link preparation is very precise. It should be, I spend a lot of time in graft preparation. And if it's stronger, you don't need any internal brace. It's time consuming, flip cutter is expensive, graft passage is usually technical. If we are doing traditional all inside ACL, the graft will pass from AM bundle rather than from tibia. And I always look at the button while setting on the cortex because it may travel through the tibial tunnel and you would have to repeat all the process. So we can tie another knot on the femoral as well as the tibial side while fixing the graft. So these are the results, and all are in favor of all inside ACL reconstruction: decreased pain, less bone violation, less periostral stripping, good healing in the tunnels, and all are in favor of all inside ACL. So why all inside ACL reconstruction? Create socket rather than tunnels, less bone removal, less of windshield wiper effect. When the graft is longer, it will move like this. The horizontal movement is called windshield wiper effect. And the bungee cord phenomena is when it moves along its length. So it's bungee cord phenomenon. Both are common if we have a longer graft, just like in traditional ACL reconstruction. Symmetry is enough, so less morbidity. We just keep rest of the flexors intact. Small graft length are acceptable, less functional deficit because flexion is never affected if we take only one symmetry, one hamstring. Less postoperative pain, already discussed. Soft bones. In soft bones, sometimes number 12, even 12 screw might be loose. I have seen it previously in patients, female patients, or patient having osteoporosis. So in that case, all inside might be a blessing. Can cinch again after tensioning. We can tension again and again on femoral as well as tibial side. So how I do all inside ACL reconstruction. So this was the first all inside ACL reconstruction according to the company. The Arthrex, it was done in 2019. We waited a lot for the flip cutter, almost a year, and then the graft link was prepared. And this is the retro reamer or flip cutter I used in my first all inside ACL. Although I have changed it, but it was the first, and the blue marking is at 15 and the green is at 20 So it's from joint towards the tibia. This is the first all inside ACL reconstruction which I did, and I used traditional buttons on both sides. So I have shifted my practice a little. I use the traditional reaming, and I have added an attachable button system on the tibial side, and I used the Arthrex non-button adjustable loop. And you can see the graft, there are 4 points of fixation. So graft should be extremely tight, and it should be, every stitch should be stronger. So it's the picture. I use ABS. We can aid internal brace if we want, and I always see the femoral tunnel while pulling my button. So I don't need marking, fluoro, or shaving of the lateral gutter. It's under vision, and I do it with comfort. This is tibial sided scoping. When I pull the graft, I examine the tibial side, and I make it sure that there is some bridge, bony bridge. When I was doing in start, the graft was longer than the tunnel, and the graft was lying outside the tibial cortex. So I had to use screw in that case. So the graft should be at least 15 shorter than the femoral tunnel, the intra-articular length, and the tibial tunnel. It's very important. And the key in all inside ACL is stronger graft. It should be very stronger. So recent advances are we can add PRP, stem cells, bone marrow aspirate or things like that to board the tunnels and then drag the graft inside, and it might increase healing or enhance healing. Thank you.
Any question from the audience?
Do you do ACL reconstruction in osteoporotic patients? Mean above 60 years of age? You said osteoporotic patient, we don't have a good purchase.
Actually, that was multi-ligament knee injury. The patient had a failed previous ACL reconstruction, and if a patient have failed previous ACL reconstruction, he will not use that side. So that might affect his bone mineral density, and in that case, I had very poor bone quality in that patient. So it was most probably a female with multi-ligament knee injury. Female in 40 age might have the same bone quality as a 60 years male have in some cases.
All the inflammatory disease patients like rheumatoid, others, all have the poor quality bone,
Yes,
even
sir.
at the younger age group. If they need this, the screw is a bad option. Okay, that is at younger age group. Otherwise, the osteoporosis is basically an older age group. This is a very good presentation, and I think the concept of the sockets is from your ACL avulsions on both sides. They are the sockets, you put them back. They are the sockets, you put them down. The whole of your strength is on the strong ACL, which you have reconstructed out of SAMI-T. So, if you pull them on both sides with a adjustable button, they have a little movement in those sockets as well when you go through the range of movement of the knee. Is there any subsequent laxity available after 6 months? The failures of the grafts? You have not mentioned in this.
Sir, actually in the start, I used to just tighten it from the tibial side. But with passage of time and with the advent of tightrope 2, it's so much stronger that residual laxity is quite low. In the start, when I was using tightrope 1, there was residual laxity because creep in all button is more than 2 or 3 mm if we compare different companies. So I emphasized on stronger graft, and I believe that there should be press fit graft in all the tunnels above and below. I think I had failure of endo buttons more than 7 or 8 in my hand when I was using Arthrex tightrope 1, but in tightrope 2 is too strong and I can drag it, and I usually always focus on press fit in both the tunnels. So the tightrope 2 is the game changer in my case, and I always emphasize on press fit, and there is less windshield wiper effect and bungee cord phenomena when I use press fit fixation.
These injections of PRP at etc. and stem cells harvested from here and there, still the literature is quiescent about their very, very conclusive evidence about the augmentation of any repair, even the cartilage regenerations. If we're injecting in the tunnels the PRP, you are injecting into a tunnel or a socket which is rich in the cancellous bone, which is again a source of PRP. If you want to inject how much out of that, what is the fun of which a tight your ACL into the socket and another PRP into that? Well, that is absorbed, resorbed, extruded out, and what does the role of PRP scientifically? Can you explain it?
Dear sir, I agree with you. These are the recent advances, but I do not agree with their concept. Because when I put my scope in the tibial tunnel, dear sir, when I put my scope in the tibial tunnel, it's extremely pinkish because the bleeding in the tibial tunnel is different as compared to the femoral tunnel. While scoping, if you see the femoral tunnel, there will be no bleeding. It will be whitish. And if you compare it with tibial side, it will have lot of bleeding. So I do not agree with the recent advents. I just used my graft, and I do not believe on the foreign bodies like internal breast because I believe on graft. It should be stronger, extremely stronger. No, I don't use PRP because it will wash out. I agree. I agree with you. Yeah.
But speaking about the mode of action, I think you have a point. these growth factors, the stem cell, they have an anabolic effect, and they would strengthen the graft also to some extent. Naturally, the research is still going on, and it might take 5 or 10 years, and like many concepts which were initially frowned at, probably stem cell would also become part and parcel of our armamentarium. So there's no harm in working at it and probably finding out how it works and establish more clinical applications. I have seen it works. I do it with my arthroscopies where the patient has refused TKRs, and it does lead to reformation of the joint space, and the Lasham scores, they improve, the function improves, and these are old patients who cannot sometimes afford the expensive surgery. So yes, you are right, maybe we should consider it.
You are right, and there is some evidence, but not a conclusive evidence. If somebody needs joint replacement surgery, and you have your X-rays, the weight-bearing X-rays, it is a stage 4 disease, and when you go for the MRI, it's not a weight-bearing MRI, it is just a relaxing patient MRI, giving you a significant space on the medial side, which is, if you don't have the weight-bearing X-rays, you may have a space. Regeneration of the cartilage to its entirety that fulfills the demand of a joint is still a dream. It's still a dream.
Yeah. Dr. Nadeem, you want to add something to the topic?
I think probably in front of the senior sitting on my right and left, there is hardly anything to add, to be very frank. But every surgeon who is doing the ACL is always worried that if there is anything which I can add to make my surgery successful, and after you follow many of these patients in your clinics where you have done all the good, but still at 4, 5, 6 months, no matter what you have done, you see that there is still something which is not right. So probably that is where these things come into play, and you think that why not to add something more, although not proven, but let us work it on our setup. But I agree with sir that definitely it's going to wash away, or how much it is going to stay, and how much is the conclusive evidence. As the literature evolves, everything would come with more robust evidence. I was just wondering, once you were mentioning your all inside ACL, so we understood that you meant on femoral side you are using a flip cutter to cut the tunnel and make it all inside from the femoral side. Do you cut your tunnel on the tibial side with the flip cutter as well? Because that is only what it make it all inside. Otherwise, it will be still half all inside and half outside, and a hybrid type of.
Exactly. I always use traditional drilling for the femoral. For tibial, I use flip cutter because sometimes there is difference of 1 mm on tibial and femoral side.
Because you need to match it with the computerized precision to use it all inside ACL if you're using the flip cutter on both the sides.
Exactly.
And that is very, 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 very challenging to cut it so precisely and quadruple it so precisely that all of it is going to stay inside.
Exactly.
But I think you're right. If you use the endo loop on both the sides, you can have a better access to stretch it further inside the tunnels even after you have cycled it, and try to remove as much creep as possible.
Exactly.
Any question? Okay. So nice talk, Dr. Sanaullah. Was a wonderful, nice, rather extremely dynamic talk. So the next presenter is Dr. Amir Sohail, and he will talk about arthroscopic shoulder stabilization. Dr. Amir Sohail Saab. So now we will move to the free papers. The first paper is the clinical and functional outcome of traumatic osteochondral fracture in adolescent patella, and the presenter is Dr. Sobia Aziz. Yes, please go to the dais and present your talk, your paper.
Assalamu alaikum. I'm Dr. Sobia Aziz and I'm resident orthopedics from Liaquat National Hospital, and I'll be presenting this article, Clinical and Functional Outcome of Traumatic Osteochondral Fractures in Adolescent Patella. So osteochondral fractures, they are quite infrequent and they present to us with two mechanisms. First is direct shear due to patellar dislocation, and second is indirect shear of the tibial plateau by the twisting of the knee. So adolescents are particularly predisposed to this osteochondral fractures because of generalized ligament laxity and reduced biomechanical stress. So the most common site of osteochondral fracture is the medial facet of patella, the second most common being the central facet, and the third being the lateral femoral condyle. So surgical fixation has been proposed if the fracture fragment is partially or totally detached, or the fracture is in the patellofemoral zone, or the size is greater than 1 centimeter square, because if we try to fix the fractures which are less than 1 centimeter square, they are prone to break down. So poor prognosis is seen if the fracture fragment size is less than 1.2 millimeters, which I already told that it would be prone to break down, if it is a chondral fragment, or in younger age group with open physis. So in patients with poor prognostic groups and those with symptoms are the ideal patients for surgical management. So in our study, we used headless metal screw, which are also known as Herbert screw. So it provides excellent strength and compression across the fracture fragment, the only downside being the need of removal of implant. So it was a prospective study from 2019 to 2021, which was done in Liaquat National Hospital. So our exclusion criteria was patient who had history of prior dislocation of the knee, any prior knee surgery, or had any congenital knee problems, or were of Clanton class 1, which is depressed osteochondral fracture, or class 2, which is osteochondral fracture which was attached by osseous bridge. So the only fractures which we surgically managed was either detached, non-displaced, or displaced fragment with symptoms. So procedure was like, first diagnostic arthroscopy was done, followed by open reduction and internal fixation. So medial parapatellar approach was used. 11 patients had complete separation of the fragment, while in 3 patients the fragment was still partially attached. So fracture fragments was removed and the defect was seen, which was filled by irregular fibrous tissue, and then which was drilled to expose the bleeding bone, and fracture was then fixed with the Herbert screw. So in our study population, there were 12 males and 2 females. Mean age was 16 years. There were 9 left knees and 5 right knees, and the average fragment size was 2.58 centimeters square. Fixation technique was ORIF using Herbert screw, and the average time from symptom to the surgical fixation was 5 weeks. So as you can appreciate, there is osteochondral fracture which was seen, which was then fixed with 4 Herbert screws. These are the post-operative x-rays showing 4 Herbert screws in situ, AP and lateral view. So this is the arthroscopic image which shows Herbert screws being placed. So this is another case in which this was the osteochondral fragment. And first we've kept the fracture in place using the K wires, and then 3 Herbert screws were placed. This is the lateral x-ray showing lateral view of knee, showing 3 Herbert screws in place. So on 1 year follow-up, there was no difference in range of motion, thigh girth, or tenderness on palpation, and our satisfaction score was 86%. So IKDC score was the which we calculated. So pre-operative score was 47.6, the mean score, whereas on 1 year follow-up it was 88.6, which was statistically significant with p-value of less than 0.05. So conclusion was that study shows excellent outcomes can be achieved with the use of Herbert screw in osteochondral fracture fragment fixation. So these injuries should be treated as acute fractures requiring urgent imaging and then early fixation. Diagnosis of osteochondral fractures is crucial, as failure to diagnose these fractures may lead to early degenerative changes, osteoarthritis. So there were certain limitations. First, as it was not a comparative study, so we could not compare the outcomes, but as we only used headless screws, and there are other methods as well, like suture fixation or bioabsorbable screw. So we did not compare, we only used Herbert screws. Selection bias can be seen, and in our study, the sample size was relatively small of only 14 patients. So obviously we need a larger sample size to get better results and outcomes. Thank you.
Nice talk, Dr. Sobia. Any question from the audience, please?
One little query, and thanks, Sobia, for excellent presentation. You were talking about some arthroscopic images after the surgery. How did you do that? After fixing the fracture openly, then did you guys resort to do an arthroscopic kind of thing?
Yes, sir. First, we did arthroscopic. We first see the fracture fragment through arthroscopy, and then we open it, and then we take out the fracture fragment.
Okay, well,
so sorry.
I was thinking that you were showing
Yes.
the screw. So did you do any arthroscopy after the procedure as well?
Yeah, this was the case where we could not see when we put the screw inside. We could not see the screw inside. So we just like kept the arthroscope to see the inside of the screw. So that is what the images show.
Okay, and the other thing is that, it would be wonderful if you could present or if you could show us, the audience, some post-op x-rays, maybe a year later. The x-rays that you've shown were just kind of
Yeah,
post-op
it was
in it.
post-operative,
And to
yeah.
me, like those screws a little bit prominent, and I was scratching my head that they may be kind of, I'm not sure that how they would be behaving with the femoral side in the groove, the patellar
Yes,
groove.
yeah.
So I would be very keen to see those x-rays.
Yeah,
Thank
I
you.
would make sure to do. Thank you, sir.
Any question? So thank you so much. The next paper is roll-up stem cell in the treatment of osteoarthritis, and the presenter is Dr. Muhammad Mustafa. So please be to the dais.
Okay, Assalamu alaikum. My name is Dr. Muhammad Mustafa, and I am a resident of Liaquat National Hospital. So I'll be presenting on my research article, Role of Stem Cells in the Management of Osteoarthritis, a review of literature that I did. So we all know that osteoarthritis causes joint pain, which results in inability to function and subsequent disability. It is associated with certain characteristic features like loss of articular cartilage, hypertrophy of the synovial membrane and the joint capsule, and degeneration of the ligaments, as we can see over here in this diagrammatic picture. So primary treatment of osteoarthritis, obviously it initially involves exercises, weight reduction, analgesics, non-invasive therapies, which have been investigated like PRP, hyaluronic acid injections, and glucosamine, and eventually resulting in operative treatment for which we have total knee replacement. However, it is associated with significant morbidities in itself. For instance, continuous post-operative pain, pulmonary embolism, infections, and eventually even deaths in 2% of the patients. So there is a significant health and financial impact of osteoarthritis, which has made it a liability and helped us in researching further mechanisms, modes of interventions, which will eventually help us in treating this particular disease. So a German pathologist, he actually devised this bone marrow derived cells, and he found that these cells could migrate through the bloodstream and go to distant sites of injury and participate in tissue regeneration. And these pluripotent cells have the capability of dividing into several cell lines. So mesenchymal stem cells are known to their ease in extracting and safety profile and ability to differentiate into chondral tissue. And these can be isolated from the bone marrow aspirates or the adipose tissue, and then can be used in the form of injection in different joints for degenerative conditions. However, The issue is that this aspect of stem cells is still being discussed and still open to discussion for further efficacy, for further data being studied to study its efficacy. So this diagram basically tells us the role of stem cells, how it's being injected, and then so inflammatory cytokines are present within the joint, and so injecting the mesenchymal stem cells results in cartilage progenitors being evolved, and eventually resulting in healing, homeostasis, and immunomodulation with the help of these stem cells. So many case series have been identified which do point towards acceptable results of mesenchymal stem cells in patients with cartilage damage. So what we did was that we did a literature search to evaluate the efficacy of mesenchymal stem cells injection. The current review, it included studies until July 2022, and we searched multiple databases, Cochrane, PubMed, Embase, and we studied a couple of logic terms like stem cell therapy and randomized controlled trials. Our inclusion criteria included randomized controlled trials in particular, and studies in patients with osteoarthritis, human studies, and exclusion criteria included all the non-human studies. So what was the outcome measure? What were we looking for? We were actually looking for effectiveness of pain management and functional improvement by applying stem cell therapy. And outcomes were assessed via visual analog scale, ICRS score, Lissom score, and Lequesne index. So initially, 152 articles were identified, and after removing the duplicates and all the articles which were excluded by our exclusion criteria, we eventually studied 12 articles. So in all of these articles, the mean age of the patients were about 53 years of age. 5 of these studies compared mesenchymal stem cells and placebo, and included other associated interventions like arthroscopic debridements, hyaluronic acid, platelet plasma, rehabilitation programs. Some studies, for instance, 2 studies compared hyaluronic acid and mesenchymal stem cells, and primarily the mesenchymal stem cells in all of these studies were derived from the bone marrow. So this is basically a summary of some of the important studies that we studied. The yellow ones highlighted show these are the high quality studies, and as you can see, the source of mesenchymal stem cells in primarily all of them were either from the bone marrow or the adipose tissue, and they were either, the study group would either include arthroscopy plus mesenchymal stem cells, or only mesenchymal stem cells, and compare it with multiple other interventions like arthroscopic debridement and PRP or hyaluronic acid alone. So when we studied the outcomes on pain, we evaluated that using visual analog score, and it showed us that either alone or in combination with other interventions, it did have an impact, the stem cells did have an impact on pain in osteoarthritis. However, this was not quite significant, and when the low quality studies were removed, we came up with the answer that yes, it does result in significant score. However, we could not come to the conclusion that stem cells is as effective as it should be in reducing pain. When we talk about function, again, similarly, when high quality studies were removed from our results, we came to the conclusion that functional outcomes were not significantly improved in patients who were receiving stem cells as compared to the patients in the control group. So, and at the 6 months post-injection, there weren't any significant differences between the control group and the experimental groups. So what is the conclusion that we come to? So as this was a literature review, primarily the clinical trials, they are the basic ultimate research in real patients, and they are the ones which help us in either confirming or refuting the value of multipotent stem cells. In recent years, a series of clinical trials have come into practice, and that is what we went through. However, they are limited in number, and so the effect of MSCs has still not been quite conclusive. So in all, our review included 12 RCTs, which fulfilled the inclusion criteria, and 6 studies used visual analog score for the evaluation of pain. However, no significant definite benefit was demonstrated of pain relief at the last follow-up. And again, as I mentioned, when the low-quality studies were removed, the results of the remaining high-quality studies found that mesenchymal stem cells did improve levels of self-reported pain. So we cannot clearly say that mesenchymal stem cells do have an impact on pain. When we talk about function, again, significant positive impact of mesenchymal stem cells was observed compared with the control group, but it isn't again a significant positive impact at 6 months post-injection when compared with the control group. So when compared to the hyaluronic acid, we studied 4 different studies, and one study reported visual analog score showed a non-significant effect regarding pain reduction with the use of mesenchymal stem cells. And comparison of the Liquin index in 2 studies showed that mesenchymal stem cells were more effective than hyaluronic acid post-injection. So in conclusion, this current evidence shows and points out that there could be a potential significant effect of mesenchymal stem cells injection on pain in osteoarthritis patients. There may also be a potential benefit on physical function as well on patients with osteoarthritis of the mesenchymal stem cells. However, the evidence is quite weak, and as the quality of the majority of the studies was low, and patient-reported outcomes are not completely reported, and the sample sizes are really very small, with the highest sample size being 72 in one study. So what were the weaknesses of the study? It is the limitation is that it is just a review, and the findings are just based on an observation on evidence which is already present. So it increases the risk of bias, obviously, and majority of the studies being low quality. And moreover, the number of studies is still limited in this literature search, with just 12 studies being identified. So we need more sample sizes, more studies for that. So what is the recommendation out of this study? That we need further large-scale sample size studies and high-quality RCTs with proper measures to protect against biases, and which will help us in identifying outcomes based on patients' pain and functional outcomes to confirm the role of mesenchymal stem cells as an injectable therapy for osteoarthritis patients. Thank you.
Any question, please?
Mustafa, that was an excellent talk, and that was since the start of this conference. I've been kind of pushing against the PRP and stuff because we have done these things quite a few years back. The we have bought for the PRP is dusted. It is part in one of the corridors, so we haven't been using. This was the new thing that still was coming in, and it was shown that it is not as effective as the pharma company they are kind of talking about. The other thing is that meta-analysis and systemic review, they are the strongest of the literature. So that was not your weak point. That was the strongest point. That is if you see the ladder of the research strength, they are at the top. So this was a very strong evidence, not a weak evidence. My second point was that you mentioned that 2% mortality in total knee replacement. I'm wondering where is 2% mortality in the face of earth, and if somebody is with 2% mortality, they shouldn't be replacing the knees. It's like you are going on a death penalty to that center if you are dying. 2% people are dying.
So the thing is that eventually related to all the complications. 2% is something which I picked up from the literature itself. And nothing, I wouldn't.
Well, the mortality of morbidity obviously is more, but mortality, I won't replace my knee if I'm dying. My chance of dying is 2%. Anyway, thanks very much. Well done.
Thank you.
Well done. Well done.
Thank you.
Very good comparative study. In fact, the negative points are the more positive, and they are the strength of those studies. We are heading toward the regenerative medicine, regenerating the cells from the stem cells to the regenerating the organs like bone and the growing the cartilage. Eventually, we will be heading toward organogenesis in the lab and replacement of that. Will it be to that extent? We hope we are going toward that. But right now, the stem cells, the PRP, I strongly believe in that. There may be some anti-inflammatory and pain-killing effect in those particular situations, particularly with the degenerative arthritis, for which your study is being referred. It's not more than that. You may inject, कोई आके आपको कहती है बीबी के मेरी बहन को आराम आ गया तो मुझे भी कर दें, आप उसको भी कर दो. दूसरी आके कहती है मेरी बहन को आराम नहीं आया था तो आप कहते हैं आप ना करवाओ. लेकिन एक बेनिफिट इसमें बहुत ज़्यादा है. वो मरीज आके कहता है डॉक्टर को, डॉक्टर साहब फ़ायदा नहीं हुआ, डॉक्टर साहब फ़ायदा नहीं हुआ. कहता है बीबी मैं बार बार कहता हूँ फ़ायदा हुआ है, मुझे फ़ायदा हुआ है. सो द फ़ायदा तो है किसी न किसी तरह. द कंक्लूसिव एविडेंस अभी तक वही है. And yes, the things come out of your errors, hate and trials, and the experiences, particularly based on scientific evidence. So go with the scientific evidence and move forward. Good study, a comparative one.
Thank you.
Yes, Osama, I think you brought a very pertinent. Mustafa. So you brought a very pertinent topic to present. Just 2-3 comments on your presentation. I was just wondering that what was your study timeline, from which era to which era you
It was from 2010 until July 2022.
So you study around 12
years of articles.
Evidence.
Yes.
And was it all English literature you were searching?
All English literature, nothing.
Because you probably did not mention, or probably I did not focus on that portion.
Yeah, all English text, all English text words, all the non-English literature was excluded from these.
Excluded. And what was your aim once you were trying to evaluate the literature? What was your specific query in your mind once you were trying to go through it?
My exact query was that whether this whole notion of these interventions that we are performing, the non-invasive interventions, so stem cells, so basically the primary idea was to come up with something for a journal, basically a surgical conference which was being held within the city. So the basic aim of that surgical conference was the stem cells, the role of
something which is presentable or
yes,
right?
Yes.
Publishable on that account.
Because the role of stem cells is something which was among the newest.
But what was your mind thinking once you were trying to search?
So because being an orthopod, the first thing that we think about is osteoarthritis. So, and it is the most common modality that comes to us in the clinics. So my basic question was that whether there is something which can prevent us from going to the intervention and we can just stop it over there or not, and whether we can improve our functionality with the help of these new modalities or not. So I was basically trying to compare stem cells with the plasma-rich proteins and the hyaluronic acid. That was my basic aim in searching over that.
Because in your, and then you said that there was 4 studies which were comparing the stem cells with the hyaluronic acid.
Yes.
But you did not mention about the rest of the studies. What were they trying to compare?
So they were, for instance, some of the studies were trying to compare the stem cells with the arthroscopic debridements that were being performed and with the PRPs included in that. So there were multiple modalities that were.
What I meant to say, just to instigate your search mind, because you came up with this wonderful topic, that you should have probably broken down and gave us a table.
Probably more, yes.
That would have made the audience more wise. That these were the studies 12, and this is what they were trying to compare. And then you should have been thinking, putting something as your prime outcome or first outcome. that this is what you were looking for as a first outcome in those studies, and then there's always secondary outcomes which you can always think of in those studies, like relief of pain, like improvement of the function, and then you can use some scores if they are there in that. So just for future, if you want to do something.
Thank you so much.
Any question?
Maybe I should jump in a little bit because we too might be the odd man out. I have been following stem cell research for the past few years, and there is a society called International Stem Cell Research Society. And they hold their annual meetings, and I had attended a meeting in Korea 3-4 years ago, where, as Bakar Saab just mentioned, orgogenesis might be something to look for.
Yeah.
And he was growing muscle sheaths from the stem cells, and this was a cardiac surgeon, and he was grafting it onto the heart where the patient had suffered an heart attack, and that started growing into muscle cells.
And
he
probably
showed those patients.
Yeah.
And we have already experienced bone marrow transplant, which is actually allogenic stem cell engraftment. So there is some science behind this. The only thing is we have to try and apply it and research on it
further.
And if we can grow cartilage cells, these stem cells could also differentiate into those. That's the science behind it. So yes, please go on, study more.
Yeah, definitely.
And
Thank you.
maybe you'll be the next developer.
Okay. Thank you, sir.
And incidentally, 2 of those Japanese professors, they were given a Nobel Prize of Medicine in 2012.
Looking forward to it for 2030, probably.
Yeah.
Okay, thank you.
So, nice talk, Dr. Mohammad Mustafa. The next paper is basically correlation between the clinical examination, MRI, and arthroscopy for ACL and meniscus. And the presenter is Dr. Rehan Alwani, please. Dr. Rehan. So the next paper is basically the PIC major repair, a case report of one of the first case in Faisalabad, Dr. Zuhaib Nadeem. So the last paper is basically regarding the AC reconstruction with remnant preservation, and the presenter is Dr. Huzaifa Tariq. So we are at the end, and I would like to request the panelists for inconclusive remarks.
I think the presenters were successful in generating a lot of discussion, which is a sign of success of any meeting. And we congratulate all the presenters and the patiently listening audience for being here. Thank you very much. Colonel Sir, would you like to say a few words?
That is fine. I think I agree with sir. Wonderful talks, and I wish those additional talks which were there and meant to be presented would have been there, and it would have been more conclusive, but whatever was presented was of good quality. Thank you.
Okay, so it was a nice session. So I would like to request the panelist, respectable Professor Dr. Khalid Mahmood Shah, Kem Shah Saab, Professor Dr. Umar Saab, and Dr. Nadeemullah Saab to come onto the dais for the certificates and shield distribution, please. So first, we would take a start from the certificate distribution for the free paper. I would like to request Dr. Shah Rukh Khan come onto the dais and receive your certificate. Okay, for the next certificate, I would like to request Dr. Muhammad Mustafa to come onto the dais to receive your certificate, please. Dr. Sobia Aziz, please come onto the dais to receive your certificate. Yeah. So regarding the shield distribution, I would like to request Dr. Kazim Saab to come onto the dais to receive his shield. So the next receiver is Dr. Javed Iqbal, I myself, so I will receive the shield. Thank you so much. The respectable panelists are requested to have your seat, and we will conclude the session. Thank you, sir. So it is the end of the session, and now we can resume our activities, and we can join other halls as well. Thank you so much. Okay, sir. Yes, sir. Yes, sir. So we have another session, and the moderator for that session is Dr. Naveed Juman Saab and Dr. Amir Suhail Saab. They are requested to come to the dais and control the situation and proceed as per their protocol. The panelist for this session is Professor Khalid Mahmood Shah Saab, Professor Masood Umar Saab, Professor Faisal Masood Saab, and Dr. Kashif Mehman Saab. The respectable faculty is requested to have their seats. Should we start?
Thank you, sir. I think we can start, so I don't have a program for that.
Or to you, please.
So I think we are quite late, so
I will request the panelists to come on stage again. There is one shield left of Dr. Osama bin Said. Panelists are requested to come on stage again. Khalid Saab.
panelists would be again Professor Khalid Mahmood Shah Sahab, Professor Masood Umar Sahab, I think is not here, Professor Faisal Masood Sahab, and Dr. Kashif Mehman. So Amir Suhail, I think I can't see him. Dr. Osama bin Said again. Sir, ऑर्थोस्कोपिक सबस्केपुलर रिपेयर पे कुछ बात करें.
Thank you very much, Dr. Naveed, for the invitation. I would like to discuss arthroscopic subscapularis repair. So where are we today? I have nothing to disclose about this talk, and all our patients have consented for the data to be used for educational purposes. Just to all my mentors who helped me navigate through my career to this day. Subscapularis tears, biomechanical principles, we all know. We have to dig down and know that why do we have to repair subscapularis. A couple of functions that it performs are biomechanically and dynamically really important. Subscap plays a crucial role in stabilizing glenohumeral joint when the arm is abducted and externally rotated. It has a tenodizing effect, which has been well proven in the literature. The superior border of subscap inserts attachment at the anterior cable of the rotator cuff, and leaving it unrepaired produces extra strain on the posterior cuff cable. So the intact subscap opposes humeral elevation, and we all know by now, just to make you understand about the regions and the fibers, the superior ones, the middle, and the inferior, that's where it originates from. The scapular subscap fossa on the scapula insists on the lesser tuberosity of the humerus, and that's the arm abducted and externally rotated. That's where your subscapularis is mostly taut and tension in this position. Subscap repairs are relatively recent and newer, coming in to the play, first published by Dr. Burkott nicely in 2002, and thereafter there was increase in number of repairs subsequently. And why it was there? Just because of a lot of awareness, a lot of deep and accurate imaging that is available to this day. So just to dig down and deep and know the diagnosis of subscap was possible with these modalities. MRI plays a crucial role in diagnosing the tears. MRI technology have evolved. We can just go deep down, just like this slice in the axial view. You can well appreciate these tears in the superior borders and in the mid substance, and you can well establish the place of the biceps tendon. That's where you can appreciate whether a tear has gone deep down into affecting the biceps. The tips and tricks to diagnose a tear in the MRI, a couple of things that keep in mind. The axial view, we keep an eye on the long head of biceps, whether it is in place, it's in the bicipital tuberosity, it's a groove, or it's out of the groove, is it subluxed. The subscap tear in the superior border can be evident as clear as it is in this picture. Sometimes it is possible, it is suggestive, it is clear, but sometimes the MRI, we just miss it, and there is a high index of suspicion that we may miss the tendons. We need to go for these 2-3 signs together, just in axial views, and then the sagittal oblique views, a subscapular atrophy can be visible, and the bare lesser tuberosity can be easily seen in the sagittal oblique views. How do we examine and how do we diagnose these injuries in the clinic? These tests, we have all heard of it, from the bear hug to belly press to lift off test. All these tests, they perform different functions and just highlight tears in the different areas of the tendon. The most sensitive out of these is the bear hug test, and correlates best with the full thickness is the lift off test that is well practiced and established, and that's how we diagnose it. Belly press test activates the upper subscap the best way. So all these tests combining with MRI finding, they just make a perfect combination that could lead you to the right way in diagnosing subscap tears. Left-FOSS classification is one of the best classifications so far. It just helps us direct our management, treatments, and options, and it also helps us to speak the same language as just to make each other understand how the tears are. First three are really mostly seen, and they can be dealt easily with arthroscopic approach, even with the single row techniques. And if we go deep down in the type 4 and type 5, when the whole subscap is torn and the atrophy is there, there is fatty infiltration, so we might have to consider alternative options like a double row technique. One of the cases we just encountered back in Faisalabad, 51-year-old male, doctor by profession, he's a right-hand dominant, presented to me with pain and weakness in internal rotation in the shoulder after a fall 4 months back. It was neglected and undiagnosed since injury. When I examined him, the impingement was positive and supraspinatus stress test was positive. Proceeding down the line, the lift off and bear hug and belly press, all these tests were suggestive, but these things alone cannot just conclude this injury. I have to go deep down and read the MRI myself most of the times, and just to see the tear is there. Just like in this MRI, you can just see clearly the sagittal oblique image. You see the upper subscap tear is quite evident, and it can be easily be picked up in some cases. I do all my shoulders in B-chair position, and helps allow me to access the shoulder from all around. Maybe that's how I was taught, and I was just beginning, and this is the diagnostic scope. Going deep down into the bicipital groove, you see a little inflammation in the bicep tendon, but it was in place. So bicep is in the bicipital groove. Just to taking it back and to the evaluating the subscap, you see the upper border. The tear is there, Lefos 2, or maybe leading into the 3. So, but the thing in the tear is the upper 1/3 of the part of the subscap, and the bicep is in place. Further evaluating the tear just with a second look, and you see the lower part of the subscap is perfectly fine, and it goes all the way to the lesser tuberosity and its attachment. The upper part is torn, it's Lefos 2, so we'll consider our options according to that. So I just went for a knotless suture anchor. In this case for me was a push lock. And you see the post repair after these tears, you see the tear tendon is back in its place, and the bicep is all back to its normal position, and subscap there is no atrophy, there is no laxity, and the VV sign and the comma sign is negative now, and it's back in place. This is the patient almost 1 year after the surgery. I just recently called him for a follow-up video. So he's doing perfectly fine, no pain, no restriction and weakness on the range of motions in performing movements all around. I just want to thank Tall David from San Diego, who helped me clear my concepts about the subscap tears. We've done a lot of good work on subscaps. So I spent a lot of time with him learning and how to operate on these tears. They could be sometimes challenging, and they're not letting you perform the surgery so easily. So you have to devise, you have to improvise on table and in OR to just make it clear that you do the right thing and just evaluate the biceps along with it. My recent experience at the Espitar Doha in Qatar, amazing FIFA Center of Excellence, and how they are treating sports injuries, how they manage sports injuries in the FIFA World Cup, how they are optimizing the outcomes in the knee and shoulder surgeries. So it was a great opportunity for me to present my cases from Faisalabad to the global renowned faculty over there. So we had great consensus about certain things in there, from knee surgeries to ACLs, to from primary ACL repairs to LETs to shoulders. So it was a great experience. So take home out of this discussion is, whenever you see a patient having pain, an anterior shoulder, and the weakness in the internal rotations, you do have a high index of suspicion of subscap injury that could be missed in your clinic examination, or sometimes even in scoping it. So thorough examination is the key, that you must have to do it by yourself in the clinic, and you see all the options open for when you're examining the patients. And don't forget, I prefer reading my own MRIs. That really helps you elucidate a lot of things that a radiologist or anyone who has written the report might have missed. So single row versus double row, and decide the Lefos classification. The first 3 ones usually can be done with the single row. I've never done double row so far, but people do it if they have tears in the type 4 and type 5. Biceps stenotomy to tenodesis is decided on table according to the situation, patient's age, and whether the bicep has been subluxed out of his bicipital groove or not. And rehabilitation out of this has been a challenge. It's newer one, new techniques, new pathologies. So even the physiotherapist, you have to train them. You have to keep an eye on the patient throughout the rehab. Thank you very much, and I would love to have any questions you have.
Thank you, Sama.
Wonderful talk, Osama. I think the subscapularis isolated tear is very rare to find, and normally it is always associated with the cuff tear as well. You can get the isolated tears, but it falls lower in the. And I remember reading through the literature once I was dealing with this Swiss disease, which they call it. because once it was described initially in the literature, it was Mr. Gerber who picked up the subscapular steer first of all. And as he was trying to publish his data, he sent his study to be published into American Shoulder and Elbow Surgery Journal, in which they denied that you can't, because this is, first they did not believe that there is something like that which exists. And once they believed, they discarded it, saying that it's not a American side problem, it's a European side disease. And it took a long time for them to accept that is a disease entity which is there, and then they started doing it. And Mr. Gerber is still a working surgeon in Swiss, and on his techniques, these different tests are there to have the sensitivity and specificity which they are, but well-presented case and well handled as well. I was just wondering, because once the upper portion of the subscapularis is gone, that is what is believed to have some sling effect onto the biceps tendon as well. And it is difficult to fix it back without doing something with the biceps. So what will be your plan to do with the biceps if you come across such a situation?
That's a great step in the surgery. I mean, sometimes you face this challenge when you enter the joint and you see there is an upper body tear, which is type 1, type 2, type 3. And as it makes, the posterior effect, the sling effect on the biceps, and the coracohumeral and the superior glenohumeral ligament comes in the front. So that's why when you see my scope going down in the bicipital groove first, I checked it, where the bicep is in place, everything is perfectly fine. So I just make another portal anteriorly, and then I view just to have another view, I just visualize the biceps again and then the subscap, and just put it with the grasper and then just pull it back and see, making sure that bicep stays in place. In the type 4 and type 5, which I have never come across so far, but it's believed that the biceps has been subluxed, and that's where you have to fix the biceps. And when bicep is subluxed, you could pick it up with the MRI, you could go inside the joint, you could just easily see that bicep is not in place. So at that point, you have to decide what you do with it. You have to tenodase it, of course, according to the age of patient, what you want out of it. So I've never done so far, but I've never seen any patient with coming to me with bicep subluxation. Luckily, there was all type 2, type 3 tears.
Thank you, Sama, and thank you, Dr. Nadeem. My practice is mostly shoulder. It's all shoulder. You would be surprised if I show my list today that is being done there. We would have like an average good amount of cases. To me, subscape isolated tear is not an kind of unusual thing. We do face it. A few things, there is a French study which was presented by Csientific this 2023, that this long head of bicep subluxation, dislocation, its association with the subscap tear. It is a very low association with subscap tear. And the other thing is that if the upper part of the subscap, it is a tubular kind of structure. It is one of the strongest part of the subscap. Down there, if you go there and if you see, it is kind of a flattened part and then the muscular part. The distalmost part is the muscular part. So if you have torn the topmost tubular part of the subscap, the damage is done. I all the time go double row fixation, no matter if it's to be honest, I didn't even know the Lefast classification. I just go there and see it. And I don't mind if my long head of bicep, unless it is just lying interiorly, I don't mind. Once the patient has no pre-op bicipital symptoms, and once they have no slap tear, I just leave biceps as such. I kind of just buzz it with wand and that radio frequency device, just going to clear the inflammatory tissue, and I just leave it alone. Because your transverse humeral ligament, it is keeping it there. And even normal anatomical, that is a normal kind of anatomical thing that biceps may be kind of subluxing interiorly. I don't do subpectin or even tenotomy on these guys. If I repair, subscap, I just leave it alone. And the other thing is MRI. In Europe, in Ireland, we have good musculoskeletal radiologists, but most of the time you rely on your own perception of what you see there because of so many things, just how much it's retracted. I find subscapes tear very tricky. I find it tricky to pick it on the MRI. My MRIs are 110 times better than your MRI, those static film. I have a big screen like this. I can play around with that. Still, I have to call the radiologist if I'm struggling with the MRI interpretation of subscape tear. I really appreciate that you're quite good. To be honest, if these MRI was handed over to me, I would have kind of say sorry to know anything out of those. Thank you.
That's fair enough. We are trained to pick tears out of these MRIs, so we have a good experience with that so far. And also about the biceps, we just really easily pick up on the basis of an axial cut on the MRI that the bicep is in place or not, and you could see the fluid in there. So I mean that really helps. Otherwise, most of the things you do, you don't go by the classification, but the upper part tears, upper portion, type 1, 2, 3, the single row technique works fine. Otherwise, if you go for double row, it's a lot of anchors. I don't know how you manage them in the first three. I would like Dr. Naveed to show some highlight on that.
For subscape, you're saying?
Yeah.
So actually, the Burkhardt, I think, has a lot of work on this, describing this bear hug sign and also intra-articular sign of the comma sign, you know.
Yeah.
So during my time with him, so I saw him mainly repairing subscape in a single row.
Yeah.
So with the same anchor, he used to do intra-articular bicep tenodesis at the start of the groove, and through same anchor, he used to repair the upper portion of the subscape. So, and obviously you learn with observation. So in few cases, I have followed the same technique. So I haven't myself done any double row for the subscape yet. So.
Dr. Khalid want to say something?
Wonderful talk, Osama, and really you are doing excellent job in Faisalabad.
Thank you.
Zabardast.
Thank you.
Keep it up.
Thank you.
In fact, the surgery and the fixation of the subscap, particularly in our setup, when we see that you see the lesion most of the time arthroscopically, and many a times with MRI you miss that.
Yeah.
And secondly, the most important indication for repair is the pain. If the patient is having pain, then it should be repaired. Yeah. As far as function is concerned, the maximum function with the passage of time, it is covered by the pact major, and it doing the same work. Because many a time in my practice, particularly in patient with nerve palsy, I sacrifice the subscap as well. And I don't see any functional disability as far as internal rotation is concerned. Rather, the patient have very good external rotation and the abduction in such cases. So the indications still are very, very specialized, particularly in our setup. As far as degenerative tear is concerned, then mostly the degenerative tear of upper to third, they work very well even with the debridement. And if you feel that it is a patient having pain and the tear is about 2/3, then you can go for repair. And as far when you are doing the repair, then the relation with the biceps, you should keep in your mind. If there is slab lesion or there is bicep tendinitis in the groove, then definitely you should do the tenotomy and fix the biceps with that even the suture, or you can do it independently. And if there is no slab lesion and biceps is fine and the groove is fine, then there is no harm to repair the subscap whether in a single layer, and it works very well with the single layer.
That's fair enough, yeah.
So I agree with Professor Khalid Saab. So even today we see patients coming for second opinion with MRI saying complete supraspinatus tear, complete subscap tear. When you examine the patient, they have not much symptoms. So then you are surprised, I mean, what to offer. So probably the next talk may little explain. So.
Yeah. Okay. Thank you very much. Thank you.
So this is just a recap of approach how to deal with the patient coming with the rotator cuff problems. Not my experience, but a general go through. So, obviously it's a very common problem. 70 million patients per year in USA, 200 to 500,000 cuff repairs are performed. We don't have data of our region. Obviously, maybe if you can remove 2 last digits, so that may reflect our own surgical volume in the country. Presence of cuff tear is highly correlated with the age. 67% of and 70 years old have rotator cuff tear. And many post-mortem studies have shown that more than 80% of subjects older than 80 years have the cuff tears, mainly degenerative obviously. If more than 60-year-old patient with unilateral shoulder pain, 50% there is likelihood of contralateral cuff tear or bilateral cuff tear in those patients. So classification is fairly simple. Partial and full thickness. Partial are again further divided according to their fancy nomenclature, grades, how deep it is, then pasta and paint lesions, and then mainly we deal with the full thickness tears. They are of more interest to us, and usually we classify them according to their size, less than 1 centimeter, 1 to 3, 3 to 5, or massive tear which is more than 5 centimeter. So this concept is really important, and Burkhardt was very much explaining to this concept of rotator cable, and this may behave like you can say a suspension bridge analogy or mechanism. So if that cable is intact and the crescent is gone, so the patient may still have some function preserved. So that's why to me this sometimes explains with large cuff tears patient may have fairly preserved function although they do have pain. So there are a lot of options nowadays, from rehab to physical therapy to arthroscopic cuff repair, open cuff repair with a page. Then SCR is in quite nowadays. Balloon is mostly done in UK, in European areas, I think. Then tendon transfer, and reverse shoulder arthroplasty. Sorry. So variables to consider, obviously there are patient related and there are your tear related, muscle related. That include tear size, tear retraction, tendon quality, atrophy, Gottlieb grading, fatty infiltration, and then nerve injury as well. From patient point of view, it is the age, activity level, expectation of the patient. They are very important. Acute versus chronic, how old is the tear, whether it is traumatic or atraumatic, whether you are doing a second surgery or primary surgery, arthritis and stiffness. So literature has shown that the higher risk rate of failure after primary cuff repair is when patient is more than 65-year-old, he is diabetic, quality of tendon is poor, patient is a smoker, tear, a massive tear obviously, retraction more than 2.5, cuff, the tear obviously this will correlate with the size of the tear. There is severe atrophy, grade 3 or 4 in the Gottlieb grading, and then unwillingness to do rehab. So this was a fatty infiltration more than 50%. We will come to the grading. So grade 0 is normal. Grade 1A, when there are very minimum fatty streaks. Grade 2, there is fatty streak, but obviously more cuff than the fat. Grade 3, 50-50, and grade 4 more than 50. So initially Gottlieb described if it is more than 50%, the results are very poor. But Burkhardt has probably changed this concept and say even if you have a almost 75% fatty infiltration, the tendon cuff repair may give good results. So attempt it. So Gerbert found that combination of Godley grading and preoperative tendon length appears to be more powerful predictor to the repairability of a tendon tear than Godley grading alone. So both things need to be considered. The grading, atrophy, and plus how much it is retracted. Obviously, this will describe your tension at the repair site. Predicting success of surgery, again, this is the same thing. More than 75% can work in words of work hard. And then nerve injury, obviously, when there is more tendon retraction, there are more chances of suprascapular nerve injury due to secondary retraction injury, and then that may compromise your repair or the outcome. So partial with patient with full thickness tears did poorly non-operatively if they have more than 1 square centimeter tear and the symptomatic for more than 1 year, and then they have functional impairment and weakness. Obviously, they do well. Again, we are just talking about older tears, very chronic tears. So this will just give you some overview how the patient present to us. There are a few cases and how what things will be helpful in decision making. 60-year-old lady, right hand dominant, right shoulder pain and weakness for 3 months, no trauma, not improving, no physiotherapy has been done yet. MRIs, patient come to us, it's a routine scenario, MRI showing a tear. Surgery has been recommended. Now she is here for second opinion. What is on examination? Active forward flexion 130 degree, passive is much better. External rotation 40 degrees, no leg, bicep tendon not tender, little bit reduction in power, but otherwise fully functional. Negative horn blower, negative lift off, negative belly press, pain in with bear hug. These are the X-rays, fairly okay. MRI, not a massive tear. What would you recommend? Physiotherapy, because she has never had physiotherapy and she regained pain-free, acceptable range of motion, then you will leave her. May not do anything. 50-year-old gentleman, engineer, right hand dominant, left shoulder pain, 3 months, similar kind of almost symptoms, worse for 3 months. But physiotherapy for 8 weeks had already been done, very active, doing hiking, playing cricket. On examination, you have forward flexion active 160 degree, passive almost same, no leg in external rotation, with good external rotation, little bit less power in supraspinatus, bicep tendon and tender. So what you do here? X-rays are almost normal. I mean, these are videos but may not work, but just we are trying to show the grading was okay, muscle tear was not massive. So in this case, sorry, you go for repair, obviously. Patient has already tried physiotherapy and he is very active gentleman, so go for repair. So many options are there still. Arthroscopic open with the page, arthroscopy with the page, capsular reconstruction, cervical balloon. So all these options are there, but you can repair this case very easily and patient will get benefit. But obviously, sometimes you do consider augmenting the biology with the repair. So there are 3 options which I found in the literature: patches, doxycycline, and microfracture. Microfracture we usually do. Doxycycline was something we don't practice too much, and it actually inhibition of matrix metal proteinases improves healing after rotator cuff repair, and many studies have shown in the past, these are still decade-old studies. It inhibits the formation of MMP, improved collagen formation at enthesis, at the insertion of the tendon, and improves strength of tendon at enthesis. So bone marrow stimulation, again, it has shown good result, especially when you are doing a revision surgery. You do some trephination at the area of footprint, and re-tear rate is reduced, and large massive cuff tears have a little bit more healing rate when you are doing bone marrow stimulation. Page augmentation, again, it's more important revision surgery, and massive tears, they have different variable results. So coming to case 3, 52 gentleman, pain and weakness for 3 weeks, first time dislocation reduced in ER, no treatment done yet. He is also again very active, very hiking, cycling. On examination, almost full forward flexion, active and passive both, painful arc, and no leg in external rotation. Power is 4/5. So what do you do? So this was the answer, fix it acutely. I mean, this is acute injury, okay? You don't have to ask so many questions in this case. So next. Okay.
52 gentlemen, right head dominant, engineer, 9th month duration of pain and weakness. Again, he is now post-surgery. So again, we told one of the factors important is the patient already had surgery or not. 3 years post-surgery, surgical repair, plus bicep tenodesis. Again, had injury, dislocated shoulder, no improvement in physiotherapy. He is also again very active in hiking and cricket, unable to throw ball. What you do here? On examination, forward flexion 90 degree, active, but passive is 160 degrees. So here the patient has significant weakness. Dyskinesia, external rotation 60 degree without any leg, negative belly press, lift off, negative bear hug, and negative horn blower. These are the X-rays, not bad, no signs of arthritis. MRI again, this is very important. So this was supposed to be a very active gentleman, but you can see his quarterly grading is very bad, more than 75% atrophy. So what you do here? So many options again. So this can be, because patient has a very good passive range of motion, you can offer him superior capsular reconstruction. So they will give very good results. So another case, again same patient. So I have just changed the scenarios, little bit scenarios with the, almost same patient history, same patient age. 9 months post complaint, 3 years straight post arthroscopy, almost same patient. So what is the change here? Little bit in examination. He has 30 degree of external rotation leg. So how that will change our management? We may go for tendon transfer because now he has a external rotation leg, excuse me. So let's him a dorsal transfer or a lower trapezius transfer. Professor Khalid Saab has much more experience with the transfer as well. Now the key here was the external rotation weakness, external rotation leg sign. If the patient has external rotation leg sign, so it's better to go for tendon transfer. Again, last case, 75 gentlemen. Now the age is progressing. 3-time failed rotator cuff repair. Physiotherapy of 6 months, not benefiting, not progressing, no signs, symptoms of infection. Retired, active in the community. So maybe you may not go for repair then. He has 20 degree of the rotation leg. Passive range of motion is very good. Active is very much limited. Significant power loss. And obviously not too much arthritic, but there is superior migration of the head as well. And these are again movies may not work, but it was again showing significant atrophy in the muscles. For this 75 retired, there are options: arthroscopic partial repair, ACR, balloon, reverse shoulder. So you can offer him balloon, or you can offer him shoulder arthroplasty. Both can work here. So indication of surgery: acute traumatic full thickness tear, refer early, operate early. Chronic tear that has failed conservative measures, or any full thickness tear in a young patient would go for immediate surgery. What are other indications? Unremitting pain, especially at night pain, loss of activity of daily living function, significant loss of strength, bony impingement with failed rehab, moderate to massive tear with active job and healthy less than 50 years old, isolated partial or full thickness tear without relief from rehab, and these have high probability of success when you are doing repair. So fixed traumatic tears early, no trauma, then start with the rehab. And young active patients, superior capsular reconstruction when it is not fully repairable, there is no leg sign. Do tendon transfer when there is a positive leg sign, there is a positive external rotation weakness. Older sedentary patients do reverse shoulder arthroplasty or some other things, temporary balloon or something like that. Okay. Thank you very much. Exactly.
What else you are offering now?
Well, so if he has approached me, that means he has some problem. If his activity, yeah, so that's what this approach is describing. If the patient is coming to you with pain, not getting better with physiotherapy, his activity of daily living are affected, he has night pain, then you have to offer something. That includes injection for pain relief as well, and then reverse shoulder arthroplasty can be done as well because the cuff repair has already failed 3 times. That was my last scenario. leave it alone is also an option if the patient has symptom free and he is willing to modify that particular joint as well. So even in my experience, patients with shoulder arthritis, many of them choose to leave them alone themselves. They do, once it is arthrodesed or too much arthritis, they have no motion, joint is fused, they become actually pain free. Now their only issue is range of motion. If they are happy with their scapulothoracic motion, I do encourage them to carry on in elderly people. बिल्कुल.
I think the person who is failing his cuff repair so many times and still coming to the clinic, so one must try to find out what exactly he is searching for. So unless we don't know what the patient is actually searching for, we can't answer the question exactly what to be done with this patient. For me, in such a patient, I would try to see whether his joint is fine still or not. As far as glenohumeral articulation is concerned, there is no sign of arthritis. And what is the status of his front muscle and the back muscle? If both the muscles are fine, so I can deal with in some way with his top muscle still. Because that patient, if he's coming with persisting pain, so we know that this pain is probably coming because every time he's trying to elevate his arm, his humerus head is touching against the acromion, and that can be one of the reasons of his pain. So you need to do something in that area to prevent that humerus moving forward with each motion, which can be the source of one of pains in that patient, because his cuff failed 3 times, we don't know why. So definitely the assessment of such a patient would require more detailed history, more detailed evaluation, and to give him a solution which can benefit him the 4th time. Otherwise, better to leave it alone so that he can.
Yes. I mean, it's a general concept. So the degenerative tears have more chance of failure, but literature very clearly says it doesn't mean you have to revise. Even the re-tear in many patients do well with physiotherapy and they carry on.
Well done. It was an excellent talk. Just for rotator cuff tear, as I said earlier, I have 2 categorization: young patient traumatic tear and old patient atraumatic tear. Young patient traumatic tear, I all the time fix them. And the literature, if you go on the literature, even if they are minimally symptomatic or they are improving quite well with physio, my inclination is to fix them, because if you search the literature, there is a good evidence that this tear, they progresses, they retracts, they fatty infiltrate, and in a young fellow who is 40 years of age, rather doing a simpler job now, you are doing a difficult job 10 years later. So I fix them all. Agreed. Secondly, the elderly population, as you said, 60% or 60, they have tear. If they have a symptomatic tear on one side, 50% chance they could have an asymptomatic tear on the other side. I feel still quite lucky. In Pakistan, we get MRI the next day. In my setup, which is the 2nd university hospital of Dublin, Ireland, we have to wait for 6 months to get an MRI scan. So if the person is pain-free or minimal pain, I inject plus physio. And if that is the case, they are 60 years of age plus, I don't bother even doing MRI scans because it won't change my management. Painful shoulder with cuff tear, obviously you have all the option. My inclination for a superior capsule repair, I can't do the latissimus transfer, lower trap transfer. It would be I have a very, very high kind of threshold. If the muscle is retractor, very high level activity, and you can't repair at all, then I do a lower transfer. For the in-space balloon, in UK, was this multicentric study just conducted now. They stopped the study because the results were so poor that it was not worth of continuing the study. But again, the atrocities that on the other side of Atlantic, they are coming up with very excellent result in America. So what is right, what is wrong, I'm not sure. That's what you can say, sir, and that's what's right. So in-space balloon is not an option for irreparable tear because you won't gain it, just disappear within 3 months. Partial tear, young people, and then re-tear, just to give them, I would put regenerating page because it does increases the, okay, so the regenerating, it's better than that, okay, thanks. So the regenerating patch that I use, I only use it in young re-tear people. I've stopped using in-space balloons. Anyway, it was an excellent topic and very elaborately explained. Well done, thank you.
Thank you. So I agreed with a lot of your comments. So obviously we have this liberty, the patient comes already with the MRI to our clinic and we have to explain more MRI finding than the actual symptoms. So in my practice...
82 years young man who is a regular tennis player at the age of 82 is better a patient as compared to a 55 years young man who is a shopkeeper without any activity. So what he wants at 82 years, he wants his rotator cuff repair because he wants to play again. One of the very renowned principal of a very renowned medical college in Punjab, at the 82 he had a supraspinatus tear. While playing the game, he wanted to play again. It was openly repaired way back. It's almost now 10 years down the line. It was open repair. Arthroscopy were not available that particular with chromioplasty. He's still at the age of 92. He's still playing a daily. Okay. So the fit patient with adequate diagnosis and adequate treatment most of the time will not need any subsequent interference.
So exactly, so it's not the age, so there are so many factors.
It's so many other factors.
Exactly, so that's what we, this is our motto, we treat our patient, all patient like athletes.
This is good, this is good.
So one comment which I wanted to give, so in many patients with this particular age group, before ordering MRI, if they come to me without MRI, so I usually ask them, my purpose of MRI doing to find out something which needs intervention. If you are willing to go for surgery, then I order MRI. Otherwise, I even don't do MRI. So.
Very good. Yeah, so the age was because of the tear progression. Not that I'm kind of against my elder people. Yeah.
Exactly.
And for the very elderly people, I do, like even if they are not consenting for reverse geometric shoulder arthroplasty, I do just tuboplasty. You know, it's just kind of shave off the GT because their deltoid is firing, the humeral head is kind of touching the subacromion, the undersurface of acromion. So just kind of do a sham kind of procedure, just take away some of the GT tubercle, and it works well. It works well. Thank you.
Thank you. So we are getting, I think, behind schedule. If there are no further questions, we can proceed. So Dr. Sanaullah wants to share with us his experience of dealing with rotator cuff, massive rotator cuff tears.
इसको थोड़ा सा brief कर देते हैं ये rotator cuff को. It was a healthy discussion. In my practice, what I have seen that there are only 4 factors that you need to keep in your mind while dealing with the rotator cuff. Number 1. As Nadeem mentioned, what the patient wants. Whether he wants to get rid of pain or whether he wants to get recovery in the work as well. Uska chahta kya hai patient. Then the next is what is the age of the patient and the pathology of the patient. ये 4 factors को ज़हन में रखते हुए मतलब है कि we have to manage. And there no doubt, as Sir Abu Bakr is saying, that there are patients. I came across General Jahangir Karamat. He is around 90 plus, but he is playing golf as well, and got the rotator cuff tear and wanted to get it repaired. So, ये patient की demand अगर है तो then we are here to fulfill the demand of the patient. Thank you.
Thank you so much, Professor Abu Bakr, Dr. Masood, Dr. Khalid, and Dr. Sami. 50% of the topic is already covered, almost 60%, and there was very good discussion on the topic. I will further proceed to the new topic, massive rotator cuff, how I do it. My name is Dr. Sana. I'm working as assistant professor in RMI Peshawar. So, rotator cuff tear are a very common source of shoulder pain and decreased motion that can occur due to both traumatic injuries as mentioned by Dr. Sami and young patients as well, and degenerative diseases in elderly patient. Diagnosis can be suspected clinically with provocative test in setting of Ireland, where he diagnoses it clinically and straightforward go to the arthroscopy. But it can be confirmed by MRI. I will not go into the slides and the text, prevalence, and the risk factors are already covered by Dr. Naveed Jumman, and the classification like supraspinatus, infraspinatus, teres minor, subscapularis tears, all are covered by the worthy speakers. And again, cuff tear, massive rotator cuff tear is either more than 5 centimeter detected, or it may be two tendons tear or more than 2 tendons tear. So focus will be massive rotator cuff tear here. Allman's classification is for pulsar tear, and I will not go into the detail. We all know the bursal sided tear, the articular sided tear, and the interstitial or intratendinous tears. One thing which is important, the bursal side has a rich blood supply and it heals quite good as compared to the articular side. I will not go into the detail. Guttalial classification is for rotator cuff atrophy, and it normally should have no fatty tissue or fatty streaks. So again, rotator cuff tear shapes, crescent shaped, U-shaped, L-shaped, and massive cuff tear. So how I do arthroscopic rotator cuff repair? This is our setting with our fellows, and the steps are important. How I do arthroscopic rotator cuff repair? It starts with a diagnostic scope, address the pathology. Subacromial decompression will further improve vision and cuff tear visualization. This is one of my case. And again, retraction. Sorry for the poor picture quality, but in the upper picture you can see that the supraspinatus is at the glenoid level, and with retraction it's coming towards the tuberosity. So lateral traction stitch, cuff tear mobility, cuff tear size determination is important. Bursal sided releases and articular sided releases are required in massive rotator cuff tear. So sometimes we need interval slide. This is very important concept. If the cuff is torn and it's at the level of glenoid, we can do anterior interval release. Most of the tears will come to the tuberosity. If we need, we can do posterior interval slide as well. So these are the steps. The anterior release, tendon mobilization, tuberosity preparation is important. Anteromedial row anchor placement, you can see that the first anchor has been placed and the second anchor is placed in this picture. You can see these are the medial row anchors. The tuberosity is prepared and now it's ready to be passed through the cuff, and further deployment of the lateral row anchors. So this is case number 1. The MRI waiting time in our institute is 2 to 3 hours, and the quality of report is always standard, and it's a bit satisfactory for the patient, and cost is also range from 6,000 to 16,000. It's my patient, a young man of 70 years. He's also a sportsman, and you can see that the cuff is at glenoid level. So it's a massive rotator cuff tear done 3 or 4 months back, and the cuff is at glenoid level. So I do the superior release, the articular sided release, and I did only anterior interval slide in this case.
And you can see that the first two anchors are deployed. Sorry for the poor quality, but I medialized the footprint because it should be tension-free repair, and the releases were sufficient enough to bring it to the tuberosity, mid of the tuberosity. So these are the pictures, and one can appreciate the medialization of the footprint in the post-op picture. That is the post-op. The razor is not, you can see, and it's medialized. So we can medialize it 5 to 8 mm to have a tension-free rotator cuff repair. This is case number 2. Again, the medial row anchors, the lateral row anchors. This is case number 3, another massive rotator cuff tear, and it's the repair, strong repair, stable repair. This is case number 4. Again, single row repair, stronger repair, and tension-free repair. Case number 5, again, massive rotator cuff tear and tension-free repair. Case number 6, it's not massive but a huge rotator cuff tear. I have video for this which will be played after this slide, and it's after the repair. So kindly play the video. I have 2 videos. Rahim, arthroscopic view of right shoulder. You can see rotator cuff tear. It's a massive rotator cuff tear. The cuff is at glenoid level. Now we will try to repair it with suture anchors. Now you can see that the anchors has been deployed and the biomechanics of the shoulder has been restored. The movement of the shoulder is now normal, and this patient will do very good, inshallah. Bismillahirrahmanirrahim. This is arthroscopic view of the right shoulder. There is complete rotator cuff tear. I am checking the reduction, and you can see that the tuberosity has been prepared for the anchors. You can see the 2 middle anchors has been tied, and the cuff is nicely reduced. Now I will apply the 3rd anchor. You can see the completely repaired rotator cuff, and there is no gap right now. Thank you. Thank you. Any question, please? I don't put metal anchors anymore, whether in knee and shoulder, in instability or in cuff repairs. I do not put any metal anchors. I have discarded even bio or peak anchors in instability repair. Where possible, I use all suture anchors. In instability, I use 100% all suture anchors. There is no drilling, there is just pinning. But in this case, in rotator cuff for the lateral row, we don't have all suture anchors for lateral row. Maybe Arcex or any other company developed it. I am strictly against foreign bodies, whether it's titanium, biocomposite, or peak.
And what about the angle that you put your anchor in? Do you prefer any sort of like what you call dead man angle, or?
And, there is no specific rules for it. Just use your spinal needle, and where you can put your medial row anchors nicely, you can put it. Of course, you will use a guide wire or a spinal needle that will guide you.
So, maybe due to cost issue, so I have been now compelled to use metal anchors as well for medial row. And metal anchors are double loaded, and we don't have usually double loaded anchors in peak or in Arthrex system. So you have advantage of getting 2 sutures, and repair you can do a medial row with the metal anchor, and for lateral row you use civil locks. That's what I do recently.
And sir, what about the angles? What do you think about the angles? Do you go 90 degree in or 45 degrees in?
45 degrees, not 90 degrees. So
Your aim is always 90 degree to the surface, whether you are doing trauma, where you are doing ACL, but it's not possible always.
So maybe you're confusing two things: the angle which you make in relation to the humeral head, or in relation with the surface of the bone. So probably I may not be able to describe clearly, but Burkhardt had described a kind of जो वर्ड हम उर्दू में वो खोंटा टाइप का यूज़ करते हैं ना, the hook जो बैल वगैरह को लगाने के यूज़ होता है, तो a little bit oblique जाता है ताकि वो strength उसको वापस खींचने निकल, तो इस तरह when he was developing these techniques for double row repairs.
Important is that your anchor should be strong enough and it should not be pulled out. You should not have complication. It should hold your tissue tension free. That's important. Angle is of less importance. You should follow the principles. The tuberosity should be properly prepared. It should provide a healing bed. The cuff should be properly mobilized. These are the important things. And if there is stress on the cuff, you can put a pillow, abduction pillow, for some time. These are the important principles. Angle, I don't think.
Biomechanically, if you put the anchor in less than 90 degrees or this way, then there is chance of pulling the anchor out.
So biomechanically, it does make a difference. If you put the anchor in less than 90 degree, I'm talking about the towards of the head. Right.
If you have a tension band principle in your mind,
yes,
it's a band you are reconstructing onto the lateral side of the shoulder.
Exactly, sir.
You have to consider three things. One, inline pull, active pull. Three, your medialization is coming in my way now. If you medialize your little bit of a cuff, 3 to 5 millimeter even, with the atrophic muscle already retracted, which you have pulled out of your retraction, and you are suturing it there, will certainly reduce the lever arm effect. There's no doubt, and the muscle is already atrophic. It will lead a lot of physical therapy, rehabilitation to build that muscle and to pull that arm out, which may be 3 to 5 kg more heavier than when you have it lateralized it. People may lateralize it with an augmentation. The medialization may be still under research.
Exactly.
Okay, so have you seen some pole like this which is bending, the tension band is on other side?
Exactly.
It is these particularly anchors, they are in line with the pole.
Exactly.
If they are at right angle to the pole, they will pull out. If they are any angle to the pole, they will give way. Exactly. So they should be anchored in a right angle, that they are constructed like that,
exactly,
which is a biomechanical perception.
Yeah, well, it sounds a very good question, but to be honest, to me, like if you see the rotator cuff, they are not coming up from the ceiling, attaching to your humeral head, pulling it up. To be honest, I would agree with Sanola. I don't mind, measuring angles and putting anchors. It's not that simple. You need to have a very good anchor. I used all suture anchor. We call it why not. So it's I just put it there and I pull it. I give it a good tug. And if it is there, it is there. In terms of medialization, we are lucky that we are not knee surgeons. Maybe some of you are. I'm not a knee surgeon. We are not walking on shoulder. You put your scope in an elderly person with a big tear. You come out, you do a sham procedure, they would have some benefit. So just covering the humeral head with some soft tissue will do. If you are talking about quality, yes, then it matters. If you medialize it, you are changing the biomechanics. And ideally, if you're talking about improving the patient function, then a medialized anchor, rotator cuff is not doing the job. But if you're talking about pain, you interpose anything between the humeral head and the subacromial space, there would be pain relief. And that's what I would say.
Yes, I think probably the doctor, Dr. Naman. Dr. Naman, I think there is a very good article which was written by Stephen Burkhardt on the angles which you should use while fixing your cuffs. And he related that angle of fixation
as per his article, once he was visiting Texas ranches around, and he saw that while building the fence of those ranches, they put the wires around the peg in the middle first, and then they pull that thread and the anchor with another peg onto the ground with a different angle. So that is from where he created this theory which is called dead man's theory, and it remained into the literature for a quite long time, whether it is valid or not valid, but it has generated quite a healthy discussion which is worth reading on just the angle of fixation once you have passed the threads through your cuff. And as far as the medialization concept is concerned, it is all to release or relieve your cuff of the tension. There's no doubt that it changes the biomechanics, as Sir Bakar has pointed out, but it is just gaining those few millimeters that you can fix the cuff without a patch. Otherwise, he was lucky that he could fix all those cuffs without putting in augmentation patch with them, because that would put all these repairs under a lot of stress, and the chances of failure are high once the cuff is under tension.
Exactly. If we go much medial and the tendinous part, the suture should pass through the tendinous portion rather than the muscular portion. It creates type 2 or the musculotendinous junction tear. Second is you should put more anchors to distribute that force. If I put 2 anchors, the chances of failure will be high, but if I put 4 anchors, that will decrease, and the shear towards each anchor will decrease. And the third thing is keeping it in abduction will give it some time for the healing. So all the 3, medialization, multiple anchors, abduction, all are meant for decreasing the failure and increasing the chances of healing.
They have a tendency to elongate. You can build a muscle to any extent. See the builders. So muscles have a tendency with their elastomeres to compensate for this much of a tightness. So the abduction is the answer.
Exactly.
So you can put it, you can cover almost 1 to 2 centimeters with the abduction, adequate mobilization, not going beyond that point where you hurt some vital structures.
Yes,
So that is the limit of your release. So most of the pain released with this abduction, this matters. Putting sutures, and suture will add 35,000, and 35,000 to the industry. So you have to be economical on both sides.
Exactly, true.
Wonderful talk. The principle number is 1 for repairing the rotator cuff. The repair must be tensionless. If there is a tension, then the patient will come again to you. Rather, you have put 10 sutures to that patient. Number 2, when you are repairing these, in such cases, it is better that you apply 2 rows, one in the medial and one in the lateral. The angle for the medial row doesn't matter. कि जी क्या है आपका, क्योंकि आपका जो lateral row का जो angle है, वो इतना strong होता है कि जी वो उसको अपनी position में रखते हैं. Number 3, whenever you feel that there is a tension and there is a problem, particularly in these massive sort of sutures, massive sort of tears, then never ever try to repair to do the primary repair. Then think for the tendon transfer, think for augmentation, and think for any secondary sort of repair in such cases. So the number 1 principle, the repair must be tensionless. Number 2, where you feel that there is a problem in the repair and there is a problem with the excursion and you feel that excursion is not fine, so as a first stage, go for tendon transfer in such cases. That's my experience.
So to conclude, if you are repairing in the tension, so you're not putting tension at the tendon, but you are creating tension for yourself. So that's our conclusion. So
These are the cases where cuff was mobilized and was possible to be
no,
repaired.
I mean this was just general comment.
I
So you
haven't
can-
shown cases where I have.
You did a commendable job. So in the interest of time, so we will be moving forward.
Thank you.
So So only I think 10 to 15 degree support we usually give. So free papers turn it's now. So if we have Dr. Atif is here. So no. So Dr. Muhammad Mustafa, Dr. Arslan, Dr. Noman Malik. So Dr. Noman is here. So he'll be presenting functional outcome of congruent arc lateral J procedure and off-track lesions of shoulder with recurrent anti-shoulder instability. You exactly have 8 minutes, 8 per my record. Okay. So I was thinking about 5 minutes, but
Let me start my computer first. Thank you. Please deduct this time.
so do we have Dr. Sabir Khan Khatak? Dr. Mohit Sheikh? Dr. Mohit is here? No. So we probably have this last talk then. Last paper.
Assalamu alaikum and very good evening to everyone. I'm Dr. Noman Ashraf Malik. I'm currently fellow in sports surgery and orthoscopy at Liaquat National Hospital, Karachi. The topic I'm going to present here is the functional outcome of the congruent arc lateral J in off-track lesions of the shoulder in patients with recurrent anterior shoulder instability. This is a study that we have done here. These are the authors, the principal investigator being Dr. Mohammad Sufyan. So coming to the introduction, the recurrent anterior shoulder okay. Yeah. Sorry. Take it. All right. So coming to the introduction, basically recurrent anterior shoulder instability is mostly seen in young individuals who are active and involved in a lot of sports, weightlifting, heavy labor, or military training. Here in Pakistan, people mostly are involved in road traffic accidents as well. The mechanism of injury is basically forced abduction and external rotation, and in those patients, it is said that the glenoid bone loss have been present in 86% of the time in the recurrent dislocations. So any dislocation after the first dislocation will add on to more glenoid bone loss, and the humeral lesions are seen up to 100% of the patient. Furthermore, 60 to 70% of the patient have bipolar lesions which are at risk factor for recurrence. So coming to the modalities of the treatment, that could be ranging from the soft tissue procedures to the bone block procedures. The soft tissue procedures may be Bankart repair or remplissage, and bone block procedure may be lateral J, Bristow, or that can be added with the soft tissue procedure as well, that is remplissage. And literature is supporting both of the treatment option, the orthoscopic and the open as well. So the concept of glenoid tract as described by the Yamamoto and Itoi in 2007 basically states that when the shoulder goes into the abduction and external rotation movement, the glenoid is the head of the humerus is tracked onto the glenoid and rotates over it. So there is a fine balance between the glenoid and the glenoid tract. So if there is a bone loss onto the glenoid surface, like here you can see that, I don't know, there is a chance that the glenoid tract is disrupted and the humeral lesion may engage with the glenoid. So this is the working hours of the treatment option that we follow. This is a table according to which if there is a bone loss of less than 25% and the lesion is off track, then we can go for the, if the bone loss is more than 25% and there is an on track lesion, then we go for letter J or bony procedures. So this led to the hypothesis of our study, that is the congruent arc letter J procedure in off-track lesions of shoulder with recurrent anterior shoulder instability yields good functional outcome. And this is the objective of the study as well, to evaluate the functional outcome of the procedure. So methodology is it is a retrospective study done at the Liaquat National Hospital, Karachi. The sample size is 25 patients. Follow-up was between post-operative 1 month, 6 months, 12 months and 24 months. The inclusion criteria was recurrent anterior shoulder instability, glenoid bone loss exceeding 20% and an off-track lesion, and the patients who are available for 2-year follow-up. The exclusion criteria were if the patient had any concomitant procedure, if the Hill-Sachs lesions were large, or it required any soft tissue procedure to fill in the gap, posterior or multi-directional instability, previous shoulder surgery of involved shoulder, neurological injury in the limb involved, and a Bayern score of greater than 6. So the bipolar bone loss and on-track and off-track lesions were calculated on MRI films using the best fit circle method. This is a good article that described the calculation of the off-track lesion with the help of MRI, as most of the bone loss is calculated onto the 3D CT scans, but this article is very good and states that it can also be calculated onto the MRI films. So the outcome measures were VAS ranging from 0 to 10, ROE score which involves shoulder function, pain, shoulder instability, and shoulder range of motion. So the it has been categorized into excellent, good, fair, and poor. So range of motion was recorded and compared with the normal shoulder. Statistical analysis was done with IBM SPSS version 25. Paired sample t-test was used. P-value less than 0.05 was considered significant. This is how the surgical procedure is done. Basically, the approach is sorry.
2 minutes are left.
The approach is same position is the beach chair position, and the patient the incision is the deltopectoral incision, and the identification of the coracoid is done initially. Then the preservation of coracoacromial ligament stump is basically performed, and then there is release of pectoralis minor tendon from the medial coracoid, and the osteotomy, coracoid osteotomy from the base is done from medial to lateral side, and that is shifted along with the conjoint tendon through the horizontal split in the subscap in upper 2/3, lower 1/3 junction, and transferred onto the glenoid, anterior inferior part of the glenoid, where there is the bone loss, and that coracoid is rotated on its long axis to 90 degrees to achieve the congruent arc in this case. So this is these are the pictures of the patient MRI picture, which shows Hill-Sachs lesion, and the intraoperative image taken in which the coracoid graft is fixed with 3.5 mm cannulated screws onto anterior inferior glenoid, and the third one is the post-operative radiograph. So the rehab is done. For patients were always kept in sling for 6 weeks following surgery. Then the passive range of motion PROM was started, and after 6 to 12 weeks the active range of motion was started. Patients were allowed to return to all activities at 6 months post-operatively after the union was confirmed at the plain X-rays. In results, there were 25 patients. All were male. The average age was 29.1. The VAS score improved from 7.4 to 1.4 at the 2-year follow-up. The RO score improved from 20.8 to 95.5, which comes under the excellent outcome. The range of motion over the 2 years period improved from the forward flexion improved from 72 degrees to 160 degrees, and the external rotation improved from 9.6 degrees to 45.1 degrees. So with the p-value of less than 0.05, the RO score shows that in initial phase, in the pre-op phase and the initial 1 month, it was there were 25 patients who are lying onto the poor side, but following the patient up to 2 years follow-up, all the patients achieved very good functional outcome. So these are the intraoperative pictures which show the well-fixed coracoid graft with 2 cannulated screws. This is another patient, and these are the results. There is very less loss of external rotation at the left shoulder after the surgery, which is very insignificant. The complications were one patient had surgical site infection which got resolved with antibiotics and regular dressing. One patient reported apprehension initially in the rehab phase, but eventually when the rehab was slowed down, it went away. So the latter J basically benefits having 3 points that are increased glenoid surface area, and there is reinforcement of anterior capsule by the help of sling effect from the conjoint tendon that is passing through the subscap. And when you go into the range external rotation movement, this sling effect comes into play. And there is a restoration of the bumper effect of the glenoid labrum as well. And the congruent arc modification in our case basically achieves the normal classic lateral J restores 29 to 36% of the glenoid surface area, while in congruent arc modification it restores up to 53% of the glenoid. So technically it converts an off-track lesion into on-track lesion in case if there is a small to medium hill sac defect. So the congruent arc lateral J procedure is an effective technique for treatment of recurrent shoulder instability with off-track lesion, as it produces excellent outcome in restoring shoulder function, range of motion, stability. More studies are needed with longer period of follow-ups to study the osteoarthritic changes. As well, the limitations of our study are small sample size. It's a single center study. It's a retrospective one. There is no head-to-head comparison, and our population did not have professional athletes, and post-operative CT scan findings were not included in our study because we do only X-rays in post-operative. We don't have any conflict of interest, and there is no grant and funding associated. Thank you.
Thank you, Noman. So, any burning questions, comments?
उन्होंने कहा कि सी में ले चलो तो उनके कोई जहाज गिर गए थे, उन्होंने कहा एक्सटेंड द प्लेटफॉर्म, फिर भी गिरने लगे, उन्होंने कहा रेज इट अप. So that is what you mean by congruency and raise extension, that your raise is through what? The coracoid and is attached slings. How do you raise it? How you make it congruent?
Sir, the undersurface of the coracoid basically is more concave. So when you rotate the coracoid onto its long axis, 90 degree onto its long axis, the undersurface comes into play with the, gets flushed with the glenoid. So it becomes a congruent one.
The congruent means you are more containment on the anterior side,
Right.
because of that particular hook of that coracoid.
Exactly.
That is the congruency.
Right.
That's good.
I was
This non-congruent one, letter J, I've never done that would be our usual way to do it, the congruent arc. That was otherwise it was an excellent composition of the research. Few things that your external range of motion was excellent. We have a recent paper published in American Journal of Arthroscopy. Patient with recurrent instability, they have external rotation leg even pre-op, because they, to get to that external rotation area where they start dislocating, subconsciously they avoid that range of movement. So they are limited pre-op even with external rotation. That was our study recently published there in that American Journal of Arthroscopy. Yes, so that was excellent that you have got even normal external rotation range of movement, which was surprising. And then the whole idea of the on-track and off-track, it is coming under a huge amount of kind of, I won't say criticism, but critical analysis. If you are examining your off-track and on-track lesion, you are moving the shoulder, how it is possible in that setup. How the person is moving when he is dislocating the shoulder, it is completely different than that. So only deciding on an off-track and on-track, I would say I don't do it. My, indication for letter J are kind of a little bit more than only looking at the MRI or CT scan. I would do letter J in someone with recurrent dislocation, glenoid bone loss, and glenoid inversion, and obviously the patient, if patient is hyperlex, if the patient is Hagel lesion, I will do for letter J. And the other you mentioned, adding remplissage, that is a very technical thing, and to be honest, I was thinking that it's only us doing it because we have done only 10 cases, because you're doing remplissage arthroscopically, and you have to follow it up by a letter J, and sometimes you have to struggle. And if you take more than 10 minutes, you are working on a ballooned out shoulder, and it's technically very difficult. But yes, a huge hill sec, I would do a remplissage arthroscopically as quick as I can, and then I will do a letter J.
Sir, do you have a threshold for the bone loss? First of all, do you categorize the bone loss into any?
I do purely on size.
Okay.
What is the size of the bone loss? Not to be, specifically going for the off-track and on-track, and more than my clinical judgment if the patient is dislocating its shoulder 10 times. If I see there is, the patient is hyperlex, if I see a Hagel lesion, those would be my indication for, letter J. And obviously, I will discuss some people who would be in the gray zone. I will discuss them the option that if you are doing arthroscopic Bankart repair, you have another option down the line if they kind of come up with recurrent instability. The other thing is, I wonder why do you use this cancellous? The cannulated screw. Do you use a
Y-wire, yeah.
Okay. I don't use a cannulated screw because of the strength. I've seen quite significant bending of my screws in epileptic patient. They were bending even the non-cannulated screws. They dislocate sometimes their shoulder even within the first few months. So I don't use the cannulated screw. But that was like a bit interesting for me that you're using the cannulated screw.
Sir, yes, I agree. In epileptic patient, the story is altogether different.
Well, we have just stopped using cannulated screw. There is no added advantage of using the cannulated screw. I don't know, what would be the other people thinking about it.
Yes, I think very pertinent points highlighted by Dr. Sami, and it's a wonderful talk, Numan, which you have presented. I was just wondering because one of the complications of letter J you mentioned, which is infection, which you had in one patient and it was handled very well. Another problem in these patients is that this bone which you are putting in there, it tends not to unite. That means non-union is another complication which is there in
with the letter J. And I was just wondering that how can X-ray tell us the non-union, because that is the purpose of following these patients with the. Otherwise, you don't need an X-ray. What are you looking for on an X-ray, which is an AP view? Your screws are going to be there, which are there on the first X-ray, which you did, which you can take it for the patient satisfaction, but it will not add any value to you as a follow-up of such patients. So what you need an X-ray, if you need an X-ray, is an axial view so that you can see the interior glenoid from top, a striker notch view or west point view, so that you can see where you want to see where your coracoid is sitting. And the best way to follow in these patients, if you are looking for a non-union, is with a CT scan that you do at the roughly around 3 months' time, once you think that your bone must have united by now. Otherwise, the letter J works wonder. It has various ways by which it is effective. Some of them are proven, some of them are not proven. I was just wondering, how do you add the bumper effect with the letter J? Because you are taking all the labrum. Clarify a bit more, how are you reversing your coracoid that you bring from the cut surface, you plug it in, or you just
flush with the if
does reduce the strength of the screws, there is no doubt about that. It's just the ease of access that you hold your
No, I support you, don't worry. I use cannulated screw, yes, but I use 3 cannulated screws, right, and long one, and these work very well, क्योंकि ये दोनों तरफ से contract करता है. So my experience with the cannulated screw is excellent, and they work very excellent. But the indications of letter J now, it has been reduced now. If the pathology is on glenoid side, then it is fine. If the pathology is on humeral side, then probably you will have to choose another procedure. आपने जो हमें एक्सरेज दिखाए हैं उसमें हमें ग्लीनाइड साइड पे कोई पैथोलॉजी नज़र नहीं आई. Pathology is on humeral side. So the indication with the passage of time of these letter J, these are getting down and down, and probably the things are going more towards anatomical side. So the simple principle is that bony defect more than 25% on glenoid side go for letter J, and the defect and deficiency is on humeral side, then you will have to choose some other procedure like remplissage like that.
So, sir, there are articles that state divide the humeral-sided defects into different categories like mild, moderate, and severe. So, if you have less than 20% bone loss onto the humeral side, you can get away with not doing any procedure. If the bone loss on the humeral side is between 20 to 40%, then that is the gray area. You can increase the bony surface onto the glenoid, and the humeral defect won't actually engage with that defect. But if the loss is more than 40%, then definitely you'll have to do something about the humeral side defect. So these are the latest
I agree, but how will you evaluate that
Sir,
it is percentage of the bone loss?
onto the of course the CT scan is very good. The best modality is the CT scan, but we do only single study, that is the MRI. So
Yes, I mean bone loss you can gauge on CT preferably, because that is proven that it is more easy to pick the bone on the CTs, and MRI is lately coming up additionally as well, that you as well. The concept of off track and on track and checking whether it is engaging or not engaging, you can't do it pre-operatively in the clinic, because you're putting that shoulder into risk of dislocation, and that's not a pleasant experience for you as a surgeon sitting in the clinic, and not for the patient, not for the onlookers as well. So that is what you do once you are doing your scope. You have put in your scope, you have seen the defect on or findings on the anterior side of the glenoid, and now you are seeing where your Hill Sachs defect is, and then you try to move the arm in the abduction and external rotation and elevation, and see how far your humeral head Hill Sachs defect is trying to engage. So if it is reaching and dislocating interiorly, it means that it is definitely going on track and coming out of the socket easily.
So 100% agree. So this on-track, off-track concept gives you some insight preoperatively to where you are to plan accordingly. But obviously you decide, or I decide peroperatively whether they're engaging or not engaging. So.
You may modify your some things when you are operating, that this is on track, this is off track, the Hill Sachs is looking this much, it was looking this much, it is 30%, it's 25%. If you have done this homework pre-operatively at home many a times, then you are much more precise for execution of the plan. If there is a defect, 30% of the glenoid, there is a 20% of the humeral head. To combine, it is a 50%. The both should be a combined consideration. Exactly. If you're going for the remplissage, if there is again a 30% defect and more than 30% on the glenoid side, you have to reconstruct that particular with the letter J. That is how you combine the both. It's not the simple on the anterior or glenoid, or it's a combination. Yeah. The pre-operative, I think, homework is more important than to the execution. And the CT with 3D reconstruction may be better option.
Yeah, I mean, now MRI is probably replacing this even CT.
For the particular bone defects. I'm talking about the bone defect.
I agree with Sir Abu Bakr that
I agree with the bone
CT with
defect.
3D reconstruction is a very valuable.
I am going for the bone defect. Yes, for the other tissues, you may combine it with the CTs.
No, I mean, practically, to reduce the cost of the patient, we do try to determine bone defect even from MRI as well. Practically, I mean, I know CT is bad. And now, in latest technology, they are also they are somehow giving this CT sequence with the MRI as well.
Exactly. So moving on with the industry, and we will move on.
So we are short of time, so I think we conclude the session. This was the last presentation. So maybe few shields are left if we want to, if we give the esteemed guests can come on the stage, Professor Abu Bakr Saab, Professor Khalid Saab, and Dr. Nadeem Saab. So एक दो शील्ड आखिर रहती हैं वो दे दे मेरे ख्याल में. Ajay sir. So, so first would be Dr. Osama bin Said. So, Ajay sir, आप तीनों Ajay sir. Shield, Dr. Osama. हाँ ओपन थोड़ी होगी. Khalid Shah, so you were part of the panel, Abajan. So second would be Dr. Sanaullah, I think, chale gaye. So Dr. Sanaullah, I think, chale gaye. So then it's my turn, Dr. Naveed. So. Dr. Noman Malik. So. Do you have shield for panelists के लिए भी थी या सिर्फ speakers के लिए हैं? So Dr. Khalid Mahmood के लिए है प्रोफेसर से. So Professor Masood Umar साहब तो नहीं है. Professor Faisal Masood. Then I think we are done. So thank you very much. Thank you. So this concludes the fifth arthroscopy session. I think also concludes the Orthocon proceedings. So, मेरी डॉक्टर नवीद के नाम से होगी. वो नहीं है डॉक्टर नवीद के नाम.